Good morning, everyone, and welcome back to the International Journal of Medical Students World Conference of Medical Student Research 2026. I am Justin Nathan Federigan, a fifth-year medical student at the Tongji Medical College, Huazhong University of Science and Technology, Wuhan, China. It is an honor to be serving as the Masters of Ceremony for this year's conference. We have heard nearly 50 amazing presentations from medical students yesterday, studies from Georgia, Sudan, Bangladesh, and all parts of the world, each sharing research driven by passion, curiosity, and a commitment to advancing medical science. And it was truly an honor to witness a myriad of ideas and the global spirit of collaboration that drives our medical community today. We will be seeing another set of oral and poster presentations. And at the conclusion of today's program, we will also be announcing our awards to celebrate each contributor's hard work and dedication, not only in this conference, but in the world of scientific research. But before we begin, I would like to remind all our presenters that this is your time to shine. When it's your turn to present, turn on your mic, cameras to share your research on this global stage. You will be sharing your screen, so you have to have your slides ready or even your posters ready. And for our judges, please ask a question for each presentation and consider the thoughtful responses that you are about to see from the presenters. Audience, please vote for your favorite presentation by scanning the QR code every after presentation. All right, let's finally start our last day together. For now, let's first welcome the first presenter for this morning, which is Raghda Babikar from Al-Azhar University Faculty of Medicine for Girls, Cardio-EG, and he'll be presenting knowledge, acceptance, and hesitancy towards malaria vaccination among healthcare providers in conflict-affected Sudan, a cross-sectional study. Welcome to join us, Raghda. Are you able to prepare your presentation?
Can someone please share my presentation for me?
All right, let's try to have the tech team present for us. And for this session, we'll also have Dr. Imad as our judge. Dr. Imad?
Hi,
Welcome to
hi
join
Nathan.
us.
Thank you so much.
Yeah, okay.
Wishing you best of presentation, Raghda.
Thank you.
Okay, this is Raghda Mubarak, a third-year medical student at Al-Azhar University, Faculty of Medicine for Girls, and also a member of the Students' Association of Medical Education and Research, SAMR. I am here to present our research titled Knowledge, Acceptance, and Hesitancy Toward Malaria Vaccination Among Healthcare Providers in Conflict-Affected Sudan, a cross-sectional study. Introducing our study, malaria remains a major public health burden in Sudan, particularly in conflict-affected regions where healthcare services and health communication systems have been severely disrupted. In October 2024, Sudan received its initial consignment of 186,000 doses of the malaria vaccine. The initial phase targeted about 148,000 infants, marking Sudan the first country in the Eastern Mediterranean region to introduce the malaria vaccination. This study aims to assess knowledge, acceptance, and hesitancy of the malaria vaccination in Sudan. Moving to our methods, this study employed descriptive cross-sectional study conducted between January and February 2024 at Al-Gadarif and Damazin Teaching Hospitals, which are located at Al-Gadarif and the Blue Nile states, respectively. Eligible participants of our study were house officers and medical officers, which gave informed consent to participate in this study, and which are employers at the time of the study. Our data collection tool assessed the socio-demographic factors, the knowledge sources, and the information sources the acceptability, hesitancy, and the concerns regarding the malaria vaccination. Data analysis were done using IBM SPSS version 28. Descriptive analysis was done to the socio-demographic factors. Bivariate analysis was done to check the independent to check the factors. Multivariate logistic regression was used to identify the predictors of the vaccine acceptability. Informed consent was obtained from the Ministry of Health at the Blue Nile State. Moving to our results, as you can see in the first paragraph, the participants were predominantly young, almost single, and the majority were house officers. Interestingly, while overall vaccine acceptance was encouragingly high at 56.7%, only about 35.1% of the participants demonstrated good baseline knowledge. Their primary concerns was about the adverse effects regarding the vaccine storage and handling conditions in Sudan, and uncertainty regarding the vaccine effectiveness. Moving to the table on the slide, the table demonstrates that the knowledge was the only predictor of the vaccine acceptability, and the figure shows that the major sources of informations were the social media and the healthcare peers. Concluding our research findings, we found that knowledge is the only predictor of the vaccine acceptability, and the concerns regarding the vaccine were not theoretical only. It depends on other factors like concerns regarding the effectiveness of the vaccine and concerns regarding the storage of the vaccine in Sudan. Our recommendations that we encourage the healthcare providers and the researchers to include more healthcare cadres. Future research should encompass broader geographic regions and diverse healthcare cadres to monitor longitudinal trends in vaccine confidence as the immunization program expands. Also, we recommend that health authorities must pivot from generalized promotional campaigns to targeted educational modules that address specific clinical protocols and safety profiles. Also, given the severe disruption of formal institutional channels due to ongoing conflict, leveraging secure digital professional network is essential to rapidly build provider confidence, which remains a fundamental prerequisite for broader community uptake. Ending my presentation, I would like to acknowledge and thank the Students Association of Medical Education and Research, SAMIR, and Khartoum Medical Students Association, KAMSA, for their valuable efforts and support throughout the phases of this study.
All right, thank you so much for that wonderful presentation. Now we'll be calling on our judges to provide their questions and suggestions on the research. Hello, Dr. Imad.
All right. Thank you so much for this presentation, Raghda. It's a thoughtful study, especially on malaria vaccination in Sudan as the first country in Africa that has received this. I have a few questions, if I may. First one is why healthcare providers, not the patients, receiving the vaccine and their acceptance of this vaccine or not? Regarding the sample size, I believe it's a good sample size, but we would love to know about the power analysis. And also, how did you develop your questionnaire? How did you validate the study tool? And also, how did you make sure that it's reliable? It wasn't mentioned in your methodology that you have piloted or you have done something like so. If it was missed, furthermore, my last questions would be, what do you think one single target intervention can improve the vaccine acceptability? And why do you think there is a gap in knowledge in the healthcare providers? Thank you so much. And also,
Thank you so much.
I would like also to thank um, one point that was mentioned in the study, which is the concerns of healthcare providers regarding the handling of vaccines. I believe that this is a rational and reasonable concern. Um, yeah, thank you, Nathan.
All right, thank you so much for that. And it is very important that we have great validation on our research. All right, so now we will be going on to the code. Thank you again, Dr. Imad and Raghda, for that wonderful presentation. Right, here is the code. And we would like to remind everyone once again to please scan the code and choose your most preferred or to vote for your most preferred presentation. And as for our judges, please use this time to submit your judging response form. And all our votes will help determine the awards that we'll be announcing just before the closing ceremonies today. All right. So now we will be going on to our next presenter, which will be from, let me see. Our next presenter is Filip Kapor, a fifth-year medical student, University of Novi Sad, Faculty of Medicine, Sebra, sorry, rather. And the title is on identifying high-risk groups of pathological gambling, evaluation of socio-demographic markers for future predictive modeling. So that's all welcome our presenter. And for this session, we'll also have Dr. Imad again for our judge.
Good afternoon, distinguished members of the committee and colleagues. The topic of my presentation is identifying high-risk groups for pathological gambling, evaluation of socio-demographic markers for future predictive modeling. My name is Filip and I'm fifth-year medical student interested on brain behavior and mental health. Also coffee lover and lifelong learner. In the last few decades, gambling has shifted from a common social activity to a recognized mental health disorder. This is reflected in its potential. So the now place it within research shows that the gambling activity is the same dopamine reward pathways in the brain, especially in regions involved in decision making, such as the prefrontal cortex. This can create a false sense of control and provide a temporary escape from stress or emotional distress. The main aim of this study was to evaluate the link between socio-demographic characteristics and pathological gambling, and to identify factors that could be useful for future predictive models. We conducted a retrospective study at the Clinic for Psychiatry of the University Clinical Center of Vojvodina, covering a 6-year period. The initial search identified 282 patients diagnosed with F63. After removing duplicate and incomplete records, the final sample included 101 patients. Data were collected using models from the Pompidou questionnaire, and statistical analysis was performed using JASP. Who is our average patient? The data shows a strong gender imbalance, with males making up over 96% of the sample. The mean age is around 37 years. These are typically individuals with secondary education, working in manual labor or service jobs, reporting average socioeconomic status, and living in urban areas. When we look at gambling patterns, we see a clear preference for fast-paced games, with rapid outcomes. Sports and live betting are the most common at 48%, followed by roulette at 23%. A particularly important finding is the duration of the disorder. Most patients report gambling for 3 to 10 years and over 20% for more than a decade. This suggests that individuals usually enter treatment at a chronic stage when the disorder is already deeply embedded in their social and financial lives. We found a clear positive relationship between age and duration of gambling problem. Older participants tended to report a longer gambling history. We also found significant differences in gambling duration across age groups, but the effect size was relatively small. We now come to the most severe psychological consequences and the key findings of our study, which is a very high rate of suicidality. Nearly 42% of patients in our sample reported suicidal ideation or previous suicide attempts. Financial debt was present in over 62% of cases. Analysis shows an important finding. In our cohort, suicide attempts occurred only among patients who had financial debt. This association was statistically significant, confirmed by Fisher's exact test with a p-value of 0.02. Importantly, the odds ratio showed that the risk of suicide attempt was 14 times higher in patients with financial debt. We also found that suicidal patients were on average older. In older patients, suicidality seems to be individuals. It is more often an impulsive reaction. The next finding, suicidal patients were on average older. In older patients, suicidality seems to be linked to long-term accumulation of losses, while in younger individuals, it is more often an impulsive reaction to acute financial stress. The next finding shows an interesting and somewhat unexpected finding, which we can call the living arrangement paradox. All 20 relapse cases in our sample occurred in patients living in a shared household with family members. In contrast, no relapses were recorded among patients living independently. This patterns was statistically significant, confirmed by Fisher exact test. The odds ratio suggests that independent living is associated with a 20-fold lower risk of relapse. Although family is usually considered a protective factor in addiction, this finding can be explained through the concept of high expressed emotion. In some cases, a dysfunctional family environment marked by criticism, tension, and financial blame becomes a strong stressor. The pressure may trigger the well-known chasing losses behavior, where patients return to gambling in an attempt to resolve family financial problems. In conclusion, what do these findings mean for future predictive modeling? They show that the socio-demographic markers such as debt, status, and living arrangements have strong prognostic value, not just descriptive relevance. By integrating these variables into clinical databases, we could develop automated screening tools capable of identifying high-risk patterns for suicide or relapse in real time, allowing earlier and more targeted preventive interventions. Of course, this study has limitations. It is retrospective, single-center, and does not include a healthy control group. It also has strong gender imbalance, and for future research should focus on prospective longitudinal designs and include standardized psychometric instruments to better capture family dynamics over time. Thank you for your attention, and I'm now open to any questions.
Thank you once again for the presentation, presenter. We will now have Dr. Imad as our judge. Since it was a pre-recorded video, we would just take note the questions on this recording.
Thanks, Nathan. This is a very thoughtful study addressing the pathological gambling along with socio-economic factors. I have a few questions. First, how did the authors identify the pathological gambling? Second, what were the inclusion and exclusion criteria for the study? I believe that this is a retrospective study for a period of time, but also like they consider the socioeconomic factors purely, or did they consider some sort of designs? That's good to address. Uh, yeah, that would be my questions. And also, the presenter overstated the link and relationships, the associations, let's say. Did they use logistic regression or only Fisher exact test? I believe that I've seen the odds ratio only one time, but this could be also have a chance for a second thought. Thank you so much.
Well noted. Thank you so much, Dr. Imad. We will have that noted. Next, we'll be calling on our next presenter, and that will be Ummey, Arshiya, College of Medicine, University of Perpetual Health System Delta from the Philippines. And the recording will be on biomarkers in the battle against sepsis. Does procalcitonin lead the way? And for this session, we'll again be having Dr. Imad with Dr. Adarsh Karshi as our judges.
Good morning, respected judges, faculty members, and fellow participants. My name is Ummey Arshiya, and I am an MBBS graduate from the University of. Today, the battle against sepsis, does procalcitonin lead the way? This study compares the diagnostic and prognostic performance of procalcitonin, or PCT, and C-reactive protein, or CRP, in predicting the severity of sepsis. Before discussing our study, I'd like to briefly explain why this topic is important. Sepsis is a life-threatening condition that occurs when the body's response to infection becomes dysregulated, 48.9, making it one of the leading causes of mortality worldwide. One of the greatest challenges clinicians face is identifying sepsis early and determining which patients are at risk of developing the disease. Among the biomarkers currently available, procalcitonin and C-reactive protein are the most commonly used. The better reflects disease severity and has greater diagnostic accuracy. Therefore, the objective of our study was to compare the diagnostic and prognostic performance of procalcitonin and C-reactive protein in predicting the severity of sepsis. As shown in the diagram, infection progresses to sepsis and then organ dysfunction, highlighting the need for accurate early biomarkers. Methodology. We performed IJMS guidelines. A comprehensive literature search was conducted using 3 major databases: PubMed, Scopus, and the Cochrane Library. We included studies published between January 2016 and March 2026. Our inclusion criteria consisted of adult patients with sepsis enrolled in observation diagnostic accuracy studies. We excluded pediatric studies, animal studies, case reports, reviews, editorials, and non-English publications. To reduce, we performed by 2 reviewers. Finally, pooled outcomes were analyzed using a random effects model with 95% confidence intervals, while heterogeneity among studies was evaluated using the I-squared statistic. Now, moving on to the results, our analysis consistently demonstrated that procalcitonin outperformed C-reactive protein in evaluating sepsis severity. First, procalcitonin showed a pooled sensitivity ranging from 80 to 87%, whereas CRP demonstrated a lower sensitivity
coefficient of 0.479 with a p-value less than 0.001. Although moderate heterogeneity was observed among the included participants, its use may also improve risk stratification, guide timely initiation of antibiotic therapy, and support better clinical decision making. Ultimately, earlier intervention has the potential to improve patient outcomes and reduce sepsis related mortality. In conclusion, our systematic review and meta analysis demonstrates that procalcitonin is superior to C reactive protein in predicting the severity of sepsis. Compared with CRP, procalcitonin showed higher sensitivity, greater diagnostic accuracy, and a stronger correlation with bloodstream infection, organ dysfunction, and increasing SOFA scores. Based on these findings, procalcitonin should be considered a valuable biomarker for the early diagnosis, prognostic assessment, and clinical management.
All right, it seems that that was the end of the presentation earlier. We would want to invite again Dr. Imad to help us out on the judging. And Dr. Adarsh. Yep,
Hi,
all right.
am I audible?
Hi, both. Hello, both. Yes, you are audible.
Uh,
So-
Dr. Adrash, you may go.
Yeah. So thank you, Nathan. It was a good study, to be very honest, but the correct methodology was not appearing. For example, was it a systematic review or a narrative review or a meta-analysis done? And second question, if considering it was a review, how was the quality of assessment and the bias of risk of the studies being done? These are my two questions. Thank you.
Well noted. Thank you, Dr. Adarsh. Do you have anything to add, Dr. Imad?
Uh, thank you so much for the presentation. I didn't follow because there was no audio basically, so I reviewed the slides.
Hmm.
Do you suggest the procalcitonin should be always used in suspected sepsis, or what do you think in relation in terms of CRP, considering also the socioeconomic factors, the poverty or the patient's baseline information? This can be addressed in the study. Uh, yeah, that's it. Thank you so much.
Thank you so much again. Okay. For both, and as well as the presenter for giving a wonderful presentation. A poster presentation by Khadija Kahil, Faculty of Medicine, University of Khartoum, Sudan. And that will be discussing on the barriers to accessing diabetes medication during the Sudan conflict, a cross-sectional study. And for this, we would still want to invite Dr. Adarsh and Dr. Imad as our judges for this session.
Good morning, everyone. I am Khadija Ala Khalil Ali, MBBS holder, Faculty of Medicine, University of Khartoum. I am presenting our cross-sectional study entitled Barriers to Accessing Diabetes Medications During the Sudan Conflict. Starting by the background, diabetes mellitus is a chronic metabolic disease that requires continuous access to medications to maintain glycemic control and prevent serious complications. During armed conflicts, healthcare systems are often severely disrupted due to damage to health facilities, interruption of medication supply chains, displacement of populations, and worsening economic conditions. Since the outbreak of the armed conflict in Sudan in April 2023, there has been limited evidence on how the conflict has specifically affected diabetic patients. Therefore, our study aimed to assess the challenges faced by diabetic patients in accessing their medications during the 2024 armed conflict in Sudan. Moving to the methodology, we conducted a descriptive community-based cross-sectional study between April and August 2024. It has been conducted among adults diagnosed with either type 1 or type 2 diabetes living in conflict-affected areas of Sudan. Data were collected using a structured Arabic questionnaire that was mainly distributed online through social media platforms. The questionnaire consisted of 3 sections, covering participants' socio-demographic characteristics, their general health status, and the impact of the conflict on their access to diabetic medications. Initially, our calculated sample size was 384 participants. However, due to the challenges of conducting research during an ongoing conflict, we obtained responses from 314 participants. Data were analyzed using our software. Moving to the results section, regarding our participant characteristics, a total of 314 diabetic patients participated in the study. Their mean age was 53 years and 55% were female. Approximately 66% had type 2 diabetes, while 34% had type 1 diabetes. Nearly half of the participants, 47%, reported at least one diabetes-related complication, with diabetic neuropathy being the most commonly reported complication. Moving to the impact of the conflict, our findings demonstrated that the armed conflict had a profound effect on diabetes care. 84% of participants reported that the conflict negatively affected their ability to access diabetes medications, while 82% stated that it negatively affected their overall health. In addition, 91% believed that the ongoing conflict was the main reason for medication inaccessibility. Regarding medication supply, 76% experienced intermittent interruptions, while 17% reported permanent disruptions, indicating that a very small proportion maintained uninterrupted access throughout the conflict. When talking about the barriers to medication access, injectable medications, particularly insulin, were the most difficult medication to obtain, followed by oral hypoglycemic agents. The most commonly reported barriers were the unavailability of medications in pharmacies, followed by financial constraints. As a consequence of these challenges, 62% of participants reported relying on alternative remedies. When asked about potential solutions, participants most frequently requested more affordable medications and improving medication availability. Discussion. Overall, our findings clearly demonstrate that the Sudan armed conflict has had a substantial impact on access to essential diabetes medications. The widespread medication shortages and interruptions in treatment place diabetic patients at increased risk of poor glycemic control and long-term complications. Our findings are consistent with previous studies conducted in other conflict settings, including Gaza and Iraq, where destruction of healthcare infrastructure, population displacement, and financial hardship similarly reduced access to diabetes care. One particularly concerning finding was the difficulty in accessing insulin, which requires continuous availability and proper cold chain storage. Frequent electricity power cut during the conflict further increase the risk of insulin becoming ineffective. The high proportion of patients relying on alternative remedies also highlights the desperate measures many patients were forced to adopt because prescribed treatment were unavailable. In conclusion, the armed conflict in Sudan has significantly disrupted access to diabetes medications. Medication shortages, pharmacy closures, and financial barriers were the main obstacles identified by our participants. These findings emphasize the urgent need for coordinated efforts by governments, humanitarian organizations, and healthcare providers to ensure uninterrupted access to essential medications for patients with chronic diseases during humanitarian emergencies. Thank you for your attention. I would be happy to answer any questions.
Thank you once again for that wonderful presentation. Now we would like to have the judges on stage with us. Dr. Adarsh.
Thank you for the wonderful presentation. My only question to you is that were there any potential confounders that you have appear to have in your study or no? Other than that, the study seems to have a significant impact also, and it's a well curated study. So congratulations on that. Thank you so much.
Thank you for those suggestions at Dr. Adarsh. Now we will be moving on to the code, and we would want to invite all the judges as well to use the form that was given to you. For our audiences, please do scan the code and vote for your most preferred presentation. Moving forward, we would want to have Martin Rodriguez Alvarado from the Instituto Politécnico Nacional Ciudad de Mexico, Mexico, on the meta-analysis on the use of artificial intelligence for anatomical identification of pelvic autonomic nerves in laparoscopic and robotic colorectal surgery. Welcome, Martin. And for this session, we'll still have Dr. Adarsh and Dr. Imad as our judges.
Good morning, judges, professors, and colleagues. My name is Jimena Cueto, and I am a third-year medical student at the National Polytechnic Institute in Mexico City. And today I am pleased to present our research. The title of our study is Meta-analysis on the use of artificial intelligence for anatomical identification of pelvic autonomic nerves in laparoscopic and robotic colorectal surgery. In this study, we evaluated the current evidence regarding the use of AI as an interpretive support tool for identifying pelvic autonomic nerves during minimally invasive colorectal surgery. Colorectal surgery is the identification and preservation of pelvic autonomic nerves. These nerves are anatomically complex, relatively small, and located deep within the pelvis, making them difficult to identify during laparoscopic and robotic procedures. Failure to preserve these structures may result in postoperative urinary and sexual dysfunction, significantly affecting patients' quality of life. To overcome these challenges, AI has emerged as a promising technological tool. AI systems can analyze the surgical field in real time, providing anatomical recognition, interpretive guidance, and improved visualization of critical structures, which may enhance surgical precision and patient safety. However, despite the growing interest in this technology, current evidence remains limited and heterogeneous. Therefore, artificial intelligence, pelvic nerves, colorectal surgery, laparoscopy, and robotic surgery. The search focused on studying surgery, in which AI was specifically used for pelvic autonomic nerve identification. We included review articles, editorials, studies unrelated to colorectal surgery, and These figures summarize our study selection process. After the initial search, duplicate records were removed. Now let's move on to the main findings of our meta-analysis. The first plot summarizes the pooled anatomical recognition rates reported across all studies included in the quantitative analysis. Overall, AI achieved a pooled anatomical recognition rate of 69.1%, with a 95% confidence interval ranging from 44.7% to 86%. These findings, however, we also observed high heterogeneity indicates considerable variability among the included studies. Such variability was expected because these studies, including the AI algorithms used, surgical approaches, image datasets, and outcome definitions. Overall, these results suggest that AI intelligence showed the highest performance lumbar splenic nerves, achieving a pooled recognition rate of 89.8%. Recognition was moderate for hypogastric nerves at 62.7% and considerably lower for pelvic visceral nerves, consistent anatomical course, and are surrounded by clearer anatomical landmarks, making them easier for AI system to recognize. In contrast, pelvic visceral nerves present greater anatomical variability, are thinner, and are frequently obscured by surrounding tissues during minimally invasive surgery, making automated identification considerably more challenging. These subgroup findings also help explain the high heterogeneity observed in the overall analysis and suggest that AI performance depends not only in the algorithm itself, but also on the anatomical complexity of the target structure. These findings have several important clinical implications. First, AI may improve surgical decision-making by helping surgeons identify critical anatomical landmarks and perform safer dissections. Second, more accurate nerve recognition could reduce inadvertent nerve injury and consequently decrease postoperative urinary and sexual dysfunction. Third, AI may help facility, however, an important limitation remains. Most available studies evaluate only technical outcomes, such as recognition accuracy and segmentation performance, while very few assess clinical meaningful endpoints, including long-term urinary function, sexual function, postoperative complications, or quality of life. Therefore, although active studies are artificial intelligence may have a broader clinical impact in colorectal surgery. AI has already demonstrated clear benefits in colonoscopy by improving adenoma detection, particularly for small and serrated lesions. Similarly, deep learning models applied to laparoscopic and robotic colorectal surgery have reported recognition accuracies ranging from 70% to 90%, supporting the identification of critical anatomical structures during surgery. Together, these findings reinforce the potential of AI as an interpretive support tool, while highlighting the need for prospective studies evaluating long-term patient outcomes. Evidence remains preliminary, highly heterogeneous and primarily based on small observational studies. Future research, larger multicentric comparative studies, standardized methodologies, and the evaluation of long-term functional outcomes to determine whether improved anatomical
We are having great technical difficulties, but we would want to welcome Jimena to take the questions instead of Martin. So we'll be welcoming again our judges. But before that, maybe Jimena, you could discuss or give a general idea of the study once again to give the judges an idea.
Okay. Yeah. Well, my in resume, our study was a meta-analysis about the identification with the help of AI of pelvic autonomic nerves, and we found among a lot of small studies that it is, in conclusion, a good tool for identification of principally subplastic nerves, and it also remains limited about the information we have, and we need more studies to understand the potential, the complete potential of AI implementation in laparoscopy and colonoscopy, colorectal surgery. That's like the main idea of the whole presentation.
Well, thanks, Jimena, for the presentation. This is a very interesting study. Having good prisma, having good search methodology. However, I have one question, which is about the high heterogeneity reported in the study. What do you think the factors contributed to this high heterogeneity? And also, my other questions would be, do you think, based on this study, while you reported extensively the limitation, but do you think that AI is ready to replace the human clinical examinations and recognition of the autonomic nerves in the pelvic? Thank you.
Thank you for your question. Well, first, I think that the cause of this high heterogeneity was the amount of studies that we looked for, that we used. There's still not a long field of studies, particularly for this topic. So we knew that this was going to be like this kind of limitation, but that's why the heterogeneity was so high. So we expect in the future to be larger studies and to have more studies about it, so we understand more specifically and particularly about this topic. And can you tell me the second question again, please?
What do you think that AI is ready to replace the clinical examinations, the human based practice and recognition of the autonomic nerves in the pelvic?
Okay, no, I really
Like
don't think...
we assume that the authors have summarized and have analyzed 8 studies out of a number of studies. So we would love to know your elaborations on this. And also, was there any risk of bias assessment in the study?
Well, thank you again. First, I don't think that AI is ready to replace humans clinically. These studies are completely about technique and about recognizing and securing a safe intervention for the patient, but they're not enough ready to look forward the patient's quality of life or to evaluate the post-operative results of that use of AI. So I think that it is a really good tool. It is it's a really good tool, but it's not enough. We still need that human intervention and to clinically evaluate the patient and to take care of it after the surgery.
All right, so we can say that we can conclude together that AI can be used as an assisting tool along, like, for example, any medical and clinical tool like CT scans, X-rays, and so on, in terms
Yeah.
of clinical, because there are a lot of rumors going around these days that AI can replace doctors and so on and so on and so on. So also this, like, in the future research, we hope that more informative research, awareness research regarding AI to the public also, so that they can really like comprehend the role between AI and doctors or medical practice. Thank you so much for your presentation. It's really thoughtful. I like it. Thank you.
Thank you.
Dr. Adarsh, you have anything to add?
So, a very well conducted study. Congratulations on that. And my first question would be, how did you validated the AI studies? How was the AI validated? Means, did you did it internally, externally, or prospectively going?
Well, we did it prospectively. Yeah.
Okay. And the second question is, does the learning curve for the coming surgeons or for the junior surgeons increase or decrease when they do real-time AI assistance or when they take real-time AI assistance? Because obviously you already mentioned that it cannot replace humans totally, but do you think the learning curve becomes steeper or slower on the slope side of it?
Well, of course, it is a good tool, like in this moment, and it'll help like surgeons to confront this new environment that is the surgery. It will help them to for a start, and of course, the learning curve will be not like it used to, but it will be also easier to access to this kind of procedures for the new surgeons, for the junior surgeons. So I think that that's like a good thing about this, like it's not going to be that limited for people that understands the procedures, but it will help to learn to the juniors.
Okay. My last question for you is that what in your study, what was the strongest evidence that you came across? Was it for laparoscopic colorectal surgeries or was it for robotic colorectal surgeries? Means which of the both two in comparison get you the most evidence for the studies for AI assistance or something?
It was through laparoscopy. That was like our our, our focus, because there's more studies about it.
Okay, thank you. That's all. Congratulations on a well conducted study. It's a well thought and methodologically sound study. Thanks.
Thank you.
Thank you so much, both the presenter and the judges. Now we will be moving on to the code. So we would want to remind the judges to fill in the form that has been given to you previously. And as for our audience, please do scan the code as presented on your screen and vote for your most preferred presenter. All our awards will be announced just before the closing today, so we do hope everybody will be joining us just before then. All right, moving on, we'll be calling on Akram Anim from the University of Medical Sciences and Technology, Sudan, and he'll be discussing on the complications of nephretic syndrome in the children in Tertiary Hospital of Rwanda, Kigali, was it? And the University Teaching Hospital of Kigali from
sorry,
2019 to
I cannot
2025.
hear you.
Sorry? Oh, can you hear me now? All right. You may present your presentation. And for this session, we will
I'm
have...
not hearing anything actually. I could start.
Yes, you may begin. All right. So I will be providing him with the assistance. Here you go. You will be having Dr. Isabel as our judge for this session, and Dr. Adarsh.
I'm not hearing anyone, but am I audible?
Oh, Isabel, you can't hear him. That's weird. I could hear him from my end. Uh, does anyone else hear him other than me? Okay. You may begin.
Okay, I will be starting. So my name is Dr. Akram. I'm a recent graduate from the University of Medical Sciences and Technology, Faculty of Medicine. And today I'll be presenting the findings from a 6-year retrospective cohort study evaluating the complications and outcomes among children with nephrotic syndrome at Rwanda's largest referral center, which is CHUK, University Teaching Hospital of Kigali. Okay, so starting, nephrotic syndrome is a progressive disease. It's characterized by massive proteinuria, severe hypoalbuminemia, and edema. So after a patient is initially diagnosed, he's on to a stage where he's at a high susceptibility to developing infections. And the question comes, why is this? That's due to the immune dysfunction. Immune dysfunction occurs due to the protein loss that occurs through the proteinuria and the hypoalbuminemia we've mentioned, leading that as we know, the immune system is its main constituent is proteins. This can lead to major complications, including infections, AKI, hypertension, anemia, and others. In severe cases, it might even lead to progressive kidney damage, might reach to CKD, and might lead to high risk of mortality and morbidity. So our key message is early identification and management of complications. It can slow the disease progression and increase the survival. So as we know, nephrotic syndrome is generally considered treatable, but its complications is a major cause of morbidity and mortality. Actually, in Rwanda, unfortunately, data is extremely limited, making it difficult for us to develop context-specific strategies for prevention and management of complicated cases of nephrotic syndrome. So going on to the study objective, our study objective was to determine the burden spectrum predictors and outcomes among children with nephrotic syndrome at CHUK. For the methodology, we included all eligible children diagnosed with nephrotic syndrome at CHUK between 2019 and 2025. We had a total population sampling of 132 child. Data was then collected using a standardized data extraction tool. It was then analyzed using IBM SPSS statistics version 29. We analyzed the clinical characteristics, complication predictors, and survival analysis. We use multivariable logistic regressions, Cox hazards, and Kaplan-Meier survival analysis. Going on to who were the patients, as we said, we had 132 child. The cohort was predominantly male with a 64.4%, and more than half of them were underweight at presentation. This emphasized the nutritional burden among our population. Going on, let's have a look first at the clinical profile at the first consultation. So edema was by far the most common presenting symptom, with over 3/4 of children presenting with it, followed by others like history of infection, abdominal pain, and hematuria, but not much compared to edema. So for our key laboratory findings, the serum albumin was quite low with just 21 grams per liter. We had marked hypercholesterolemia, double the normal. Anemia was also found with 22% having lower than 10 gram per deciliter. And we have found that there is a significant kidney damage for a substantial proportion of our patients. And these findings present and reflects that the disease severity is really advanced at the time of presentation. Going on to the burden of the complications, We went on to see that the most common complications were hypertension, followed by anemia, infections, GI complications, and AKI. And hypertension has affected 1 in 3 children, others also like CKD and others. We had an in-hospital mortality rate of 3%. This actually emphasized that in our setting, the morbidity was much more than edema alone. Okay, going on. For our complications, we went on to look specifically on hypertension as it evolved by being the most common complication affecting 1 in 3 children. It is clinically important, not just because that it was frequent, but that's also because that it was found to be an independent predictor for the CKD progression. This emphasizes the need for early recognition and the BP control itself. Going on and having a short talk about the infections. Infections affected a quarter of our patients, which is a high number. We found that the most common infection was bacterial infection pneumonia. This emphasized that the need of reinforcing vaccinations, such as pneumococcal and Haemophilus influenza. Almost a third of the patients developed an episode of fungal infection, including Tinea capitis and Tinea corporis, respectively. This indicated 2 things, starting from the immune suppression that we've mentioned earlier, and the other thing is the local clinical environment itself. So as we can see, one of our strongest predictors is the severe hypoalbuminemia, being less than 15. This increased the odds ratio of developing infection by almost 4-fold, using the 95% confidence interval. Going on and having talked about the AKI and CKD, kidney injury was a continuum part in our study. A quarter almost developed AKI, almost above 11% progressed to CKD, and half of them reaching end-stage renal disease. Hypertension and AKI were a significant and strong independent predictor for CKD progression. We also found a 6-fold higher increase in mortality risk for patients with CKD stage 5. So going on to what predicts the complications itself. So after checking the burden of the complications, we went on to examine which clinical factors specifically independently predicted these outcomes using the multivariable regression. That's a quick flow diagram you can see, but it will be explained better in the coming slide. So that's a summary for the regression analysis. So hypoalbuminemia is the single most modifiable risk factor in our study. As we can see, it is highly increasing the likelihood of and expecting the presence of infections, AKI, and hypertension. Steroid resistance was also not really much significant, but associated with both hypertension and CKD. And of course, hypertension and AKI was mostly significant in predicting the CKD, as we've mentioned earlier. So what we can say from this that hypoalbuminemia is the single most important therapeutic target in order to reduce many of our complications. Going on to our survival analysis, we have done a Kaplan-Meier analysis. We've seen that the patients with CKD stage 5 had a 6-fold increase. Despite that, we have a 3% mortality, which is relatively low, but it clearly identified the highest risk group for mortality. So this requires and emphasizes the need for early intervention and the close monitoring of the high-risk groups. Going on to the last thing, which is the conclusion, our key takeaways for the topic is that complications of pediatric nephrotic syndrome was really common in our cohort, and severe hypoalbuminemia was identified as the strongest independent predictor, as well as we can see the high-risk patients were the people with CKD stage 5 having a 6-fold higher risk in mortality. So these findings support the need for earlier recognition and the targeted therapy, which we would like to be involved with in order to improve the outcomes in resource-limited settings. And thank you so much. That's all, and I'm more than pleased to have any questions.
Thank you so much for that wonderful presentation. Now we'll be having the judges. Dr. Isabel, are you able to help us with the judging? Are you able to hear us?
I'm actually not hearing. I'm not sure if
Yeah, I was
my
able
voice
to
is
hear
clear
him.
like before.
Okay. All right. Akram. Oh wait. Let me just tell him to go off stage and be back. And Dr. Isabel you could put in your concerns. Yeah. Give me a moment.
Okay, I'll be leaving and rejoining the session once again. I hope it will reconnect.
Yeah. Akram, welcome back. Are you able to hear us?
Oh, hi, Akram. Can you hear me?
Yes, I'm able to.
Okay.
Yes,
Okay,
I'm here.
now
Double
I
to everyone.
cannot hear you guys. Uh-oh.
I'm actually hearing you well. Is my voice audible to all of you, both?
Well, it seems that Dr. Isabel may not be able to hear us. So let's give her a moment again to reconnect.
Yeah, sure, no. Okay,
Well, it
sure.
seems that everybody's connection today is not as good. Dr. Isabel,
There's a bit
welcome
of a
back.
tech.
Okay, I can hear you guys now.
All right, great,
Yes, good.
perfect.
Okay. Thank you, Akram, for your presentation. The one question I had for you was, how did you determine that the risk factors for complications were actually risk complications rather than markers for like a more severe nephrotic syndrome? Because those complications could also just be a more severe nephrotic syndrome. So how were you able to determine that difference?
I'm sorry, you mean that how did I determine if the complications were like due to the severe nephrotic syndrome or it's like just a complication
Actual
as of...
complications. Yes.
Okay, so of course we cannot like be sure as 100% if it's due to the severity or due to the complication itself, but we tried on like rechecking the complication and how each one was dealt with the drugs given and so on. This showed that each complication was some were due to the severe state of the disease, but in the first place, that most of the patients were presenting with advanced severity of the disease. That's why the complications were considered to be much severe. But as we said, our main objective was to find the complications in order to reduce the possible and prevent the possible high, or we could say like very complicated cases, in order to reduce the patients from reaching such a stage.
Okay. And during the study, did you at any point distinguish complications that were caused by the disease versus complications that could be caused by the treatment administered to the patients?
Yes, we've tried to check, but according to us, it was mostly due to the disease itself. There were a few complications from the drugs, which can be due to, for example, the infections, because most of the patients were the people who went on to take the second-line treatment, not only the steroids. They were taking immune suppressants, and that would lead to high risk of getting an infection. So this was one of our major issues, but finding out it was mostly related to the drugs itself for the infections part only, but most other complications were apart from the disease.
Okay, thank you. I have no other questions.
You're welcome.
Okay, thank you, Dr. Isabel, and thank you, Akram, for that wonderful presentation. Now we'll be going on to the code. Judges, please do use this time to fill in the forms that was given to you previously. And for our audience, please do scan the code and vote for your most preferred presenter. All our awards will be presented just before the closing today, so we do hope everybody will be joining us up to the end. All right, up next we'll be having Aunis Misiridis. I'm not sure if I'm saying that right. From the School of Medicine, Aristotle University of Thessaloniki, Greece. Welcome and for joining us, and thank you for being here. We'll be presenting radiographic and patient-reported outcomes after Laode's procedure of hallux valgus, a single-center retrospective study. And for our judges, we'll be having Dr. Imad. Sorry for that. Please do begin if you're ready.
Of course, thank you. Greetings, everyone. My name is Ioannis Mirisidis, and I'm a fifth-year medical student at the School of Medicine of Aristotle University of Thessaloniki in Greece. It is a pleasure to present our study titled Radiographic and Patient-Reported Outcomes After Lapidus Procedure for Hallux valgus, a single-center retrospective study. This study was conducted in collaboration with the Second Department of Orthopedics of Aristotle University of Thessaloniki. Hallux valgus is a deformity characterized by lateral deviation of the great toe and medial prominence of the first ray. The Lapidus procedure involves arthrodesis of the first tarsometatarsal joint. By stabilizing the first ray and correcting intermetatarsal malalignment, it aims to restore structural alignment. Although the immediate radiographic correction achieved after Lapidus arthrodesis is well described, two important questions remain. First, how well is this correction maintained over time? And second, does radiographic change necessarily correspond to an unsatisfactory outcome from the patient's perspective? This second question is particularly important because the success of surgery cannot be assessed only through angular measurements. Pain, function, footwear comfort, cosmetic satisfaction, and the patient's overall experience are also clinically relevant outcomes. Therefore, our study evaluated, first, the immediate radiographic correction, second, maintenance of correction over time, and third, patient-reported outcomes in relation to the radiographic findings. We conducted a retrospective, single-center, single-cohort, longitudinal outcomes study. Patients who underwent Lapidus arthrodesis for hallux valgus between 2022 and 2026 were included when preoperative and immediate postoperative radiographs were available. All eligible patients were invited for a follow-up radiographic assessment. We assessed two radiographic parameters, the hallux valgus angle, or HVA, and the intermetatarsal angle, or IMA. Measurements were performed for preoperative, immediate postoperative, and final follow-up radiographs. Paired comparisons were performed using the Wilcoxon signed rank test, while Spearman's correlation was used to assess associations between follow-up duration and radiographic changes. Telephone follow-up also assessed satisfaction, pain, function, perceived recurrence, footwear comfort, cosmetic outcome, and willingness to undergo the same procedure again. A total of 11 patients underwent Lapidus procedure and met the eligibility criteria for the immediate radiographic analysis. 8 of them responded to the invitation for a follow-up radiographic assessment and telephone interview. The median follow-up duration was 11 months. The Lapidus procedure achieved significant immediate correction of both radiographic parameters. Median HVA decreased from 39.6 degrees preoperatively to 12.3 degrees immediately postoperatively, corresponding to a median correction of 27.3 degrees, with a p-value below 0.001. Median IMA also improved significantly, decreasing from 17.8 degrees to 11.7 degrees, again with a p-value below 0.001. At final follow-up, however, the two parameters behaved differently. Median HVA increased from 12.3 to 26.4 degrees, and this increase was statistically significant. However, final HVA remained significantly improved compared with the preoperative measurements. In contrast, IMA showed no statistically significant change between the immediate postoperative assessment and final follow-up. No significant correlation was found between follow-up duration and changes in either HVA or IMA. Telephone follow-up satisfaction was high, with a median score of 8 out of 10. The median cosmetic outcome score was 9.5 out of 10, while median pain was 4 out of 10. In addition, 75% of patients reported that they would choose to undergo the same procedure again. Most patients also reported improved daily function and footwear comfort, while most did not perceive recurrence of the deformity. The main clinical message of our study is that radiographic and patient-reported outcomes should be interpreted together. HVA increased during follow-up, but final values remained improved compared with baseline. At the same time, IMA correction remained stable, and patient-reported outcomes were generally favorable. Therefore, in this cohort, measurable radiographic change did not necessarily correspond to perceived clinical failure. However, our study cannot determine the reason for the increase in HVA. Differences in radiographic conditions, including loading conditions, may have influenced the measured angles, but this remains an interpretation rather than a demonstrated explanation. In conclusion, Lapidus arthrodesis achieved significant immediate correction of both HVA and IMA. During follow-up, HVA increased significantly, although final values remained improved compared with the baseline measurements. In contrast, IMA correction remained stable. Patient-reported outcomes were generally favorable, suggesting that radiographic change in HVA does not necessarily correspond to perceived clinical failure. The main limitations of this study were its retrospective design, small sample size, variable follow-up duration, and non-standardized radiographic conditions. Larger prospective studies using standardized weight-bearing radiographs and validated patient-reported outcome measures are needed. Thank you very much for your attention.
Thank you so much for that presentation. Now we'll be having the judges, Dr. Imad, to join us. Dr. Imad. All right. Dr. Imad, could you hear us?
Yes, thank you so much for the presentation. You have acknowledged the limitations of the study, but given the small sample size of your study, do you think that it is acknowledged or it is appreciated to mention that there is a statistical significant difference in terms of the results that you have between IMA and HPA?
I'm sorry, could you repeat the question a bit louder because I didn't hear you well enough?
I said that this is a retrospective study including 10 patients baseline and only 8 patients at the final analysis, right? And you have reported significant statistical results and relationships in terms, in terms of the improvement in follow-up compared with baseline in HPA, compared with IMA treatment, right?
Yes.
How can we say that this is a statistical significant difference while we only have like 10 or 11 cases? The difference could be nearly immeasurable.
Yes, this is a very interesting question. Thank you very much. The reason why we used data from 11 patients is because this is the total amount of patients that were that underwent the Lapidus arthrodesis in this specific clinic. So this was the only amount of patients that we could work with. And from these 8 patients, only 8 responded to the interviews. So we tried to take this into account. This is the reason why we didn't use the t-test, because we don't have a standardized population. So we use the signed rank test, Wilcoxon signed rank test, in order to try to mitigate this effect as much as we can.
All right. And how did you overcome the risk of bias selection in the final analysis? Like we only had left with only 8 patients, the final analysis, out of 11 patients. So how did you avoid the risk of bias selection?
How did we avoid the risk of, excuse me?
Bias, the
The
risk
risk
of
of
bias,
bias.
yeah, selection, yes. I mean, we
Yeah,
could just, a clinician, to elaborate more on the question, a clinician may just choose those who have favorable outcomes and enter them in the analysis.
yeah, I'm really sorry. I can't hear you loud enough. So, if I understood correctly, the question is how did we manage to avoid the
Yeah,
bias while we only
yeah.
have such a small sample?
Like Dr. Ayonas, like, did you have, for example, a second hand that helped in the study while this hand or this doctor was, um, uh, like, they didn't know the patients initially, or they didn't have a look at the patient's profile names and so on,
I'm really
and
sorry. I
baseline
really can't
characteristics?
hear what you're saying.
No, no
It's not
problem.
loud
No
enough.
problem. No problem. This is a very thoughtful study. I'm so happy that I've had the chance to see your presentation and to hear you out. I would just like to suggest that if we can improve this study, we would be having a prospective, if we can,
Exactly,
cohort study.
exactly.
Yeah, following up more patients, and also if we can like collaborate with other institutions within your city to have multi-center study, it would be great. But it's very a great idea, and radiology clinicians, it's just a dilemma there. Thank you so much.
Thank you as well.
Thank you so much, Dr. Imad, for those suggestions and questions. Thank you also for the wonderful presentation. Now we'll be going on to the code. We would like to remind everyone to please scan the code based on your most preferred presenter. And as for our judges, please do fill in the form that has been given to you previously. All our awards will be announced just before the closing remarks today. Moving forward, we will be having Ahmad Kasif, a medical student from the University of Medicine in the Pharmacy Georgia de Popa Faculty of Medicine in Romania. I'm not sure if I pronounced that right. And he will be discussing on the renal adverse effect associated with clozapine, FAERS disproportionality analysis. Welcome, Ahmad.
Hello, can you hear me?
Yes, we could hear you. And for this session, we will be having Dr. Nedo and Dr. Imad as our judges. All right, you may begin if
Okay,
you're ready.
okay, perfect. Hello everyone. I hope you're all doing well. My name's Imad Kashif Mughal. I just finished my fourth year at Gregori Popa University of Medicine in Romania. So today I'll be presenting our study titled Renal Adverse Events Associated with Clozapine, a Ferris Disproportionality Analysis. This work was conducted by Andrada Besuyu, Filda Kashif Mughal, and myself. In the next few minutes, I'll briefly introduce the clinical background, the outlines of our clinical methods, and summarize the main findings and implications of our analysis. So, for the background, clozapine is a second-generation atypical antipsychotic. It remains the most effective treatment option for treatment-resistant schizophrenia. For many patients, it can be life-changing. However, its clinical use is limited by the need for careful safety monitoring. In routine practice, much of this monitoring focuses on well-recognized adverse events such as agranulocytosis or cardiotoxicity, including myocarditis. Renal adverse events, however, are less extensively monitored. They're described in literature, but compared to the hematologic or cardiac complications, the renal safety profile of clozapine receives much less systemic attention, creating a knowledge gap worth investigating for us. So our aim, because the renal effects of clozapine received much less attention than its hematologic and cardiac complications, an important pharmacovigilance question remained for us, which is, are kidney-related adverse events reported more frequently than expected with clozapine? To answer this, we analyzed renal adverse events reports from the FAERS database and assessed whether any specific kidney outcomes showed disproportionality safety signals. which could indicate if there's a potential association with clozapine and warrant any further investigation. So for our methods, we conducted a pharmacovigilance disproportionality analysis using the FDA Adverse Events Reporting System, which I referred to as FAERS before, the FAERS database. We analyzed reports starting from January of 1989 through December of 2025 with clozapine as their drug of interest. Our kidney-related adverse events were identified with select MEDRA terms, which were about 11, but they included acute kidney disease, renal failure, chronic kidney disease, nephritis, tubulointerstitial nephritis, and several other renal disorders to capture a broad range of kidney outcomes. We then compared the frequency of these events with clozapine to their frequency with all other drugs in the database. Do this, we use two established pharmacovigilance measures, the reporting odds ratio, which I may refer to as ROR later, and the proportional reporting ratio which I may refer to as PRR, along with a 95% confidence interval. So just quickly, these measures tell us whether an event is reported more often than expected. ROR tells us if a specific adverse event is seen more commonly with clozapine, for example, in comparison to other drugs. PRR is a little more complicated, but an easy way to think about it is an adverse event making up a larger share of this drug's reports than we expect. So yeah, these measures help determine whether a particular adverse event is reported more often than expected, which may indicate a potential safety signal. So for our results, looking at our results, acute kidney injury was the most commonly reported renal adverse event associated with clozapine. It came out with 928 reported cases. It was followed by renal failure with 576 cases and renal impairment, which was the third largest with 377 cases. Other renal conditions, including chronic kidney disease, tubulointerstitial nephritis, and other renal disorders, were also reported, but much less frequently. It's important to note that these numbers do not represent the true incidence of these conditions. The FAERS database is a spontaneous reporting database, so the number of reports can be influenced by factors such as underreporting, duplicate reports, and reporting biases. Because of this, these case counts help describe the overall reporting pattern, but we rely on disproportionality analysis to determine whether these events are reported more often than expected compared to the rest of the database and other drugs. So this is just a continuation of my results. When we looked at the disproportionality estimates, most renal adverse events did not show an increased reporting number compared with the overall database. Acute kidney injury was the most frequently reported event, but its reporting odds ratio was 0.99, which is essentially no different from the background reporting rate. Similarly, renal impairment and renal failure both had RORs below 1 as well, and they don't suggest any evidence of increased reporting. The highest disproportionality signal we observed was for tubulointerstitial nephritis with an ROR of 1.58, followed by nephritis with an ROR of 1.28. So based on our study criteria, none of the evaluated renal adverse events showed statistically significant or notable safety signals. Overall, our findings suggest that renal adverse events have been reported with clozapine use, but this FAERS analysis did not demonstrate any evidence of disproportionate reporting compared to the broader database. So why does this matter? The main points from the study are three. So first, acute kidney injury was the most frequently reported renal adverse event associated with clozapine in the FAERS database. Secondly, although tubulointerstitial nephritis and nephritis showed the highest disproportionality estimates, none of these evaluated events met the criteria for a significant safety signal. That is because their confidence interval included the value of 1, which nullifies it, and also because for many of them, they had such low reporting numbers that you can't really take a full picture from it. And finally, the third aspect is that these findings should be interpreted as pharmacovigilance evidence rather than proof that there is no risk with the use of clozapine. FAIRS has important limitations, including underreporting and the lack of denominator data. Clinically, our results support continued awareness for renal adverse events in patients receiving clozapine and highlight the need for further observational studies. So for my conclusion, in summary, our FAIRS analysis identified several renal adverse event reports associated with clozapine, with acute kidney injury being the most frequently reported. However, none of the evaluated renal outcomes showed a statistically significant disproportionality signal. These findings support continued clinical awareness for potential renal adverse events, especially for someone with pre-existing conditions. And our study also highlights the need for further research to better understand clozapine's renal safety profile. Thank you guys so much for your attention.
Thank you so much for that wonderful presentation. Now we'll be having the judges join us. So Dr. Imad and Dr. Jodu, you may start with your questions. Both doctors, welcome. Could you hear us?
Yes, we can hear us. We can hear you. Dr. Najido, we can go.
All right. Thank you. Thank you so much, Mr. Emad, for your presentation. I think I have just one concern. I would like to be clarified on the area where you were talking about the no signal. Could you please explain?
Yeah, so a safety in simpler terms, a safety signal is basically when you can find a link between clozapine, for example, and an outcome. So, for example, when I was talking about reporting odds ratio, if we had a reporting odds ratio of 1.2 with a large data set, we could say that one would be like the same as other drugs in the database. 1.2, which would mean that, for example, acute kidney injury would appear more often than other and with clozapine compared to all other drugs. So that would be a safety signal, which we did not receive in our research.
All right. Thank you so much. That's all for me.
So hopefully that answers your question.
Yeah, thank you.
Dr. Imad, do you have anything else to add?
Yes, thank you so much for the presentation. I have also one question, which is, would you be able to explain why there was a high number of reports that didn't necessarily indicate any safety signals for the clonazepine?
Yeah, so sorry, could you repeat the question?
Like you mentioned, there might be underreported. Yeah. You mentioned there might be underreported data in this.
Yeah, so when I say that there might be underreported data, it's because with the FAIRS database, not everything is reported. So our totals, our review and our research included about 160,000 cases total over the span of so many years. And for example, with acute kidney injury, there were 928 cases. However, that does not mean that over the span of that many years, those only 928 cases appeared. That's just a small picture of the greater reportings. FAIRS only shows us what people have inputted and the data they have available. So that's what we go off. And so that's why I'd say there's a little bit of a bias there. We don't have the full picture.
Yeah, I get you. Would you attribute this to the fact that this is only small prevalence of the clonazepine, or would you attribute it, like, for example, um, like the safety signals for clonazepine is negligible? Like, what are the confounding factors for that?
So for
Like,
safety signal,
as a researcher, what do you think of any confounding factors that led to this small prevalence over years in terms of this drug side effects on kidney, especially acute kidney injury?
So I didn't do too much research into that because this was more of a disproportionality analysis rather than looking into as to what causes it. But that's an amazing question, and I think that also further warrants further research, and I think that's something I may look into in the future, if
Thank you so much.
that's
Thank you so
okay.
much.
Thank you so much.
All right, thank you, judges. We will be using this transition to have the code, and as well as our presenter, thank you so much for that wonderful presentation. We will be having the code presented here. We would want to inform everyone to please scan the code and to choose to vote for your most preferred presenter. As for our judges, please do fill in the forms that has been given to you previously. All our awards will be given or will be announced just before the closing today. All right. Next would be Angela, a fifth-year medical student from the University of Novi Sad, Faculty of Medicine, Serbia, and they will be discussing on the psychopathological characteristics and motivational factors of pathological gambling. And for this session, we'll be having Dr. Adarsh, if he is available as our judges.
Hello, I'm having a little bit of trouble with my camera, just a moment.
Not a problem. Do you have any internet technical difficulties on your end? If so, you may have the camera off.
No, I didn't have. I don't know why it's not starting yet.
Not a problem. We could hear you, just a little bit laggy though.
Okay, so I can start without the camera, or?
Yes, it is possible.
Okay.
You may proceed.
Okay. So, good afternoon, dear members of the committee and colleagues. My name is Angela Lazic, and today I will present our research called Psychopathological Characteristics and Motivational Factors of Pathological Gambling. Let me just briefly introduce myself. I'm a fifth-year medical student at the University of Novi Sad, Faculty of Medicine. I'm particularly interested in neuroscience and psychiatry, but also in women's reproductive health. Outside of medicine, I enjoy traveling, spending time with my friends, and working out at the gym. So when we think about gambling, most of us imagine entertainment, excitement, or possibility of winning. But however, for some individuals, what begins as a harmless pastime gradually evolves into a chronic psychiatric disorder that affects every aspect of a person's lives. Gambling disorder is now recognized as a behavioral addiction characterized not only by a loss of control over gambling behavior, but also by a complex interaction of impulsivity, emotional dysregulation, and psychiatric comorbidities. These characteristics contribute to persistent gambling despite severe personal, social, and financial consequences. In recent years, the widespread availability of online gambling has made this disorder an increasingly important public health concern. Yet, many questions remain about the psychological factors that drive gambling behavior and influence treatment outcomes. The aim of this study was to investigate the psychopathological characteristics and motivational factors in patients with gambling disorder, and to explore how these factors relate to important clinical outcomes. We conducted a retrospective observational study at the University Clinical Center of Vojvodina. Medical records of patients treated between January 2020 and December 2025 were reviewed, and a total of 282 records were screened. And after applying the inclusion and exclusion criteria, 101 patients were included in the final analysis. We collected anonymous socio-demographic and clinical data. and the statistical analysis was performed using JASP and Microsoft Excel, applying descriptive and inferential statistical methods with a significance level of P being below 0.05. Before moving on to the main statistical findings, let's first just take a look at who our patients were. The majority of participants were men with the mean age of 36.8 years. Most had been living with gambling disorder for 3 to 10 years, highlighting the chronic nature of the condition. As far as gambling initiation, the most commonly reported motivators were excitement and entertainment, followed by financial problems, escape from reality, and influence of the social environment. Psychiatric comorbidities were present in more than 3/4 of the patients, with substance use disorders and mood disorders being the most common. Nearly half of the patients exhibited impulsivity, while suicidality was reported in 40.6% of the sample. And almost 1/4 of the patients had a history of pre-suicide attempts. And since suicidality was observed in a substantial proportion of our patients, we next explored whether suicidal thoughts and plannings were associated with actual suicide attempts, and we found a very strong connection between those factors. Patients reporting suicidal ideation or planning had higher odds of attempting suicide. Although this is a statistical finding, it carries an important clinical message that routine assessment of suicidality should be an essential part of the evaluation of every patient with this diagnosis. Another important finding concerns treatment outcomes. Patients who regularly attended follow-up appointments were significantly less likely to attempt suicide, while better treatment adherence was associated with a lower risk of relapses. And these findings remind us that treatment does not end once the diagnosis has been made, and that long-term engagement play important role in maintaining recovery in these patients. And finally, we examined the impact of impulsivity. Our analysis showed that patients who had impulsive characteristics had 8.5 times higher odds of experiencing legal problems. And these findings show us the importance of also assessing impulsive characteristics during clinical evaluation. In conclusion, our findings reinforce that gambling disorder should be viewed as a complex psychiatric condition rather than just a simple behavioral addiction. Effective management requires not only treating the addictive behavior itself, but also recognizing the broader psychological and social challenges these patients face every day. Early risk assessment, continuous follow-ups, and individualized care may improve long-term outcomes and help prevent some serious complications. Although our study was limited by its retrospective single-center design, it provides valuable clinical insights into the characteristics and management of patients with gambling disorder. Maybe some future prospective multi-center studies using standardized tools are needed to strengthen the evidence and further improve both prevention strategies and clinical care. Thank you for your attention, and now I'll be happy to answer your questions.
Very nice presentation. Thank you so much for that. Currently, we are waiting for our judges to join us, but I do have a question for you. What is your inspiration for bringing this study up to the public?
Well, in my country, we have a serious problem with gambling. And I don't think it's talked about enough. We have casinos on every corner, and as years goes, patients who come to treatment centers are younger and younger, and I think that's really alarming.
I see. So I think in your study you would also try to add some some recommendations and suggestions to go to the grassroots. That way they'll be able to prevent this kind of disorder. Yeah.
Yeah. Yes.
Yeah. All right. For your session, okay, we do have Dr. Versha, but since she's not, we do have Dr. Versha. She'll be able to judge your session. Could you also provide a very brief one line taker for Dr. Versha? That way, she'll be able to provide some questions for you again.
I'm not sure I understand what sort of line.
Sorry, maybe it's all right for you to please repeat the conclusion of your study. That way, Dr. Versha is able to hear that and to provide suggestions for you.
Okay, yeah. Well, as I said, maybe we take this condition simply as behavioral addiction. It's very complex and has a lot of connections with other psychiatric comorbidities and some serious complications. And we shouldn't just treat the addictive behavior itself, but we should recognize the challenges these patients face on an everyday basis. And as I said, our study is limited by its retrospective and single-center design, but I think we come up with some valuable clinical insights into the management, treatment, and also characteristics of these patients. And as I said, maybe some future prospective multi-centered studies using some sort of standardized tools are needed to help us improve prevention strategies and overall clinical care of these patients.
Thank you for that. Dr. Versha, could you hear us? And could you please provide some suggestions or questions for our presenter?
Yes, I have a question. What about a patient of substance abuse and related mania? Have you seen any cases? Have you managed them?
We didn't have the contact with patients. We just reviewed medical history. But as it seems, substance use disorders were highly connected with gambling disorder. We didn't investigate whether the gambling disorder led to substance use or vice versa. So maybe next research should focus more on those connections between comorbidities.
Okay. Gambling disorder is something else, but I'm asking about mania. Patient in mania.
There were some patients with mania, and also we had a small number of patients who started gambling because of their original disorder, which was mania, but it wasn't some significant motivators compared to these previously mentioned.
Okay, thank you.
All right. Thank you, Dr. Versha, for that wonderful suggestion and questions. We will be moving on to the code. So we would want to request everyone to please scan the code and to choose and vote for your most preferred presenter. And as for our judges, please do fill in the forms as well that was given to you. All our awards will be presented just before our closing remarks today. All right. Moving on or moving forward, we will be having Dr. Dutimi Alabinet. I'm so sorry for the pronunciation.
Hello.
But then he'll be presenting on the sleep quality and its associated
can you hear me?
comparative studies on undergraduate students of the University of Port Harcourt. We could hear you. Could you hear?
Can you hear me? I can't see.
Oh, I understand now. Yes, we can hear you.
Okay. I can't see I'm not hearing your voice.
All right, I will be putting it on the comments, so you may begin. Oh my goodness. All right, wait for a minute. Let's try that again. I
Hello.
typed it to you. Hi, do you hear us?
Okay, good day everyone. My name is Dr. Ndutsime Alabinte. I'm a MBS graduate of University of Port Harcourt. I'm here to present our study on sleep quality and its associated factors, a comparative study of undergraduate students of the University of Port Harcourt. I also want to give a special thanks to my co-investigators, Dr. Ubechukwu Favour Ajoku and Dr. Abigail Edet Apan for their vital role in this topic. So sleep is a crucial physiological, psychological, social, mental, and physical determinant of undergraduates. University of Port Harcourt is a resource-limited federal university in Nigeria, and undergraduate students have unique socioeconomic and infrastructural factors and challenges which can affect their sleep quality. And such factors or challenges could be unstable electricity, congested lodging conditions, extremely intense academic workloads, amongst others. So our objective for this study was to determine the prevalence of poor sleep Okay, so the other objective was to analyze and compare its association with a wide range of variables, including socio-demographic burdens, academic workloads, screen time, physical activity, substance use, and lightning. For this study, we used a descriptive cross-sectional study design and a multi-stage sampling technique involving 4 faculties and 8 departments. And then the participants were selected using a computer-generated random number sequence based on the official university class list. This was done to minimize need bias. And our sample size was 424 undergraduate students. So in order to evaluate the sleep quality amongst these undergraduate students, we utilize the Pittsburgh Sleep Quality Index, which is a validated metric for evaluating sleep quality. And a PSQI score of greater than 5 was determined to be poor sleep quality, and that of 5 and below was determined to be good sleep quality. And then we analyzed everything using SPSS version 31, and a p-value of less than 0.05 was determined to be statistically significant. So for our results, we got a very high prevalence of poor sleep quality amongst the undergraduate students at the University of Port Harcourt, a value of 58.02%, with mean global PSQI score 6.36 plus or minus 3.47. So amongst the 7 components of the PSQI, there were 2 components which drove this very high prevalence of poor sleep quality, which were the sleep disturbances with a mean of 1.32 and sleep latency, which is the time it takes for them to sleep, with a mean of 1.07. For statistically significant associations, we had 3, which were in employment status with a p-value of 0.002. This means that the students, undergraduate students who were employed, were found out to have a poor sleep quality. Also, perceived stress was another statistically significant association, the p-value of 0.03, meaning that those students who had a very high level of perceived stress had poor sleep quality. And then also, the students who utilized recreational drugs also had poor sleep quality. For non-statistically significant associations, unexpectedly, the variables which have been globally assigned to students having poor sleep quality include such as the intense academic workloads, prolonged screen time use, poor environmental lighting were not statistically significant in this study. So in conclusion, poor sleep is highly prevalent among the undergraduate students of the University of Port Harcourt and is primarily governed by socioeconomic obligations and stress profiles rather than the typical factors such as the academic workload, prolonged screen time, and also poor lighting. And for our recommendations, we advise the university to formally introduce sleep hygiene education into the general studies curriculum, and also establish dedicated campus stress management and substance use reduction clinics in hope that the prevalence of poor sleep quality among the university students will be reduced. Thank you very much. I'm open for any questions.
Thank you so much for that wonderful presentation on sleep quality and its associated factors. We'll be inviting Dr. Versha for the questions.
Yes, I want to know actually, uh, right now the trending reels, social media, and how right now the situation is affecting the sleep quality.
Sorry, can you state your question over again? I didn't hear the beginning part. Sorry.
Sorry.
Please, can you state your
She was
question again? I didn't hear you initially.
Okay. I was asking about like today's social media trends and all. So how this is affecting the sleep quality?
Okay.
Is it?
So
Yes.
Okay. Thank you. Thank you very much for your question.
Mm.
So for our study, we didn't get any statistically significant association between social media or prolonged screen time use, since most persons who use social media usually use use their screens for a longer period of time. There was no statistically significant association between that and sleep quality. However, globally, prolonged screen time has been associated with poor sleep quality. But in our study, we found out that the infrastructural difficulties in the university had more effects on the poor sleep quality than the generic factors.
Okay. Okay. Good. Thank you.
All right. It
Thank you very
seems
much.
that Dr. Versha does not have other questions, but I do personally have certain question. So I'm not sure if I heard well on your presentation earlier, but then is there any data on sleep deprivation and how it affects, for example, your studies? Is there a direct correlation on that on your data? Just something I'm curious. None. But maybe you could also look into that in future research is possible. All right. Thank you again, and we'll be moving on to the code. Thank you for the presenter
Sorry,
and
I can't
judge.
hear. Okay.
Oh,
Thank you very much.
so sorry. All right. Please, we would want to remind everyone to please scan the code and to vote for your most preferred presenter. All our awards will be done just before the closing remarks today. And for our judges, please do fill in the forms that has been given to you previously. Next up, we would have Ummey Ulagan from Bersha Uludang University Faculty of Medicine. I'm not sure if I pronounced that right.
Hello, can you hear me?
Yes, we could hear you. Please do present your screen.
Yeah, I'm trying.
All right. And for this session, we would still have Dr. Versha as our judge.
It is processing.
All right. So while it's processing, let me try to introduce your topic. So it's on the investigation of social media addiction, anxiety, and related factors among medical and health sciences students at Bursa Uludağ University. Yeah?
Yeah, we are from Bursa Uludağ University, from Turkey, and I am Ummey Olağan. We are going to introduce you the investigation of social media addiction, anxiety, and related factors among medical and health sciences students at Bursa Uludağ University. Shall I begin?
Yes, please.
Social media allows us to communicate, learn, and stay informed. However, excessive and uncontrolled use can develop into what is known as social media addiction, a behavioral addiction characterized by compulsive use despite negative consequences. University students, especially those studying medicine and health sciences, face considerable academic pressure, long study hours, and emotional stress. So they may be especially vulnerable to unhealthy digital habits. Our study aimed to investigate social media addiction, its relationship with anxiety, and the influence of factors such as gender, educational years, smoking, and alcohol use among healthcare students. Recent years have seen a dramatic increase in social media use worldwide. While these technologies provide many educational and social benefits, excessive use has been linked to sleep problems, reduced academic performance, decreased attention, increased stress, anxiety, and depression. Medical students represent a particularly interesting population because they experience intense workloads, frequent examinations, and high expectations throughout their education. Many students use social media as a way to relax or escape stress. Unfortunately, this temporary relief may gradually become excessive use, creating a cycle where stress increases social media use and social media addiction further increases stress and anxiety. The objectives of our study were threefold. First, we wanted to determine the prevalence and level of social media addiction among medical and health sciences students. Second, we aimed to evaluate the relationship between social media addiction and anxiety. Finally, we investigated whether demographic characteristics and lifestyle factors, including gender, educational years, smoking, and alcohol consumption, were associated with social media addiction. By identifying these factors, we hope to contribute to the development of preventive interventions at universities. This was a cross-sectional study conducted at Bursa Uludağ University. A total of 613 students participated initially, and after excluding incomplete questionnaires, we have 521 responses were included in the final analysis. The participants' ages ranged from 17 to 29 years, with an average age of about 19.5 years. Information was collected using anonymous questionnaires that included demographic information, social media use, smoking and alcohol habits, and validated psychological assessment scales. And the participation was voluntary, informed consent was obtained, and the study received approval from the University Ethics Committee in accordance with the Declaration of Helsinki. We used the social media addiction scale, the perceived stress scale, Fagerström test for nicotine dependence, and Bayperi alcohol screening tool. Statistical analyses were performed using SPSS software, including correlation analysis, independent sample t-test, ANOVA, multiple linear regression, and logistic regression. Our results revealed interesting findings. First, we found a positive correlation between social media addiction, nicotine dependence, and perceived stress. In other words, students with higher addiction scores also tended to report greater stress. When comparing genders, female students had significantly higher social media addiction scores than male students in both faculties. However, anxiety scores themselves did not differ significantly between males and females. When comparing faculties, there were no significant differences in total social media addiction or overall anxiety scores. Some differences were observed only in specific cognitive and emotional subscales. Overall, these findings suggest that social media addiction is widespread among both medical and health sciences students. One interesting finding involved medical students in their sixth year, also known as interns. Compared with students in earlier years, interns demonstrated lower emotional dependence on social media, suggesting that they may rely less on social media emotionally. However, despite this reduced emotional dependence, interns actually showed higher anxiety levels than students in other years. We believe this finding reflects the unique challenges of internship, including increased clinical responsibilities, long working hours, and concerns about graduation and future careers. Interestingly, we didn't observe this pattern among health sciences students, only in medical students. To identify independent predictors of social media addiction, we performed multiple linear regression analysis. Three variables remained significant. First, male gender was independently associated with higher addiction scores after adjustment for other variables. Second, students in earlier years of education tended to have higher addiction scores. Finally, higher anxiety scores independently predicted greater social media addiction. Smoking and risky alcohol use were not statistically significant independent predictors after adjustment, although simple correlation analysis suggested some relationship. These findings indicate that anxiety is one of the strongest psychological factors associated with problematic social media use. Next, we examined whether increasing social media addiction could predict severe anxiety. Our logistic regression analysis showed that every 1 point increase in social media addiction score increased the odds of high anxiety by about 3.3%. Although the overall regression model narrowly missed statistical significance, this trend strongly suggests that greater social media addiction is associated with increased anxiety risk. Future longitudinal studies with larger populations may clarify this relationship better. In conclusion, our study highlights an important public health issue among future healthcare professionals. Social media addiction appears to be closely associated with psychological stress and anxiety. Students experiencing greater anxiety may increasingly rely on social media as a coping strategy, potentially creating a cycle that worsens their mental well-being. Although our study cannot establish cause and effect relationship because of its cross-sectional design, it identifies important risk factors that deserve further investigation. We recommend that universities implement preventive programs focusing on digital well-being, stress management, healthy coping strategies, and digital detox education. Protecting the mental health of healthcare students today eventually contributes to better healthcare professionals tomorrow. Thank you very much for your attention. We would be happy to answer any questions.
Thank you so much for that presentation. Now we'll be calling on our judges to join us on the platform. Dr. Virsha?
Yes, I would like to ask few questions. And the first is, have you seen during your research the actively suicidal patient because of the social media stress and anxiety?
Can I take it again? Sorry. Did I see what? Did we see what? Sorry.
Actively suicidal patients. Suicidal.
No, we didn't search that suicidal incidents, not that, just anxiety levels, but not none of our students were in critical degree.
Okay. Okay. And second question is, what were the personality types if you have examined them? What do you think they were?
Sorry, my connection is bad. So can you
Yes,
repeat the question
personality.
again?
I was asking about personality.
Personalities.
Yes.
The personalities, we didn't also search that, but we could see some similarities between students, of course. Firstly, the medical students especially are so stressed about being good at their education because they grew up learning this, and they are successful students in Turkey. That way they could study at medical faculty, so they have higher education stress than average. And I'm not sure about addictional behaviors than average other students, but there are some researches that they show that medical students and healthcare students also have higher addictional behaviors than the average of Turkey.
Okay. So do you think they were already in a state of anxiety or depression before the starting of this research?
Before starting, none. Do you mean like as the year? The first year students showed less anxiety, and the sixth year students showed more anxiety.
Okay. 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 Got it. Yes. Thank you.
very
Thank you.
much.
The presentation was beautiful.
Thank you.
Thank you, Dr. Versha, for those. I do have a question, if that's possible, Ummey.
Of course.
Did you look into the relationship of the social media addiction or anxiety towards their academic performance? Since you did
No, we
mention
did
that.
not look at that, but we can tell that there is a correlation, but it's just my personal opinion.
Yeah, since you did mention that they have the anxiety, or maybe the anxiety is induced due to academic pressure. So
We
does that?
didn't look. Sorry.
Yeah, no problem. You did look
We
into that,
didn't
yeah.
search the academic,
Pressure.
No, not like the better students
Performance.
or the worst students. We didn't look into that. No, sorry.
Yeah, understood. And also another question would be, I think you did mention on the women having, I think, higher anxiety. So did you
Yeah.
see any solid reason why they have a higher anxiety compared to the males? Would it be on the academic? What reason is that? Is that on the social media addiction itself, or is it the anxiety?
Actually, we can say this is why, because we have a cross-sectional study, so we can't show the reasons. We just can show the relations. Sorry, but there is there's something like that. Yeah, in both faculties, the female students showed higher social media addiction.
Oh, I see. Maybe in future research, we could hope that someone else will look into the reason on why specifically they're looking. Yeah. All right. Thank you so much again. So wonderful presentation. We'll be moving on to the code. Thank you, Dr. Versha and Ummey. We would like to remind everyone to please scan the code in front of you right now and to vote for your most preferred presenter. And as for our judges, please do fill in the forms that were given to you previously. All our awards will be presented just before the closing remarks today. All right. Moving forward, we will be having Cyprian Terence from the School of Medical Sciences University of Science and Technology in Ghana, and he'll be discussing on the knowledge and first aid practices towards burn injuries in the Tema Metropolitan District, a cross-sectional study. Yeah? Hi, Cyprian.
Hi, hello.
Hello. So for this session, we will also be having Dr. Versha as our judge. You may begin once you're ready.
Okay, thank you very much. Hello to everybody. My name is Cyprian Owusu-Ansah. I'm a medical student at the School of Medical Sciences, KUST, Ghana. And today I'll be talking about the knowledge and first aid practices towards burn injury. This was a cross-sectional study done in Tema Metropolitan, that's a suburb of Ghana. And yeah, let's get into it. So why this study? In low and middle income countries like Ghana, where I'm from, burns are one of the leading causes of morbidity and mortality. However, this is it shouldn't be so, because this is a very preventable cause. So it is imperative that community members have the first aid knowledge to prevent or to mitigate the effect of burn injuries, essentially, yes. So the aim of this study was to assess the burn knowledge and first aid practices in Tema. So let's go to the study methods. So this study was a community-based cross-sectional study. It employed convenience sampling, and we had 230 participants. The data was analyzed using descriptive statistics, chi-square test, and logistic regression. It was conducted from October to November 2025. So on this page, you can see a graph showing 3 different values. So after the analysis of the results, we were able to find out that about 80% of the participants had moderate to high knowledge on burn injuries. So a knowledge questionnaire was set, and it was based on the causes of burns, the knowledge of burns, and appropriate first aid measures to take when somebody has a burn injury. And was actually, most of the participants had good knowledge of burn injuries, but let's see what's on the next slide. So unfortunately, that knowledge didn't correlate to practices. So even though we had about 80% knowing about or having knowledge about injuries, only 50% were able to correctly identify what to do when somebody has a burn injury, which is using cooling with running water for 10 to 20 minutes. Yes. And even the few that were able to identify that were not able to identify the correct duration, that's 10 to 20 minutes of cooling. So only 13.7% of participants knew the appropriate cooling duration. And what was quite unfortunate was that about a fifth of participants reported using harmful substances. This included ice, shea butter, toothpaste. And the use of these traditional remedies worsens the outcome, the prognosis of burn injuries. So I think it's safe to say that the awareness of injuries is not equal to the actionable knowledge. So on analysis of the data, we were able to find that education and occupation had strong relationship or significant association with burn knowledge. And I think this goes to explain why these burn injuries are more prevalent in low middle income countries like mine, where I'm from, because of the high illiteracy rate, and why they are less prevalent in the first world countries, so to speak. There was no significant relationship between sex and burn knowledge. So higher education attainment was the strongest independent predictor of burn knowledge. So to conclude, 80% of participants had moderate to high knowledge. This, however, did not reflect in the appropriate first aid responses, and only 13.7% knew the proper cooling duration. About a quarter, which is 20%, about a fifth, which is 20%, used harmful remedies, and this just worsens the prognosis of burn injuries. Recommendations we had was community education, as we saw that education was one of the one of the strongest associations with burn knowledge. And proper education, not just about burns, education on appropriate first aid practices. That aside, school-based training and public awareness campaigns will go a long way to manage these burn injuries. I think I'll end by saying that the first few minutes following a burn determine the next few months of recovery. Thank you very much for your audience.
Thank you so much for that presentation. Now we will be inviting our judges to join us on stage. Hello, Dr. Versha and Dr. Franklin. Dr. Franklin, would you want to go first? All right, Dr. Versha, maybe you would want to go first.
Yes, I want to ask that why did you choose a cross-sectional design instead of you can do an interventional or something like pre-post educational study? So reasons for choosing your
So thank you for that question. A cross-sectional study was chosen because I wanted, the study was done to assess the prevalence with in the community. We wanted to see the knowledge the community members had in relation to the first aid practices. So it was just a snapshot in time, a single study to identify the prevalence of their knowledge and practices and how they related to the practices. That's why a cross-sectional study was chosen instead.
Okay, and one thing, yes, important, I want to know that what if, suppose you find a good knowledge, but poor first aid practices and facilities. So what would you do with that?
Okay, thank you very much. So that's exactly what we found, what was found in the study. A lot of people had good knowledge of the causes and the effects, but had poor first aid. And that goes into the recommendations. So the public health campaigns, and then the education programs, because obviously they know what is happening, but they don't know what to do when it happens. So yes, that's what I was trying to say in the recommendations, essentially.
Good. Okay. Thank you.
Okay. Yeah.
Thank you too.
Yeah, thank you for your presentation, Super. And apologies for the technical issues I had earlier with my microphone. Yeah. So I was thinking two questions. And thank you for the great presentation. It was just very informative hearing about first aid practices in your region. So I'm thinking that one, like, what was your sampling strategy like? And I may have missed this, but like, how did you select the people who participated in this study? And are you concerned that are you concerned about maybe the risk of a selection bias in the sense that those who did not participate in the study may have like a different level of knowledge or practice towards first aid? Then two, and this is just me generally trying to think, and I appreciate your recommendation regarding public health agencies trying to increase or trying to do things to improve the level of knowledge. But another thing, and again, as student researchers, I see how we can be constrained in terms of like resources and what we can do. But another shift is that like most times, like when we ask a question, the ultimate aim of the research is to like intervene. Otherwise, we are just like asking questions and doing exploratory things. So it will be nice that for a second stage to take your project forward, you can think of like interventions you can design to help address all of this. Because otherwise, like that, it just makes our research more ethical when after asking a question, we identify a gap, we try to plug in the gap. So yeah, so like just talk me through about your concerns about like the sampling strategy and risk of who got selected and who did not get selected to respond.
Okay, thank you very much for that, and it's very much noted. I'll take that into consideration next time. So for the sampling strategy, unfortunately, this was a convenience sampling because of logistics and financial issues. Because I mean, it was just a single. I conducted the study alone, so I didn't really have the opportunity to do it as big as I wanted to. So unfortunately, there is some level of selection bias, but I tried to mitigate it by moving through different areas in the community. So it wasn't like I went to a particular side in the community and just used that response. I tried to move through different separate locations in that particular community to get varied responses. It does not completely eliminate the selection bias, but that's what I could do in my own little way, since it was a convenient sampling at the end of the day.
Yeah, and amazing that like you were thinking about the sampling bias and trying to do things in your way to mitigate it just before going into the study. Because some people just ignore all of these things and then they could have like biased results. So yeah, just happy to hear that you were thinking about all of those. I have no other questions. Thank you so much, Super.
Thank you too.
Right, thank you so much, judges, and as well as our presenter right now. We'll be transitioning to the code. So we would want to remind everyone to please scan your code right now and to vote for your most preferred presenter, and as well as our judges to fill in the forms that were given to you previously. All right, welcome back from our break. First off, we'll be having Yorgun from the Sri Guru Ram Das University of Health Sciences in India. Welcome. So she'll be presenting on the Pauci-Immune focal crescenting necrotic glomerulonephritis imbro on diabetic nephrocirrhosis, a rare case study report. Oh, that's really a hard thing to pronounce. And we'll be having Dr. Versha and Dr. Franklin as our judges for this session. You may begin if you're ready.
Yeah. So, hi everyone, I am Hargun Kaur Malhotra, a third year medical student from Shri Guru Ram Das University of Health Sciences, Amritsar, India. Today, I'll be presenting our case titled Pauci-Immune Focal Crescentic and Necrotizing Glomerulonephritis Superimposed on Diabetic Nephrosclerosis, a rare case report. Am I audible?
Yes, we hear you loud and clear. Continue.
Yeah. So, diabetic nephropathy remains the most common cause of chronic kidney disease worldwide. Therefore, a patient with long-standing diabetes develops renal dysfunction, and it is easy to attribute the decline solely to diabetic kidney disease. But non-diabetic glomerular diseases can still coexist with diabetic nephropathy, although they are uncommon. One particularly rare overlap syndrome is this, our case, the Pauci-Immune focal crescentic and necrotizing glomerulonephritis, commonly known as PFCNGN, superimposed on diabetic nephrosclerosis. This condition progresses rapidly and carries a poor prognosis with frequent results in dialysis dependence and despite aggressive immunosuppressive therapy. Our case, the patient was a 57-year-old female with long-standing type 2 diabetes mellitus and a history of cigarette smoking. She presented with bilateral lower limb swelling and frothy urine for 1 month, and on examination, she was hypertensive with bipedal edema. The most striking finding was the rapid decline in her renal function. Her serum creatinine had increased from 1.1 milligram per deciliter to 6.64 milligram deciliter over 1 year. Her urinary analysis showed nephrotic range protein urea with hematuria, suggesting an active glomerular disease. Her urine albumin creatinine ratio was over 7,000 milligram per gram, with 13 grams of protein urea in 24 hours. The serological examination included The complement levels, hepatitis, and HIV screening, and anti-GBM antibodies and ASLO titers, which were all negative. However, the p-ANCA was strongly positive at greater than 1:640, raising a suspicion for an ANCA-associated vasculitis. Hence, a renal biopsy was planned. The biopsy confirmed Pauci-Immune focal crycentric and necrotizing glomerulonephritis superimposed on diabetic nephrosclerosis. The histology demonstrated crycentric formation with fibrinoid necrosis and interstitial fibrosis. However, on immunofluorescence, there were minimal immune deposits, and the electron microscopy supported the underlying diabetic nephropathy. So these were the reports under the microscopy, the light microscopy, and under the immunofluorescence. So her treatment was mainly included intravenous methylprednisone followed by oral prednisone and cyclophosphamide and rituximab. Despite treatment, worsening renal failure required hemodialysis, and she remained dialysis dependent further. This case reminds us that rapidly worsening renal function in a diabetic patient should not automatically be attributed to diabetic nephropathy. Clinical features such as a rapid rise in serum creatinine, heavy proteinuria, hematuria, and positive ANCA-associated vasculitis should also be kept in mind. And most importantly, renal biopsy still remains the gold standard for the diagnosis, enabling timely immunosuppressive therapy, even though the long-term prognosis may remain guarded. Thank you. And I'll be happy to answer all your questions.
Thank you for that presentation. Now we'll be having our judges join us on the platform. We'll be welcoming Dr. Franklin and Dr. Varsha.
Yeah, amazing presentation, Hagan. Like, thank you so much for just bringing all of this back to our memory, and your conclusion about how patients with diabetes, like when they have rising creatinine, we also have to like rule out other differentials. So I'm thinking that, like, and I may have missed this from your presentation. So, how was this patient managed? Like, what was the management protocol when, like, following the renal biopsy?
So when the patient arrived and when we took the history, she and on examination, since she was hypertensive and presented with bipedal edema, so we sent the all the lab investigations, the routine lab investigations with serology along with the CT or pelvis was done. On CT, she was normal and no anomaly or abnormality was found. While on serology, the main changes were seen on her urinary examination, which was proteinuria and hematuria, and on the serology. And in serology, only p-ANCA was highly positive, which attributed to the p-ANCA associated vasculitis. So the further
Then, like,
investigations like renal biopsy was performed.
yeah. So after the renal biopsy, like, what was the treatment plan for her? Like, that's what I'm getting to.
So the treatment regime started. We started with immunosuppressive therapy, and we started the corticosteroids, which included initially we gave her IV methylprednisolone, and then we tapered her down to oral prednisone.
Okay. And what was I'm wondering if there's any follow-up for this patient. Like, what was her follow-up status at maybe like 1 year post-treatment? Like, did she respond to treatment? Does she have follow-up creatinine
Yeah,
value?
she responded to treatment, and as we discussed with our seniors, at that time, if she had not been treated, she might have landed up in more severe condition and might have landed to death also. So that is the case.
So by responding to treatment, like, I imagine that you mean she maybe had follow-up serum creatinine values and they began to decline or something like that. Am I right?
The serum creatinine started to decline, but she remained dialysis dependent.
Okay. I see. So this will be maybe this may be a good candidate down the line for renal transplantation or something like that.
Yeah, like we have just had the 6 months on 1 and over 6 month follow up. These were the follow-up reports. We'll be following her up further also.
Okay, all right. Thank you so much. I was just trying to get more picture about her long-term response to treatment and like her current status. Thank you so much for your presentation.
Thank you.
Right, Dr. Versha, do you have anything else to add?
Yes. Hi. I want to know what other causes of rapidly progressive glomerulonephritis did you exclude, and how?
Okay. So actually, I was just junior student who was working on it, and my seniors were actually working on this case. And the DDs that we formed were obviously initially that was related to diabetic nephropathy, but then when the serology came up, we started associating it with obviously the ANCA-associated vasculitis. And yeah, these were the main DDs. We initially attributed her to diabetic nephropathy only, but later on in serology, the correct diagnosis of focal crescentric diabetic glomerular nephrosclerosis were made.
Okay, good. Thank you.
Thank you, ma'am.
All right, thank you both judges. I believe that there are no further questions. Thank you once again, Hargun, for that wonderful presentation. We'll now be proceeding to the code. We will want to remind everyone to please scan the code in front of you, and as well as our judges on filling the form that were given to you earlier. We would like to remind that all our awards will be given just right before the closing ceremony today. All right. For our next presentation, we would have Shurjana Rao. She'll be presenting on the when CPR fails, the open ring sign as a diagnostic anchor in Probelo HIV-Associated PML, a case report. Hello, nice for you to join us.
Okay, so I'll be presenting a case entitled When PCR Fails, the Open Ring Sign as a Diagnostic Anchor in Probable HIV-Associated PML, a case report. To give you a brief background of the case, PML is a demyelinating CNS disorder that is caused by the reactivation of JC virus in immunodeficient patients. It carries a prevalence of around 2 to 4% in those with HIV/AIDS and has a meager survival rate of less than 50% at 12 months, making it highly fatal. Early diagnosis then becomes the most important step for initiating timely treatment in order to save a patient's life. The definitive diagnosis of HIV-PML, however, requires either histopathological evidence from a brain biopsy or compatible clinico-radiological features, both combined with positive CSF JC virus PCR. But the clinical reality, however, is quite often more complicated because even advanced HIV patients can have normal baseline blood leukocyte counts, and CSF JC virus PCR can yield false negatives. So clinicians must resort to advanced neuroimaging to serve as diagnostic anchors in order to initiate life-saving treatment on time, especially when molecular testing fails. Coming to the case itself, this case involved a 29-year-old female who was a known case of intellectual disability and kyphoscoliosis belonging to low socioeconomic status, who presented with a 15-day history of low-grade fever, severe generalized pulsatile headache, and static weakness in the left-sided upper and lower limbs. She had no major meningeal or seizure-related symptoms and no past history of focal neurological deficits or transient ischemic attacks, which made the presentation highly non-specific. On examination, the patient had right-sided ptosis and diplopia with right-sided facial deviation. The power on left-sided upper limb was -4 at both the shoulders and elbows, and 3 and -4 at the hip and knee, respectively, on the left-sided lower limb. These focal deficits suggested a central nervous system lesion, but the initial picture was still very much non-specific. In reality, the patient had been referred with a misleading diagnosis. Her initial MRI and blood work were reported as being suggestive of an infective etiology, and she was referred with a suspicion of tuberculous meningitis. That was the first major pitfall in this case that delayed the diagnosis. Therefore, the initial investigations that were run were mainly for tuberculous meningitis, including chest X-ray, ECG, USG, and CB0 for sputum and CSF, which were all negative. CSF examination studies were also done, and their results have been displayed for reference. It showed raised protein and leukocyte counts with lymphocytic predominance. However, microbiological studies, especially Zn stain and cobwebs, were still negative, effectively ruling out TBM. This put the clinicians in a diagnostic limbo, where the only saving grace became the routine HIV screening test, which came back reactive for HIV-1 at just the right time and allowed for the crucial PLHA diagnosis to be made. Repeat blood hemograms then reported a newfound lymphopenia with a low CD4 T cell count of 159 cells per cubic mm, effectively confirming the diagnosis of advanced HIV infections. This positive HIV status then guided the clinicians towards a new set of differentials to consider for neurological presentation in AIDS. Therefore, additional CSF tests, including JC virus PCR, RPR, and cryptococcal antigen, along with serum torch studies were performed, but they all came back negative, which further complicated the case. The turning point in the case came when follow-up MRI with spectroscopy was done, which revealed extensive hyperintense lesions in the periventricular, subcortical, and juxtacortical white matter on T2-weighted FLAIR images. Additionally, on post-contrast T1-weighted imaging, a characteristic peripheral open ring enhancement was found, which has shown to be a hallmark of demyelinating CNS disorders. Diffusion-weighted imaging was also done, and it showed the presence of a lesion in the right high frontal gyrus with restricted diffusion on DWI and corresponding reduced intensity on ADC images, representing the active leading edge of demyelination. MR spectroscopy was the final nail in the coffin because it ended up revealing choline and AA inversions in the brain, which have shown to be highly consistent with active demyelination and neuronal loss. Taken together, these imaging findings strongly suspected PML despite the negative CSF result. Therefore, based on clinico-radiological correlation, the patient was diagnosed with possible HIV-associated PML and started on TLD therapy after ruling out TB, along with prophylactic TMP-SMX therapy. The patient was unfortunately discharged with leave against medical advice, although with a strong emphasis on regular follow-up to monitor for immune reconstitution inflammatory syndrome. This case highlights two diagnostic pitfalls. First, HIV patients can present directly with advanced disease, even when routine blood counts appear normal. So HIV screening should not be delayed in high-risk cases because it can reveal important clues for diagnosis. Second, JC virus PCR can yield false negatives since it only has 74% sensitivity without ultrafiltration. So the diagnosis in such cases might depend on characteristic MRI and spectroscopy findings, like the post-contrast T1-weighted open ring enhancement, T2-weighted FLAIR hyperintensities, and MRS markers that can help to diagnose PML in HIV patients. This is highly important if you want to initiate life-saving treatment on time. To conclude, I would once again like to emphasize that, like demonstrated by this case, in HIV PML, the diagnosis is not always declared by a CSF PCR result. Sometimes it is uncovered by a routine screening test and by pattern recognition and clinical judgment, and that difference can define a life-saving outcome for the patient. These are my references. Thank you so much for listening to my presentation. I would be happy to answer any questions.
Great presentation and an interesting case report. We will be having our judges join us. That will be Dr. Franklin and Harinee. Just wait a minute. All right. Hello, Dr. Franklin and Harinee.
Yes. Okay. Yeah, I could go first. Thank you very much, Jimena, for your very insightful presentation. Just like reminding us to be very thorough in our workup for patients when they come in with CNS symptoms. So yeah, this is what I'm thinking. Like, and I'm not sure if I missed this in your patient's history. Did is this like a first diagnosis of HIV for this patient, or she was previously known to have HIV and she did not she did not say that during her during history taking? Like, is this her first presentation or her first diagnosis of HIV?
No, she was not previously diagnosed with HIV. She was diagnosed at presentation after we did the routine screening test.
Okay, all right, okay, I see. Because this is just going to help me like frame it to understand that, like, so that means I would imagine that like after her diagnosis, she had other like workup, like chest X-rays and other things to like look for opportunistic infections, right? She would have had like a chest X-ray done during this hospitalization and things like that.
I'm sorry, I didn't get your question.
Yeah, I was just like trying to make sure that like I'm just trying to check that since this is her first diagnosis, she would have had like other workups done, maybe like a chest X-ray, LFTs, and other things done as a first.
Yes. She was initially referred as being suspected of having tuberculous meningitis by a primary care physician. And so the initial investigations that we did at our center were mainly to find out if she actually does have tuberculous meningitis, but we ended up finding out that she did not.
Okay. Yeah, like it was a great presentation, and I think you were very thorough. So I don't have any further questions regarding the patient's management. Yeah. Has she been seen or she's lost to follow up? Like, what's the most current information you have about her? Like, any ideas?
Yeah, she has unfortunately become lost to follow up.
Yeah. Okay. All right.
Yeah, thank you very much for the presentation. It was very awesome. I just want to, I don't know whether you look at differential diagnosis. I mean, conditions that can share the same symptoms with what you've already done. I don't know whether you look at that in the study.
It seems that we might not have her on the platform right now. But you may leave your concern. Oh, okay, she's back. Please wait for a minute. Let me bring her out. Hello,
I'm back. So sorry, I got disconnected.
Yeah, my question is, I don't know whether you look at differential diagnosis. I'm talking about the conditions that share the same or similar symptoms with this condition you're presenting. Do you look at that differential diagnosis?
Yes, when we found out that the patient actually indeed has HIV, we formulated a set of differentials to consider for neurological presentation in such patients. Like we thought she might probably have toxoplasmosis or cryptococcal meningitis. So we did all the CSF studies and serum torch studies to rule out those conditions. And when we found out that they were all negative, we then tried to do a follow-up MRI with spectroscopy. And those results suggested demyelinating etiologies. So then we went ahead with the diagnosis of possible PML.
Okay, thank you.
Thank you so much for your question.
Thank you so much, judges, and as well as our presenter. We'll now be proceeding to the code. All right. So we do want to remind everyone to please scan your code in front of you right now, as our awards will be presented just before the closing remarks today. And for our judges, please do fill in the forms that were given to you previously. Moving forward, we will be having Yas Hasvi from India as well. And she will be discussing on the super-refractory status on epilepticus, on paraneoplastic autoimmune encephalitis associated with ovarian teratoma, a fatal case report. It's another case report with a very hard pronunciation, so we'll be having her discuss on that. Nice for you to join us.
Hello, good morning everyone. I'm Yashasvi Sangvi, final year medical student from BJ Medical College in Ahmedabad, India, and today I'll be presenting a case on super-refractory status epilepticus in paraneoplastic autoimmune encephalitis associated with ovarian teratoma. Let's start with a brief overview of the condition. What is autoimmune encephalitis? It is a group of inflammatory central nervous system disorders occurring due to breakdown of immune tolerance against specific CNS antigens. AIE could be idiopathic, can occur post-viral infection or as a paraneoplastic complication. Tumors that are routinely encountered in paraneoplastic autoimmune encephalitis include lung, breast, ovarian, testicular, and other abdominal tumors. Let us talk about AIE in ovarian teratomas specifically. Ovarian teratomas are consistently associated with anti-N-methyl D-aspartate receptor encephalitis involving the production of immunoglobulin G against NMDAR found on neuronal membranes in the hippocampus and the forebrain. It is a rare disease considering that the incidence of anti-NMDR encephalitis is only 1.5 per million per year. The condition initially can mimic a viral prodrome or very classically a psychiatric illness. Frank neurological symptoms such as seizures, movement disorders, catatonia, memory loss, impaired cognition may occur very much later in the disease course. Important diagnostic modalities include EEG, brain MRI, serology or CSF analysis for autoantibody detection, and CT scan for tumor detection. The mainstay of the management is surgical tumor removal. First-line therapy involves plasmapheresis, steroids, and IVIG. Second-line management involves immunotherapeutic agents such as cyclophosphamide. What is super-refractory status epilepticus or SRSE? It refers to seizures that persist for 24 hours or more after starting the anesthetics, including the seizures that recur after stopping the anesthetics. Anti-NMDR encephalitis can be complicated by super-refractory status epilepticus. It is a state of neurological urgency accompanied by profound mortality. Here is the management guideline for SRSE. Antiepileptics such as phenytoin, valproate, levetiracetam, along with anesthetics such as midazolam, ketamine, and propofol are to be administered. If seizures persist for 24 hours or recur after 24 hours of weaning the anesthetics, certain additional therapies may be considered such as inducing hypothermia, immunotherapy, resective brain surgery, brain stimulation, ketogenic diet, pyridoxine and magnesium infusion, or CSF drainage. With these brief background in mind, let us move on to our case. A 39-year-old, previously healthy female developed 3 episodes of seizures on a single day, involving involuntary movements of all 4 limbs with tongue bite and mild fever. She was later stable for the next 11 days, after which she developed irritability, behavioral abnormalities, and reduced responsiveness. The behavioral abnormalities were considered as a purely psychiatric illness by the family until reduced responsiveness prompted their attention, and later they brought her to the medical center. She was brought to a local hospital in an unconscious state, and Glasgow Coma Scale at presentation was 9, G2V2M5. While she was being evaluated, the patient had continuous seizure activity and was managed with phenytoin at the local hospital. The patient and her family decided to continue further management at our hospital. These were the investigations that were carried out in this case. EEG during hospitalization at the local hospital revealed no significant abnormality. T2-weighted brain MRI revealed mildly swollen left hippocampus, as is marked in the figure. CSF analysis revealed elevated protein and cell count, normal glucose, and negative microscopy for the organisms. Virological analysis was normal. Considering that MRI revealed limbic encephalitis and the virological analysis was normal, the differential shifted to an autoimmune etiology, for which a CSF autoimmune encephalitis panel was done that revealed the presence of anti-NMDR antibodies. This prompted the search for an underlying malignancy, for which a CCT of the abdomen and pelvis was done, which revealed an approximately 37 into 37 into 35 mm size right ovarian dermoid cyst, as is marked in the figure. Following the diagnosis, the patient was started on methylprednisolone, IVIG, and cyclophosphamide. Antiepileptics, levetiracetam, valproate, and phenytoin were ineffective in achieving seizure control. Midazolam, ketamine, and propofol were used to sedate the patient. The patient was intubated and provided with oxygen therapy. The anesthetic therapy was not able to achieve seizure control, and with no sustained control beyond 24 hours, the patient had progressed to super-refractory status epilepticus. Unfortunately, despite aggressive management, the patient died due to cardiorespiratory arrest before the tumor resection surgery could be performed. This case underlines the importance of maintaining high clinical suspicion for paraneoplastic autoimmune encephalitis in female patients with psychiatric presentations followed by uncontrolled seizure activity. This being said, early diagnosis is imperative because immunotherapy and surgical tumor removal dramatically improve clinical outcomes. Finally, as is seen in this case, delayed tumor management contributes to rapid disease progression and profound mortality rates. So this was our case on super-refractory status epilepticus associated with paraneoplastic autoimmune encephalitis and ovarian teratoma. These are the references of the case study. Thank you for your time. Thank you for listening.
Another interesting case on presentation. Now let's wait for our judges to join us on the platform, Dr. Mustafa and Harinee. Dr. Harinee, you may proceed.
Yeah, thank you very much. Can you hear me?
Loud and clear.
Yeah, very good. Thank you very much for the presentation. It is very, very wonderful presentation. You said that there was no evidence of change in EEG in the patient. I'm just looking at it. Is it that maybe the timing? Maybe that is the reason why you couldn't find any changes in the EEG. I don't know whether you put into consideration timing when you were doing the ECG. Sorry, when you were doing the EEG. I mean, not the ECG, EEG. I don't know whether you put into consideration the timing. That's my question. That's my first question. Can you answer that first?
Yes. Okay. So, yes. Okay. So yes, EEG findings were non-significant, and in autoimmune encephalitis associated with anti-NMDA resistance, it is a common finding for EEG to be negative or show non-specific findings. Also, the reason could be because EEG was done very early in the disease course, and later on the MRI and CSF autoimmune encephalitis panel revealed presence of antibodies as well as limbic encephalitis. So the dependence on EEG in this particular condition was less compared to those two investigations, that is the MRI and CSF autoimmune encephalitis panel.
Okay, now I was going to ask, did you do evoked EEG? Evoked EEG. Did you do that?
No, because actually the patient was immediately referred to our medical center, and the EEG was performed the similar day only. So there was no need for a repeat EEG.
I mean, evoked EEG. Evoked EEG. I mean, did you do that? Did you do evoked EEG for the patient? Hello? Can you hear me?
Sorry, I was not able to hear you.
Yeah, I said that I was talking about evoked EEG. Evoked. EEG in response to stimuli. Certain stimuli. Did you do that kind of? Did you go to that extent?
Hello.
Can you hear me?
So sorry, actually your voice, I was not able to hear you. Can you repeat your question?
Yeah, I said, yes. I said, did you do evoked EEG? Evoked EEG. EVOKED. Evoked EEG. Okay, no problem. Don't worry about that. I think I'm done with the question. Justin.
Now we'll move on to Dr. Mustafa, who will have the comments as well on Dr. Harinee's question earlier.
Okay, so thank you, doctor. Do you hear me? Am I clear?
Loud and clear.
Is my voice clear? Yes, thank you. Firstly, I would like to thank you for this great presentation. Actually,
Um,
this is one of the most notoriously rare case reports. It will be my first time encountering such case. I have three questions regarding the clinical sequelae of this patient. Firstly, when the autoantibodies were requested, was autoimmune induced encephalitis? Was it in mind? Were you putting it in mind to be to find NMDAR antibodies, or it was an accidental finding? And secondly, what was the indication for doing abdominal CT for this patient? From your presentation, there was nothing clear. My last question is regarding the SERS. The, is she with us? Do you hear me?
Yes, she is here. She just have the video off to ensure audio quality. Doctor, could you just state one
Okay.
question at a time? Could you repeat the first one, please?
can I request you to please repeat your question?
Okay. The first question was, when you were conducting the autoantibodies screen, were you putting on mind that you will be finding NMDAR antibodies, or it was an accidental finding?
Okay, so as much as I could hear you, I think your question is that when we did the CSF autoimmune encephalitis panel, was the goal to find antibodies or so? As the patient presented, there were four differentials in mind: CSF, autoimmune encephalitis, viral encephalitis, toxic encephalitis, and metabolic encephalopathy. No, the history did not reveal any toxic exposure in recent past, so that was ruled out during history taking. Also, the routine workup did not reveal any metabolic abnormality that could have prompted the encephalitis. Later, the major differential left was virological encephalitis, which was ruled out with prompt virological analysis. And the last differential that we could think of was autoimmune encephalitis. And the first line investigation, whenever autoimmune encephalitis is being considered, is always an CSF autoimmune encephalitis panel. If that reveals antibodies, we go for a CECT to search for underlying malignancy that can produce the antibodies. And so this was our whole workup sequence.
Okay, that is sufficient. Okay, for the last question, regarding the control for the status epilepticus, as the literature is saying, the better control is to put the patient in a medically induced coma, as the control is very difficult. Was that done for this patient, or what was happened?
Yeah, so firstly, the seizures were tried to be controlled with anti-epileptics, but the patient was not responding to them. The best that could be done is inducing a coma with anesthetics, as you said. However, the disease had progressed so much that the patient was not able to respond to anesthetics as well, despite trying three anesthetics: midazolam, ketamine, and propofol. So the next step, actually the mainstay of the treatment is surgical removal as soon as possible. But for that, a prerequisite is that the patient is in a certain stable condition, which was not able, we were not able to achieve that stable condition with the help of anesthetics here. And before any further steps could be taken or any additional therapies could be considered, the patient had a cardiorespiratory arrest and passed away.
Okay, thank you so much. That's all from me.
Thank you so much.
Thank you, doctors, for those suggestions and questions. Now we will be proceeding to the code. We would like to remind everyone to please scan the code and vote for most preferred presenter. And as for our judges, please do fill in the forms that were given to you previously. We will be announcing all awards just right before the closing remarks today. So we do hope everybody will be joining us up to the end of our conference. All right, up next, we would have Sarah from the College of Health Sciences, University of Ilorin, Nigeria. And the pre-recorded video would be on the retained epidural catheter, a rare complication of regional anesthesia successfully managed with immediate spine exploration. And for this session, we would have Dr. Franklin and Isabel as our judges.
Oreoluwa Olukorode, and I'll be presenting the case report titled Retained Epidural Catheter, a rare complication of regional anesthesia successfully managed with immediate spine exploration. Here's a brief overview of my profile. I'm a final year medical student at the University of Ilorin in Nigeria. My interests span across global health, anesthesiology, and tennis. Epidural anesthesia is a common regional anesthesia technique that is used to deliver anesthetic agents into the epidural space to produce a loss of sensation and motor function in people that are being operated on. And it's mostly used in surgeries that involve the abdominal region, the pelvic region, and the lower limb. So this involves placing an indwelling catheter into the epidural space of the patient, which allows for continuous delivery of the medication into the epidural space. It is regarded as a safe and reliable technique. The aim of this presentation is to highlight a very rare case of epidural catheter fracture and retention of the catheter in the epidural space. And I plan to highlight the importance of multidisciplinary decision-making regarding such a very rare case, and also to share the outcome of how an immediate spinal exploration and catheter retrieval was the best method in these patients. This case highlights a 63-year-old male who presented with urethral stricture following a traumatic urethral catheterization. He was prepped for an urethroplasty, he had no comorbidities, and his vitals were stable pre-op. The anesthetic technique that was chosen was epidural block. The L4, L5 interspace of this patient was identified, after which an 18-gauge Tui needle and epidural catheter was advanced into the epidural space, and it was secured in place. The surgery went on successfully. There were no complications intra-op. After the surgery, there was resistance while attempting to withdraw the epidural catheter, which raised the suspicion of a catheter kinking or an obstruction. Upon further careful withdrawal, the catheter fractured, which left about 8 centimeter fragments within the epidural space. Immediately this occurred, the patient was informed and counseled about the retained catheter fragments, and then the neurosurgery team was invited to provide counsel regarding the available management options. And based on the patient's preference, an immediate spine exploration and retrieval of the retained fragments was done. The postoperative course was uneventful. The patient was fine. There were no neurological deficits, and the patient was discharged 3 weeks after the surgery for follow-up. And during follow-up, the patient remained asymptomatic. Here is a picture of the external portion of the epidural catheter following the breakage of the 8 centimeter portion in the patient's epidural space. Epidural anesthesia is a very common anesthetic technique that requires great technical skill, both on insertion of the catheter and removal of the catheter, in order to prevent complications such as breakage. Breakage is rare, but it could occur based on a number of reasons, such as multiple insertion attempts, applying excessive force while trying to remove the catheter. The position of the patient at removal also determines whether or not the catheter could be entrapped by nearby ligaments and bony structures. Recently, it was found that manufacturing-related defects can also predispose the catheter to kinking or breakage. In our case, the catheter that was utilized was made up of a compound called polyethylene, which is a material that may not offer optimal resistance to mechanical strain compared to the other types of materials. And this could have contributed to the catheter kinking and breaking in these patients. It is important to note that an epidural catheter is a radiopaque object, meaning that when it is fractured and stuck in the epidural space, it can be easily detected on various radiological imaging tests such as the CT scan, MRI, and X-rays. However, in our case, there was no radiological imaging done because the patient was scheduled for immediate spine exploration. There is no universally accepted standard of management for a patient with a retained epidural catheter in the epidural space. Decisions that are made on whether or not to extract the retained segments are done on a case-by-case basis. Usually, past studies have shown that a wait-and-see approach is the best for asymptomatic patients with small fragments being retained. There have also been studies that have advised early retrieval of the retained segments, especially in centers that have the appropriate spinal surgical expertise. In our case, the decision to proceed with removing the retained foreign body was primarily because of the patient's preference after thorough counseling regarding the risk and the benefits of both the conservative method and the surgical method of management. Since this is a very rare complication, it is still one that could have been avoided. Literature suggests that if there is ever difficulty in removing an epidural catheter, you have to pull slowly, steadily, and softly, with the patient being in the same position they were on insertion during removal. And if this approach fails, radiological evaluation could also be performed to determine the next line of action. The fracture of an epidural catheter is a rare complication, as I've stated earlier, and it has no clear consensus on what the definitive management should be. This poses a clinical dilemma: conservative management or surgical retrieval. In order to achieve optimal outcome, it's important that a multidisciplinary approach is done, and the patient must be counseled appropriately on the risk and benefits of both methods of management. And this counseling must go on alongside following up with the patient in order to detect any complication. These are my references. Thank you so much for listening.
Another interesting case. Now we'll be inviting our judges, Dr. Isabel and Dr. Franklin, I believe. Please do fill in your concerns and suggestions for this study.
Yeah. And thank you so much to the presenter for the insightful presentation. Yeah, I think she was very clear in the presentation and everything, and even up to the follow-up of the patients following the surgical exploration. So yeah, I don't have any questions for her. Yeah, that's very insightful.
Thank you, Dr. Franklin. Dr. Isabel, do you have anything to add?
Hi. No, I don't have any questions for her either. Her presentation was awesome. Good job.
All right. Thank you both judges for these. Now we'll be proceeding to the code. We would like to remind everyone to please scan the code right in front of you and to choose your most preferred presenter. As for our judges, please do fill in the form that has been given to you previously. All our awards will be awarded just right before the closing ceremonies today. I would introduce the judges for this session. So this session, we would have Dr. Mustafa as our judge. Next up, we will have Pia De Leon. They will be presenting on another interesting case report. Welcome for you to join us. So for this session, we will be having Dr. Franklin and Dr. Mustafa as our judges. You may begin.
Good morning, everyone. My name is Pia de Leon, and I'm a fourth-year medical student at Pontificia Universidad Católica Madre Maestra in the Dominican Republic. Today, I am pleased to present our case report entitled Temporal Bone Osteomyelitis Secondary to Necrotizing Otitis Externa. This work was conducted in collaboration with Dr. Maite de Leon. Now, following into the background of this case report, Necrotizing otitis externa, also known as malignant otitis externa, is a severe invasive infection of the external auditory canal that primarily affects elderly patients with poorly controlled diabetes mellitus or other immunocompromising conditions. Unlike uncomplicated otitis externa, this infection can extend beyond the external ear canal into the skull base and adjacent structures, resulting in temporal bone osteomyelitis, cranial nerve palsies, and even intracranial complications if left untreated. Although Pseudomonas aeruginosa is the most common causative organism, the diagnosis can be challenging because the early clinical presentation often resembles a simple ear infection. The objective of this case report was to present the clinical presentation, the diagnostic workup, the treatment, and the outcome of a patient with temporal bone osteomyelitis secondary to necrotizing otitis externa, while emphasizing the importance of early diagnosis, the appropriate imaging, and prompt targeted antimicrobial therapy. Now, moving into the actual case, this case involved a 62-year-old male with a history of poorly controlled type 2 diabetes and hypertension. He presented to the emergency department with altered mental status, profuse diaphoresis, and hypoglycemia. Once stabilized, he reported persistent left-sided otalgia associated with chronic purulent uremia. In the physical examination, he demonstrated very marked inflammation of the external auditory canal and perforation of the tympanic membrane. Given his persistent neurological symptoms, he was admitted to the intensive care unit and initially was managed with empirical broad-spectrum intravenous antibiotics because bacterial meningitis was considered in the differential diagnosis. Into the diagnostic evaluation revealed elevated inflammatory markers and consistent with an active infectious process. Later, a computed tomography demonstrated erosion of the mastoid and temporal bone, suggesting skull base involvement. To further characterize the infection, a 3-phase bone scintigraphy was performed, confirming the active osteomyelitis of the left temporal bone. Now, later in the microbiological culture of the ear discharge, it isolated Pseudomonas aeruginosa, whereas the blood cultures and the cerebrospinal fluid studies remained negative, excluding the central nervous system infection. Based on these findings, the antimicrobial therapy was tailored to intravenous cefepime and topical ciprofloxacin. The patient also received strict glycemic control with insulin therapy, analgesia, and multidisciplinary supportive care throughout the hospitalization. Now moving more specifically into the imaging studies. The imaging findings shown on this slide were essential for confirming the diagnosis. Beginning with the images on the top, the 3-phase bone scintigraphy demonstrates the diffuse increased uptake involving the left temporal bone with extension toward the mastoid region. This increased uptake reflects the active bone inflammation and strongly supports the diagnosis for osteomyelitis. Then on the bottom image, number 5, which is the contrast-enhanced MRI, demonstrates the inflammatory involvement of the surrounding soft tissues, illustrating how the infection extended beyond the auditory canal. And finally, the image on the bottom next to it, number 6, this was the non-contrast MRI that demonstrates the structural changes involving the temporal bone that correlate with the inflammatory processes seen on the bone scan. Together, these complementary imaging studies confirmed the extent of the disease and helped guide the definitive management for this patient. Then, following the targeted therapy, the patient demonstrated the progressive clinical improvement. His otalgia was resolved, the purulent uremia ceased, and the inflammatory markers and the metabolic parameters were stabilized, and there was no evidence of the central nervous system infection that developed. He was discharged in a stable condition with a planned 6-week course of outpatient intravenous antibiotic therapy and a very close multidisciplinary follow-up. Now, for the conclusion, this case demonstrates that necrotizing otitis externa should always be considered in diabetic patients who present with the autologic symptoms, particularly when the symptoms fail to improve with the conventional therapy. The early recognition of this with the combined advanced imaging modalities such as the computed tomography and the bone scintigraphy allowed for the timely diagnosis of this temporal bone osteomyelitis. Furthermore, with the microbiological identification of the Pseudomonas aeruginosa enabled the targeted antimicrobial therapy, reducing the risk for the disease progression and any more serious complications. And finally, the multidisciplinary management, including the infectious disease specialists, the ENTs, the radiologists, and the endocrinologists, together with this close follow-up, it was essential to optimize the patient outcomes in this high-risk population of the diabetic patients. Thank you very much for your attention. I will be happy to answer any questions.
Thank you so much for that presentation and interesting case report. Now we will be having our judges together on the platform, Dr. Mustafa and Dr. Franklin. Is there anything or any questions that you would want to ask our participant?
Okay, let me start. Firstly, thank you, Doctor, for this nice presentation. Actually was clear, comprehensive, and on point. My question is that what is the case for the development of osteomyelitis in diabetic patients due to necrotizing otitis externa? Was there any need for some sort of surgical debridement for the infected bone, or was only antibiotics were sufficient for the management? And the second question is for the outpatient management. This patient is clearly having some sort of reduced immune system, so regarding due to his diabetes. So was he referred for the endocrinology department for further management and better enhancing his glycemic control?
Okay, thank you very much for your questions. To answer the first one, for this patient specifically, surgery wasn't needed, not for his necrotizing otitis externa. It wasn't needed initially. Basically, with the antibiotic therapy, that it was initiated with the broad spectrum one, and then later was the more targeted one. This, with the strict glycemic control, we were able to basically manage his infection. So the surgery wasn't needed. The seniors on this case were more worried about any further complications that would have later developed, but in this case, there weren't any. Now for the question about the immunocompromised aspect of the patient. Yes, he was immunocompromised due to his diabetes, but in this case, the only management needed for follow-up with the 6 week was resolved with the antibiotics. So the doctors the senior doctors didn't add any other management specifically targeted for the immunocompromised aspect of the patient. Is that clear?
Okay, thank you. Yes, it was clear. Thank you.
All right, it seems that we don't have any other questions for our participant. Thank you so much for that interesting presentation. Now we will be moving forward to our code. We would like to remind everyone to please scan the code in front of you as to vote which is the most preferred presenter. And as for our judges, please do fill in the form that were given to you previously. Up next, I would like to re-welcome Shara as she discussed her case report again. Hello once again. Could we hear you now?
Am I audible now?
Yes, we could hear you loud and clear.
Thank you. All right. So greetings, everybody. I'm Shreya Gupta. I'm a final year MBBS student at Lady Hardinge Medical College, New Delhi, India. Today I'll be discussing a case titled Idiopathic Warm AIHA in a 5-month-old infant navigating a refractory course. So autoimmune hemolytic anemia is a hematological disorder which is characterized by immune-mediated destruction of the red blood cells. It typically manifests in slightly older pediatric populations, and its occurrence within the first 6 months of life is a rare entity. The overall incidence of AIHA in children under 18 years of age has been placed at 0.8 per 1 lakh population. However, population level incidence data particularly for the infantile subgroup is lacking. I present to you a 5-month-old infant who presented with a month-long history of pallor, icterus and dark urine. Over the last 15 days, he also developed worsening respiratory distress without the presence of cough or coryza. Previously admitted at an outside facility for severe anemia and received multiple blood transfusions, but it showed no improvement and prompting referral to our center. Upon examination, the child was markedly pale and icteric, and abdominal examination revealed hepatosplenomegaly. Upon the baseline investigations, hemoglobin was found to be markedly decreased with a raised bilirubin as well as a raised LDH. Coming to the evaluation and diagnosis, when faced with a 5-month-old infant with anemia, jaundice and hepatosplenomegaly, firstly, hemolysis was confirmed biochemically with hyperbilirubinemia, raised LDH over a background of reticulocytosis. All the intracorpuscular causes were systematically ruled out with HPLC, EMA binding, enzyme assays, as well as a normal peripheral smear. Simultaneously, the direct Coombs test came out to be positive with an extended antibody panel positive for IgG antibodies, establishing warm AIHA. Now, given the rarity of presentation at this age, a very thorough evaluation was carried out for any secondary underlying etiology, which consisted of infectious workup, immunological workup, whole exome sequencing, as well as bone marrow studies, none of which revealed anything significant, and the diagnosis of primary idiopathic warm AIHA was confirmed. The following images show the bone marrow aspirate showing erythroid hyperplasia. Now, coming to the management timeline. Upon admission, the child was started on IV methylprednisolone, IV immunoglobulins, as well as multiple transfusions with the least incompatible packed red blood cells. However, there was no response, and the therapy had to be escalated to weekly rituximab infusions, despite which the child developed hospital-acquired pneumonia as well as underwent ICU management. The child only showed improvement when finally the therapy was started on a combination, escalated immunosuppressive combination therapy, which included mycophenolate mofetil, in addition to the previously used drugs. Only then the child showed gradual improvement in the hemoglobin, as shown in the graph. Coming to the discussion, AIHA in early infancy represents an exceedingly rare entity with a considerable overlap with other causes. Two key aspects define the significance of our case, the first of them being absence of an identifiable secondary underlying etiology, despite a very extensive systematic evaluation consisting of infectious, immunological, genetic, as well as bone marrow studies. In the largest reported pediatric cohort of 265 children with AIHA, infants under 1 year constituted 21% of the cases. However, primary disease accounted for only 37% of the entire cohort, indicating that idiopathic AIHA in an infant under 6 months is a very rare subset. As per the published data, pediatric cases are more commonly post-infectious or immunological in etiology. The second aspect being the disease demonstrated refractoriness to corticosteroids, IVIG and rituximab. Hemolysis persisted and the patient required mechanical ventilation. This represents the aggressive nature of infantile AIHA as well as the absence of standardized management protocols in this particular age group. The therapeutic decisions being largely extrapolated from the older pediatric or the adult populations. It was only after escalation to a multimodal immunosuppressive therapy that an upward trend in the hemoglobin could be observed, and hence early escalation should be pursued proactively rather than reactively in cases unresponsive to conventional therapy. Thank you so much. These are my references.
Thank you once again for presenting this interesting case. Now we'll be calling our judges to join us. Yeah, Dr. Imad and Dr. Mustafa. Welcome, doctors. We could start with Dr. Mustafa for our questions.
Hello, doctor. Thank you for your presentation. I have only one question regarding the other options for management of warm autoimmune hemolytic anemia, especially in such a young infant. Was the plasma exchange or splenectomy were they considered as part of management or not?
No, so splenectomy was not considered given the child was really young because of the possibility of developing opportunistic infections. And the child was eventually discharged on folic acid supplementation and MMF in addition to corticosteroids with a stable HB.
Okay, thank you.
Dr. Imad, are you there? Is there anything else you would want to add?
Thank you so much for your presentation. That was thoughtful. If you just could, regarding the design of the posters to be more visually clear, that would be great for next presentation.
Yes, definitely.
All right, it seems that all our questions and concerns has been laid on the table. Thank you again, Shara, for that interesting case. Now we'll be moving on to the code. We would like to remind everyone to please scan the code in front of your screens right now. That will help us vote for who is the most preferred presenter for this conference. And as for our judges, please do fill in the form that has been provided to you previously. All our awards will be announced just before the closing ceremonies today. All right, up next we will have Jalwa, and he'll be introducing another interesting case to us. And for this time, we will have another two judges join us in a bit. Thank
Can you hear me?
Yes, we could hear you. Please do start if you're ready.
Okay. Hello everyone, it's Dr. Jalwa Khan. I have joined the session from Pakistan, and today I'm going to present a very unusual case report of Ewing sarcoma of the infrahyoid mucosal space, the first ever reported case of Ewing sarcoma of this region. These are my co-authors you can see on the screen. So Ewing sarcoma is the second most common malignant tumor occurring in the bones of children and teens, but it can rarely occur in soft tissue. It is a part of Ewing sarcoma family of tumors, which histologically is a group of small round blue cell tumors. It mostly occurs in the lower extremity. 45% of cases have been reported in the femur. To our knowledge, Ewing sarcoma of the infrahyoid mucosal space has never been reported in the literature before, so we herein are reporting the first ever case of this region. So I don't know why my slides are not full. Okay, so a 24-year-old male who was otherwise healthy presented with a gradual onset of neck mass and dysphagia for 1 month. Over the following month, he developed dyspnea, and there was no history of neck trauma. The patient also reported constitutional symptoms such as weight loss and cachexia. Upon examination by a primary care physician, a mass was palpated in the infrahyoid region without palpable cervical lymphadenopathy. Laryngoscopy revealed a lobulated mass in the infrahyoid region, causing significant airway obstruction. So a CT scan was suggested, which revealed a poorly marginated mass, roughly measuring up to 38 into 27 millimeter on the axial assessment and 35 into 27 millimeter on the coronal assessment, centered on the infrahyoid supraglottic mucosal space, particularly the right aryepiglottic fold with extension into the posterior commissure, the right false vocal cord. Associated mass effect causing occlusion of the piriform sinus and right valleculi and marked narrowing of the airway was noted. Multiple subcentimetric bilateral cervical lymph nodes measuring up to 7.5 millimeter can be seen in the CT's images shown. Due to airway occlusion, a tracheostomy was performed to aid breathing, and the tumor was staged as CT2, T3, N0, M0, TNM staging. No PET scan was performed prior to treatment, but a post-chemotherapy PET scan done after 3 cycles of chemotherapy revealed a reduction of the mass up to 22 into 21 millimeter with the SUV uptake of 5.6 and the standard hepatic SUV uptake was 2, showing that there is residual disease. You can see in the image. The patient was commenced to do more chemotherapy, so a follow-up scan done after 6 cycles of chemotherapy then demonstrated a near anatomical infrahair supraglottic space, and the right piriform sinus is clearly visualized. This was the post 6 cycles of chemotherapy PET scan, which showed a near anatomical space. The diagnosis was confirmed on the FISH test performed on the biopsy specimen using the EWSR1 gene FISH probe to detect EWSR1 gene rearrangement in the tissue. Under the microscopic analysis, the normal cells displayed 2 fusion signals per nucleus indicating an intact EWSR1 gene and thus confirming the diagnosis of Ewing sarcoma. Treatment. After the diagnosis was confirmed, the patient commenced chemotherapy with a VAC regimen, vincristine, doxorubicin, and cyclophosphamide in a 3-week cycle, and IE regimen, fosfamide and etoposide in daily cycles at standard doses. This regime is standard for Ewing sarcoma and has shown to improve the survival rates. The patient didn't underwent any surgical resection, and after completing 6 cycles of chemotherapy was declared disease-free, although the patient is still on the surveillance. Conclusion. Despite the rarity of this unusual location, adhering to the fundamental principle of diagnosis, multimodal chemotherapy, and careful clinical management lead to significant improvement in the patient condition. These are my references, and thank you so much for listening to me. Thank you.
Thank you so much for that sharing. Now we will have our judges on our platform, Dr. Imad and Dr. Franklin. Welcome. We could start with Dr. Imad.
Hi, Jwala. Thank you so much for the presentation. Am I audible?
Thank you.
Yeah. Do you think that the chemotherapy is the single definitive treatment in this case, or in more advanced cases, we would think, or in earlier stages, we would think of surgical resection?
Yeah, surgical resection can be done, but due to this location, the patient had already had a airway obstruction, so surgical resection was not possible in this case. So that's why chemotherapy was preferred. Yeah.
Yeah. Also, would be preferred if the patient consent was reported, because I'm not sure if I heard the patient consent that was reported or not. That's it.
I couldn't understand the question, please.
If the patient consent was reported.
Yeah. Patient did.
That's it.
All right, Dr. Franklin.
Yes, so thank you very much for this very interesting presentation. Like, it's just like a rare site for Ewing sarcoma, I'm thinking. Yeah, so I'm just wondering, in terms of long-term surveillance, like what kinds of investigations, like how would we monitor these sorts of patients, like maybe in the long term for disease recurrence? Yeah.
You mean the surveillance?
Yes. What kinds of tests, or like what are the options for like just long-term surveillance?
So PET scan done after 6 cycles revealed that the patient was disease-free, but for the surveillance, PET scan is being done.
And this is going to be these annual PET scans. Like, what's the frequency of the PET scans that would be used for surveillance?
I couldn't understand the question.
Yeah, so I'm wondering, like, for surveillance, I understand that the PET scan done after treatment was fine, like it showed no residual disease. But like for the long term, you still want to do PET scans, right?
Yeah, after every 6 months.
Yeah, and how frequently will these PET scans be done? Is it like annually, or like what's the?
After 6 months.
Okay, every 6 months there will be a new PET scan done.
Yeah.
Yeah. Thank you, Grace. All right.
You're welcome.
All right, thank you, doctors. I believe that there are no other concerns or questions. Thank you again, Jalwa, for that interesting case.
You're
Now we will
welcome.
be moving on
Thank
to
you.
the code.
Okay, have a nice day.
We would like to remind everyone to please scan the code in front of you right now, as it will be helping us to choose who is the best presenter during the conference. We would also want to remind all the judges to please fill in the form that were given to you previously. All awards will be announced just right before the closing remarks, so we do hope everybody will be joining us up to the end of our conference. All right, up next we will have Husted. I'm not sure if I pronounced that right. Thank you for joining us.
Hello, can you hear me?
Yes, I could hear you, but I don't see your slides though.
You don't see my slides?
Yes.
Okay, I'll try that again.
Mm-hmm. So while waiting for the slides to come up, her case is actually a rare case on Klippel-Feil syndrome presenting with multisystemic involvement of progressive short stature. Yeah? And for
Can
this
you
session, we
see
would
my
have,
slides now?
yes, you could see your slides now. We would have still Ahmad and Dr. Mustafa as our judges of this session. You may start when you're ready.
Okay, so good morning, everyone. My name is Owusu-Ansah, and I am a fifth-year medical student from Lithuanian University of Health Sciences. And I'm happy to present you a rare case of Klippel-Feil syndrome that happened in our clinics, highlighting its impact on growth and the need for multidisciplinary management of the patient. To give you some background, Klippel-Feil syndrome is a rare congenital anomaly characterized by clinical triad consisting of low posterior hairline, a short neck, and restricted cervical mobility. Although the hallmark feature of this disorder is congenital fusion of the cervical vertebrae, it may also present with extraskeletal manifestations and additional spinal abnormalities. In our case, a girl was born at 37 weeks of gestation, low birth weight, and breech delivery. Congenital findings were clubfoot and developmental dysplasia of the hips. And at age 1, spinal MRI was performed, and it found Klippel-Feil syndrome symptoms, kyphotic deformity, hemivertebral-like changes, and sacral spina bifida, for which neurosurgical intervention was performed. Initial karyotype was normal. At nearly 6 years of age, the patient arrived having complaints of severe short stature. It was below third percentile, and you can see all of that in the growth table on the right. The patient's line is black. The BMI and growth hormone stimulation tests were normal. Suspected was only primary IGF-1 related growth impairment, which is atypical for KFS. At age 8, genetic testing was identified a small duplication of on chromosome 9 of uncertain clinical significance, but no confirmed chromosomal impairment. After 2 years, short stature and low IGF-1 persisted, scoliosis progressed, and for treatment it required a brace. In summary, despite normal growth hormone response, our patient continued to exhibit significant growth impairment and later developed a low IGF-1 levels. This raises a question about alternative growth regulating mechanisms and possible endocrine involvement beyond growth hormone deficiencies. Currently, the treatment for Klippel-Feil syndrome remains largely supportive and focuses on managing orthopedic, neurological, and other associated complications, although recombinant IGF-1 therapy has shown benefit in selected patients with primary IGF-1 deficiencies. There's currently no evidence to support its use, specifically in Klippel-Feil syndrome. Overall, this case highlights a rare presentation of Klippel-Feil syndrome with persistent short stature despite normal growth hormone secretion, together with chromosomal duplication of uncertain clinical significance and it underscores the importance of multidisciplinary follow-up and the need for further research into growth-related and endocrine mechanisms in this syndrome. And that is all for my presentation. I can take all your questions if you have any.
Thank you so much for that interesting case. We'll be moving on to the code, and I would like to remind everyone to scan the QR code right now and to choose your most preferred presenter. We would like to also remind our judges to please fill in the form based on the performance of our presenters. All our awards will be provided or shown just right before our closing remarks today. All right, moving on, we will be having Mukesh, a third-year MBBS student from the Raghda Medical College and Research Institute. She'll be sharing her case as well. Hello, nice to meet you, and thank you for joining us today. Could you please share your PowerPoint presentation? All right, while waiting, I would like to introduce his presentation is on a rare complication and calcaneal fracture in a child foot compartment syndrome. All right, we have it on.
Okay, thank you, Justin.
Thank
Okay,
you.
should I start?
Yes, for this session, we will have Dr. Imad as our judge. You may start when you're ready.
Okay, thank you, Dr. Justin. I am Mukesh Pahari, currently a third-year student at Devdham Medical College and Research Institute, Nepal. The corresponding author of the case report is Dr. Navin Pahari here. The case report title is a rare complication of calcaneus fracture in a child, foot compartment syndrome. It is a very rare condition, but it is an orthopedic emergency condition. Starting with the introduction, calcaneus fracture make up less than 0.5 of all pediatric fracture, yet they are one of the most important, that is they are 23% of the cases trigger a foot compartment syndrome. It is a life-threatening emergency that demands immediate recognition and surgery. The case was 10-year-old boy followed a road traffic accident, was presented within 6 hours post-injury. The Glasgow Coma scale was 15 out of 15, that is he was neurologically stable. The X-ray findings suggest that there was a calcaneus fracture. Open physis suggests that the bone has not fused. The immature bone of a 10-year boy. The lab report suggests that decreased level of hemoglobin and ascites, which is due to the blood sequestration. The clinical picture suggests that there was a severe pain, swelling of the left foot. The child was unable to move it. Several abrasions were present over the extremities. The tense-looking foot with painful restriction of movement raised suspension for the compartment syndrome. Is the ideal diagnosis technique, that is compartment pressure monitor was not available at our clinical setting, so the diagnosis was based on the clinical ground. For the emergency management, emergency fasciotomy was done under spinal anesthesia. Multiple medial, lateral, and dorsal-medial incisions were given. The massive hematoma was evacuated. Due to hematoma, there was decrease in hemoglobin and ascites. Multiple compartments were released, and the wound was left open for the drainage. Post-op, we have given antibiotics. Multimodal anesthesia was given. Blood monitoring was done, and close neurovascular monitoring had been done. Why early fasciotomy is everything? Before that, we should learn about the mechanism and pathophysiology of the compartment syndrome. High energy axial loading, high energy axial loading, that is a fall from a road traffic accident or any kind of injury, drives the wedge-shaped talus into the calcaneus, causing depression and broadening of bone. Due to which, what happened is there is a increase in intracompartmental pressure, which cause vascular stasis, due to which there is hypoxia, anaerobic metabolism takes place, and inflammatory cascade takes place. It was also explained by Volkmann a century years ago in the arms, but the case was in this case it was a foot. The normal intercompartment pressure is below 8 mm of Hg. The surgery is indicated once the relation with arterial pressure was disturbed. Also, the
Sorry, Muket.
in near
It
about
seems that we
10% of
don't see
the
presentation. It's just stuck on the first page.
okay.
Yeah, you might need to reshare your screen.
Okay.
Yeah, I just realized now. I'm so sorry.
No worries. Okay, I'm sharing. I think it is loading.
Yes, it may be processing. But while waiting, interesting case though. Yeah, we'll wait for it to come up. All right, while waiting for the PowerPoint to come up, we would like to remind everyone that we will be having a 10-minute break after this session. All right, here.
Is it clear
You
now?
may start. It is clear and we could see it. All right.
Okay.
You may continue.
Okay. Should I start it again? Okay, no, I restart it.
You could start from the second page and then just conclude. Yeah. And then slowly go to the third. No problem.
Okay. The case was of 10-year-old boy after a road traffic accident. The boy was presented 6 hours after a road traffic accident. The GCS Glasgow Coma scale was 15 out of 15. That is, he was neurologically stable. The X-ray findings suggest that calcaneus fracture. The open physis suggests that the skeletal immaturity of 10-year boy, that was obvious. Lab investigation, there was a decrease in hemoglobin and SCT due to blood sequestration. The clinical features: severe pain and swelling of the left foot, unable to move the leg, several abrasions over the extremities, a tense looking foot with painful restriction of range of motion, raised suspension of compartment syndrome. As in our clinical setting, there was the compartment pressure monitoring system was not available, so the diagnosis was made on clinical ground. If the diagnosis was made delay after few hours more, then the leg would rather be amputated. So the emergency fasciotomy was done. Under spinal anesthesia, a multiple lateral, medial lateral, dorsomedial incision was given. Massive hematoma was evacuated. Multiple compartments were released. Wound left open for drainage. After the operation, the patient was kept on IV antibiotics. Multimodal anesthesia and blood transfusion was done, and under close neurovascular monitoring. Why early fasciotomy is everything? Is we know that is high energy axial loading, that is fall or any trauma or RTA. What was happened in that case was the weight shaped talus into the calcaneus, causing depression and burning of the bone, due to which there was rise in intracompartmental pressure causing vascular stasis, anaerobic metabolism, due to which there was hypoxia and anaerobic metabolism took place, and an inflammatory cascade. The same process was also explained by Borgman over a century years ago in arm. This was in case of same phenomena was taken place in arm, in leg in this case. Normal intra-compartmental pressure is 8 mm of Hg. Surgery is indicated once the relationship with arterial pressure is disturbed. In about 10% of cases, the patient with fracture develop foot compartment syndrome along with the complication like toe clawing, chronic pain, weakness, and neurovascular damage if untreated. The important difference diagnosis to rule out is nerve lesion, phlebothrombosis, thrombophlebitis, vessel injury, stress fracture, soft tissue infection, ergotism. As I already told, the gold standard is in this case is handheld intra-compartmental pressure monitoring with immediate joint assessment and emergency physician and surgeon. To conclude, and key takeaway of this case report is pediatric calcaneal fractures are very rare but might lead to acute food compartmental syndrome. The earliest sign we have to consider is especially disproportionate pain and numbness. These are very critical, should be followed and was looked after for diagnosis. Compartment syndrome can develop in child even when the neurological status seems normal at first. So we have to watch out for this. Immediate fasciotomy is the main and only way to stop tissue damage from lack of oxygen. A prompt diagnosis and operating without delay is essential for the good function and outcome. Thank you, and I am open for the question.
Thank you so much for sharing this interesting case. Now we will be having Dr. Imad to join us as well.
Hi. Thanks for your presentation. This is a very interesting case, well handling the case from the presentation to the treatment. I have one question: why this fracture carries a high risk in terms of developing compartment syndrome?
Sorry, sir. Can you repeat the question again?
What do you think the causes this fracture, this particular fracture, the Klippel-Feil fracture, carries high risk in terms of developing compartment syndrome, especially in children, which is difficult to develop?
In this case, what happened there was a wake shape pressure due to which there was increase in compartmental pressure inside the fascia of the bone, due to which it leads to hypoxia and cause compartment syndrome. What happened in case of small children, it is difficult to diagnosis. As the typical like in case of in case of adult we have typical syndrome, but the child is unable to counter or interact with us and consider the syndrome with us.
All right, thank you. And if there was a CT available, would you consider doing a CT, or you would just have your clinical findings and X-ray sufficient for the diagnosis and then going for fasciotomy?
In this compartment syndrome, if we go further for investigation like CT, it might take time. As the patient was already presented after near about 5 to 6 hours in our clinic. But when if we proceed him for further investigation like CT scan, we might lose his leg. So clinical diagnosis was made and was operated as far as possible.
Thank you. And one last takeaway summary. So to inform the clinicians in terms of children with this clinical fracture, maybe the early signs that suggests the compartment syndrome along with X-rays can be sufficient in order to save the limb from being amputated. Thank you so much. That was a good, interesting case.
Thanks, sir.
All right, thank you once again, Dr. Imad, for joining us, and as well as Mukesh for that interesting case. Now we will be proceeding to the code. I would like to remind everyone to please scan the code right in front of you, as it will help us. It will help us choose who would be the best or the preferred presenter of this conference. As for our judges, please do fill in the forms that were given to you previously. All our awards will be presented just right before the closing remarks of this conference. All right, welcome back to our conference, and now we will be proceeding with the next poster presentation, starting with Naba, a fourth-year medical student at Sudan University of Science and Technology. And this will be a presentation regarding the effectiveness of methylene blue in treating vagoplesial syndrome, a systematic review, and meta-analysis. Welcome, Naba. Thank you for joining us today.
Hello everyone, I'm Naba Mahdi Sheikh Musa Ahmed, a fourth year medical student from Sudan University of Science and Technology. Today I will present my paper, Effectiveness of Methylene Blue in Treating Vasoplegia Syndrome, which is the systematic review and meta-analysis. In introduction, Vasoplegia syndrome affects 25% of post-cardiopulmonary bypass surgery patients, but its mortality is more than 25% due to nitric oxide-mediated vasodilation and catecholamine-resistant. Methylene blue inhibits guanylyl cyclase, so it can be used as brachytherapy, but evidence to support this finding is limited to small studies. Our aim is to evaluate the efficacy and safety of intravenous methylene blue cardiac surgery associated vasoplegia. Our methodology, this study design, systematic review and meta-analysis, and this figure here represents PRIMSA 2020 flow diagram. We search in PubMed from inspection to January 2026. Our population include adults more than 19 years old with post-cardiopulmonary bypass vasoplegia. Our intervention is intravenous methylene blue compared to control group. Our outcomes are: primary outcome is 30-day mortality. Secondary outcomes are vasopressor duration, ICU length of stay, mean arterial pressure, 6-hour post-intervention, and adverse effects. We use an analysis for risk of bias. Risk of bias assessment two tools for randomized controlled trials. Pooling is via random effect model. Certainty of evidence assessed using GRADE framework. Our sample size are 472 patients from 4 studies, 2 randomized controlled trials, and 2 observational studies. Our results are: for our primary outcome, 30-day mortality, methylene blue was associated with a significant reduction. Odd ratio is 0.42, 95% confidence intervals from 0.26 to 0.33. P-value is less than 0.0004. Heterogeneity was 0%, so there was no heterogeneity between these studies. Grade certainty is moderate. For secondary outcomes, we saw significant benefits. Vasopressor duration was reduced by 7.4 hours. Also, ICU length of stay also reduced by 1.4 days. Both were of high significant. P-value is less than 0.0001. Note that high heterogeneity, that is 84% for vasopressor duration, so grade assessment for these outcomes is low. It's importantly to know that there was no significant difference found in adverse effects, with odd ratio is 0.97, p-value 0.95, heterogeneity 0, so the intervention appeared safe. This figure 2 here represent forced plot analysis for 30-day mortality benefit of methylene blue versus control for the primary outcome. So we found that methylene blue significantly reduced mortality with moderate certainty, improved hemodynamics and resource use, but of low certainty. It also had consistent effect regardless of timing, either as prophylactic or recuse. It acts via inhibition of guanylyl cyclase, so reversing nitric oxide mediated vasoplegia. In conclusion, we found that methylene blue reduced 30-day mortality in cardiac surgery vasoplegia. It should be considered as recuse therapy till now, but large randomized controlled trials are needed to define optimal timing and dosing. That is all. Thank you for listening and attention.
Right. Thank you, Naba, for that wonderful case and interesting case. Now we'll be calling on our judges to join us, Dr. Mustafa and Dr. Imad. Welcome, doctors. We could start with Dr. Imad right here.
Am I audible?
Yes, you are audible. We could hear you loud and clear.
Yes, but I don't think that I can hear you as well.
Oh no.
I'll rejoin. Just a second.
All right. While we're waiting for Dr. Imad to rejoin the session, now we could have Dr. Mustafa. Dr. Mustafa, what was your concerns or any questions on the current presentation?
Okay. Am I clear?
Yes, you are clear.
Okay. I have joined a little bit late, but come through the abstract. I found the topic somewhat interesting. First, thank you, Dr. Naba, for this presentation. I have only one question, actually. It is regarding the criteria for the diagnosis of Pelvic syndrome, as it is difficult for it doesn't have a clear set of diagnostic criteria to be diagnosed. It is diagnostic exclusion. The patient should be having refractory hypertension and some sort of low systemic vascular resistance if it was measured, normal or to high cardiac outputs, with the exception or exclusion of heart failure and sepsis and other sort of hypovolemia. So, were these criteria met during the diagnosis of the Pelvic syndrome in these studies that were compared?
Yes, studies met the criteria for the diagnosis of the Vasovagal syndrome.
Sorry, Naba, was that all?
Yes, that is all. All four studies met the criteria.
Dr. Mustafa, would you have anything else to add on that?
Yes, if I may, I would like to follow up a question. Okay, for the regarding the finding for your study, what could be the future implications for the using of methylene blue as part of treatment of Pelvic syndrome? Could be used as a part of management, let's say, also only refractory hypertension, or the evidence suggesting the usage is only restricted to the Pelvic syndrome?
Can you please repeat your question?
Okay, I said what could be the future implications for the using of methylene blue as a part of regimen for management of refractory hypertension or shock, or the evidence suggesting the usage is only restricted for the for Vasovagal syndrome alone.
The study found that it can be used as a recurrent therapy for Vasovagal syndrome that is resistant for norepinephrine and others vasopressors.
All right. Dr. Mustafa, would you have anything else to add on that? We could proceed with Dr. Imad.
Yes, that is all. Thank you. Thank you, Tonaba.
Thank you very much.
Thank you so much, Dr. Mustafa, for your valuable inputs. And thanks for Dr. Noba for her presentation. I do have a set of questions. In the study, you mentioned that the heterogeneity for the mortality was unimpressive. It was actually 0. While the vasopressors duration had a heterogeneity of around 84%, right?
Yes, the heterogeneity for vasopressor duration is 84%.
Exactly. So how do you explain the difference in these outcomes in terms of heterogeneity?
Of vasopressor, some studies use the vasopressor for 6 hours and some more than 6 hours. So the variation of the duration of vasopressors between studies lead to this heterogeneity.
So included studies, we had different protocols, different timings and durations. And all right, that's reasonable. My second question would be, if you just would be able to summarize the mechanism biologically of methylene blue and how it does reduces the mortality, because we are interested in um, knowing that as future researchers and clinicians. Thank you.
Methylene blue inhibit guanylyl cyclase which increase nitric oxide. So by inhibition of it, nitric oxide amount will be reduced. So it will induce vasodilation. Inhibit vasodilation, induce vasoconstriction, and thus it can prevent vasoplegia syndrome. But this study does not conclude that it used as prophylactic, but as recurrent
Yeah.
therapy. Study need more randomized controlled trials.
Very good added point. And all right, I was about to ask you what is your follow-up plan, but you already answered that. Thank you so much.
All right. Thank you both judges for giving all your insights, and thank you, Nava, for presenting this wonderful meta-analysis. Now we'll be proceeding to the code. We would like to remind everyone to please scan the current code to choose and vote for your most preferred presenter. And as for our judges, please do fill in the forms that were given to you earlier. All our awards will be announced just right before the closing remarks today. Instead, we will have someone else share their interesting meta-analysis. Asel, Mohali, are you there? Welcome for us to join us.
Good afternoon, everyone. I am Asel Mohammed, a final year medical student from the Faculty of Medicine, University of Khartoum, representing our research team. Before we begin, I would like to ask you a quick question. How many of us have used ChatGPT or another AI tools during the past week? I imagine many of our hands would go up. So the important question becomes, are medical students learning to use AI ethically as quickly as they are learning to use AI itself? Today, I will share our findings on this question. So to have background, artificial intelligence is becoming increasingly integrated into healthcare and medical education. Medical students now commonly use AI tools for learning, information searching, and academic tasks. Although AI offers major opportunities, it also raises important ethical concerns regarding privacy, transparency, and academic integrity. So this issue is particularly important in settings such as Sudan, where ongoing challenges can increase informal learning or self-directed learning methods, including AI tools. Yet, despite the widespread use of AI, we surprisingly know little about how ethically prepared medical students actually are. Therefore, our study aimed to assess AI ethical awareness and academic integrity among medical students and identify factors associated with higher awareness. To investigate this, we conducted an institutional cross-sectional study among 349 medical students from years 3 to 6. We used an anonymous online questionnaire to collect data. We measured the ethical awareness using validated 32-item scale that covered 6 domains. The scale also showed excellent reliability with a Cronbach's alpha of 0.94. And since the scores were not normally distributed, we used non-parametric statistical test and multiple linear regression and SPSS version 27. Now let us move to the center of the poster, where the main findings are displayed. The first key finding is that students demonstrated high overall ethical awareness with a median score of 4.16 out of 5. However, what really need our attention was the difference between the individuals' domains. If you look at the bar chart, you will notice that the students scored highest in privacy and data protection, while transparency and fairness had the lowest scores. This tells us that students may understand protecting personal information well, but they are less confident about issues like algorithmic bias or understanding how AI makes its decisions. Moving on, if we look at the gender analysis, female students demonstrated slightly higher awareness than males. Now, perhaps this is our most unexpected finding. We expected formal education to play the major role, but instead, informal exposure, such as self-learning, as we said, and independent AI use showed stronger association with awareness. We also found that students who used Google Gemini and Notebook LM had significantly higher awareness scores. And in the regression model, it explained 11.2% of variance. And if you look at the horizontal forest plot, you will notice that younger age, female gender, higher academic year, informal exposure, and use of ChatGPT, also use of Gemini, predicted higher scores. Taking this together, these findings suggest that students may currently be learning AI ethics outside the curriculum faster than the curriculum itself is adapting. So in conclusion, our study demonstrated that medical students at the University of Khartoum show high ethical awareness overall, especially around privacy and accountability, as we said, but real gaps remains in transparency and fairness. Therefore, we recommend that medical schools move from the passive oversight to actively integrating structured AI ethics education, targeting the gaps we identified, and also guiding and strengthening the informal learning that the students are already undertaking. Ultimately, I would like to leave you with one final thought by returning to the question I asked at the beginning. If many of us are already using AI every day, and then our findings suggest that students are often learning to use it on their own faster than the medical education is adapting. So the question is no longer whether medical students will use AI or not, because they already are. The real question is whether medical education is preparing them to use AI safely and ethically and responsibly. Thank you very much for your attention. I will be.
Thank you so much for sharing this once again, Asel. We will be inviting our judges on the platform. We will be having Dr. Imad and Mukida. Welcome, doctors. We can start with Dr. Imad.
Thank you so much, Dr. Nathan. Thank you so much, Dr. Asil, for the presentation. Actually, it's interesting that we do research on AI, especially the ethical aspects of the AI, on the students that represent the future healthcare providers in low-income countries. I would have a question regarding the validated questionnaires that you used. How did you made it like reliable and validated on your sample size?
Okay, I already used the scales that is validated and published from a past paper.
Yeah,
Yeah.
yeah, exactly. But
Yeah,
we want to know if
exactly.
you did some sort of pilot study or if you did some sort of reliability test. We're not because you did mention a very good Cronbach alpha result, but also we need to address the reliability of this questionnaire on your sample size, if that makes sense.
No, we didn't do a blood
All
test.
right. All right,
All
that
right.
might be
All right,
a
that
point
must
to
be
consider.
that might.
There is an echo, sorry. That might be a point to consider if, in developing the study. Uh, Also, do you think that gender plays a role in terms of ethical awareness? Like, for example, even interested um, gender, like females are more interested in filling out the forms than males. Would you attribute to any factor?
Yes, it may be. So this is one of our study limitations, and to develop it, we need a longitudinal study that we can say test the real action of the and then you follow up them.
All right, thank you. And for my final
All right, thank you.
critical
And for
and
my final
this,
critical and this.
there is an echo. My final question would be, would you think that the use of AI would produce less competent doctors in the future or more competent doctors in the future?
More competent doctors if we are learn and know how to use it as possible as best as we can, and we can say less if we use that non-ethically or depend on it.
So, as an
So as an
implication of this
implication
study,
of
we
this
would
study, we would
predict
predict
the
the
awareness campaign on the ethical awareness of AI use in medical students and healthcare providers. Thank you so much. I'll give the floor to Dr. Sajid.
Sorry, Dr. Mokida, it seems that we can't hear you clearly. Yes, quite muffled on our end.
Yeah. Okay, my question is that have the author conducted any ethical awareness session for the undergraduate or postgraduate students, or they just ask about this AI questionnaire or like that?
No, we just ask.
So as we know
So
that
as
ethical
we know that ethical
is required,
is
actual
required,
first
actual.
you can ask about that, because the only AI using is not I mean asking the question about AI using it's a ethical awareness. It's not good, because if you give the first information and then you ask that, it will be helpful. Okay, that's all for this session. For next, we will wait for the new presenter.
All right, thank you both. Thank you both judges, and thank you for the presenter on the interesting analysis. Now we will be moving on to the code. I would like to remind everyone to please do scan the code and to vote for your most preferred presenter. As for the judges, we do want you to fill in the form that were given to you previously. All our awards will be announced just right before the closing remarks. So we do hope that everybody will be joining us up to the end of the session. All right. Up next, I will be re-welcoming Mariam for. Sorry. Welcome back, Mariam. We will have your presentation ready.
Hello.
Hello.
Can you hear me?
And for this session, we will have Dr. Imad and Dr. Mustafa as our judges. Yes, we could hear you loud and clear.
Okay.
Maybe you could turn off your video to have a
So
smooth
our
audio.
study is about tobacco. Okay. Okay. So our study focused on tobacco use, prevalence, and key drivers, and the impact of conflict and tobacco use among male school students in River Nile State, Sudan. In the background of this study, tobacco use remains a primary driver of multi-system disease like cardiovascular and oncological complications. And also in Sudan, we have a unique form of tobacco, which is smokeless tobacco or tumbac, and poses a severe public health risk and contributes significantly to oral squamous cell carcinoma. This risk was increased by the ongoing conflict, which was started in April 2023. This study aims to address the critical lack of localized data on adolescent tobacco prevalence and social demographic predictors in such a resource-sensitive context like Sudan. Next slide, please. Okay, this was an analytical cross-sectional study. It was a school-based survey. We conducted it in River Nile State, Sudan, specifically in Tamar and Adbara localities from May to July 2024 using multi-stage cluster sampling. 288 288 male students from the age 11 to 18 were recruited from different schools, from middle, secondary, and primary schools. Data were collected using interviews with a validated Arabic version of the Global Youth Tobacco Surveys. The primary dependent variable was the past 12 months of the study tobacco use by the students, and independent variables were the daily socio-demographic characteristics like residency, educational levels, and daily allowance given to the students, and social influences like parental and peer tobacco use. We studied the impact of the ongoing conflict as well. Regarding the statistical analysis, we used SPSS version 27. We employed descriptive statistics, chi-square test, and Fisher-exact test for association, and finally logistic regression for predictors of tobacco use. Next slide, please. This study highlighted significant results. The 12-month tobacco use prevalence was 42.7%. The primary predictors were daily allowance and the parental education. 75% did not report using tobacco daily in the past 30 days, while 25% used it daily in the past month to the study. Notably, 61.8% of the students perceive the conflict as perceive that the conflict has a negative impact on tobacco use. Next. Well, this prevalence found here exceed the rate from Sudanese and regional adolescent surveys, likely reflecting that Chumpak's culture is more prominent in Sudan, and also the inclusion of smokeless tobacco. The sample included only males, and the conflict-driven instability. Peer influence was the strongest predictor, nearly 5 times increasing the daily tobacco use, mirroring peer-driven patterns seen across Sudanese and regional studies. Unlike wealthier settings where higher allowance is protected, here in this study the high daily allowance increased the tobacco use. The high awareness, almost 75.3% of the students know about the tobacco harms. It didn't prevent the use of it, which was instead shaped by the household, the school exposure, family, and peer influence. Tobacco use has reached critical level among males in River state, and this is a consequence of social and economic factors. The findings highlight a shift in the consumption patterns influenced by the current instability in Sudan. We recommend that the public health strategies must integrate tobacco control into broader humanitarian and psychological support framework for the affected population in Sudan. Thank you.
Thank you for that presentation and interesting booster. Now we will be having our judges join us, Dr. Mustafa and Dr. Imad. Welcome, doctors. Dr. Imad, you may proceed with your first question.
Thank you so much for the presentation, Dr. Mariam. And I do have a few questions. First question would be, in your study, you've mentioned you included only males, right?
Yes.
Is there any justification or rationale behind this selection?
Well, it's the culture in Sudan does not accept the use of tobacco by females, so it was like inappropriate to ask females about the tobacco use. Specifically, especially that they are school students. We cannot ask females, so we only included males in our study.
Thank you so much. That's thoughtful. However, we can improve the study by doing the anonymity and the questionnaire we have, and then we can try to assess that in the females to basically fill the gap in the literature, because we already have this underreported in our data, especially in Sudan. So doing this would elevate your study and elevate your publication potential. Second, there is the strongest predictors in your study was, I believe, friends, right?
Yes.
So do you suggest that smokers or those who have susceptibility to smoke somehow chose similar friends with the smoking, or it is a peer influences on them, peer pressure, let's say?
I think it's more like a peer influence and pressure, specifically in male societies. Like it's more common, like a peer pressure. Students tend to ask their friends to smoke with them, or even ask them just to try smoking. So I think it's peer influence.
All right, thank you so much. I'll give the floor to my colleague, Dr. Mustafa.
Okay, thank you, Dr. Ahmad, and thank you, Dr. Mariam, for this presentation. Firstly, I have a comment regarding the presentation itself. It was a little bit crowdy. It produced a little bit of organization for future purposes. Um, Two questions actually. The first question regarding the choice of the study group. I mean, why school adolescents? I get the hypothesis behind the study is that the current war in Sudan have affected the mass majority of population and resulted in the using of substances to get over the current situation. But why the choice of school adolescents rather than general population itself?
Mariam, were you able to hear Dr. Mustafa's comment? Are you still here with us? All right, sorry, but due to the limit of time, we would need to move on. Thank you, doctors, for your questions and insights. We will have Miriam look through that during the live in YouTube. Thank you so much. Thank you again, Miriam, for that presentation. Now we'll be moving to the code. We would like to remind everyone to please do scan the code on the screen and vote for your most preferred presenter. As for our judges, please do fill in the forms that were given to you previously. All our awards will be presented right before the closing remarks on this conference. Moving on, we will be having Aditi Goyal, a medical student from RUHS, College of Medical Science in India. Hello, welcome to join us.
Hello, good afternoon. I hope everybody is doing good. So good afternoon, everyone. My name is Aditi Goyal, and today I will be presenting our study titled 6-Minute Walk Test as a Functional Screening Tool for Pulmonary Rehabilitation Referral in Clinically Treated Pulmonary Tuberculosis Patients. We all know that pulmonary tuberculosis is microbiologically cured after completion of anti-tubercular therapy. Still, many patients continue to experience persistent breathlessness, reduced exercise capacity, and poor quality of life because of the permanent structural and functional lung damage. Pulmonary rehabilitation in a lot of studies has shown to improve these outcomes. However, access to these services remains limited, particularly in resource-constrained settings. Therefore, there is need for a simple and practical screening tool to identify these patients who are most likely to benefit from these rehabilitation referrals. The objective of our study was to evaluate whether 6-minute walk test can serve as a functional screening tool for pulmonary rehabilitation referral by examining its relationship with spirometry, dyspnea severity, and health-related quality of life. So yes, this was a cross-sectional study and it was conducted at a tertiary care teaching hospital. We enrolled 120 clinically treated pulmonary tuberculosis patients who had completed anti-tubercular therapy. All participants underwent a standardized assessment consisting of 4 components. First, functional exercise capacity was assessed using the 6-minute walk test performed according to the ATS-ERS recommendations. Secondly, pulmonary function was evaluated using spirometry, with particular emphasis on FEV1 percentage predicted. Third, dyspnea severity was assessed using the Modified Medical Research Council, MMRC, or the dyspnea scale. Finally, health-related quality of life was evaluated using the SGRQ questionnaire. To determine whether 6-minute walk test could actually identify patients requiring pulmonary rehabilitation, we evaluated its association with spirometry, dyspnea, and quality of life measures. Correlation analysis were performed between 6-minute walk distance and these clinical variables. In addition, receiver operating characteristic or ROC analysis was also performed to determine the optimal 6-minute walk distance to calculate the cutoff for pulmonary rehabilitation referral. This slide summarizes our results, mostly the major findings. So in panel A, we observed a moderate positive correlation between 6-minute walk distance and FEV1 with a correlation coefficient of 0.56, which was statistically significant. This indicates that a better lung function was associated with greater exercise capacity. However, one interesting thing to notice is that FEV1 explained only 31% of the variability in walking distance. This finding suggests that resting spirometry alone does not completely reflect functional impairment after tuberculosis. In panel B, 6-minute walk distance showed a significant negative association with MMRC dyspnea scale. As the dyspnea severity increased, walking distance progressively declined. Similarly, panel C demonstrates a significant negative correlation between 6-minute walk distance and SGRQ score. Patients with poorer quality of life achieved shorter walking distances. Overall, these findings indicate that 6-minute walk test does not reflect only pulmonary function, but also symptom burden and quality of life, providing a broader assessment of the functional status. And I'm so sorry, I'm not. Okay. To evaluate the diagnostic utility of the 6-minute walk test, ROC analysis was also performed, and the analysis identified a cutoff of 345 meters as the optimal threshold for pulmonary rehab referral. At this cutoff, the test demonstrated a sensitivity of 92.5% and a specificity of 75.8% with the area under curve of 0.88, indicating overall good diagnostic performance. These findings suggest that the proposed cutoff can effectively identify patients who may benefit from pulmonary rehab while maintaining reasonable specificity in resource-limited settings. In conclusion, the 6-minute walk test is a simple, inexpensive, and practical functional assessment tool. It complements spirometry by capturing exercise limitation that may not be fully reflected by the resting lung function alone. Our findings support the use of a 345-meter walking distance as a potential screening threshold for pulmonary rehab referral among clinically treated pulmonary tuberculosis patients. Thank you so much for your attention. I would be happy to take any questions.
Thank you once again for sharing this very good analysis. Now we'll be calling our judges to join the platform right now, Dr. Mukita and Dr. Mustafa. Welcome, doctors. Mukita, you may start.
Okay, Dr. Aditi, your study is good, and now we see that 6-minute walk test is using the pulmonary function test in the many of the pulmonary disease. So I have one question that you are selecting the clinically treated pulmonary tuberculosis patient. Is there a patient is previously before the diagnosis or maybe during the before the start the treatment, if they have already passed this test? And second thing is like what is have any other comorbidity or maybe another pulmonary disease are there or not? Have you checked that one?
All right. So yes, sir, our exclusion criteria included any of the patients who will be incapable regarding pulmonary diseases, musculoskeletal dysfunctions, or any pulmonary disease that might impair them to perform the test. And regarding we should do it before the diagnosis, we had actually gone through the review of literature, and a lot of studies have tried to conduct pulmonary rehabilitation along with the treatment, and this hasn't shown good results. That was the reason we chose post-treatment patients.
Okay, so you already exclude that things before you're starting. Okay, and
Yes.
after the completely treated, means there are like around like MDR-TB or any. You have any differentiation about that
Yes, yes.
DR-TB or
Yes,
MDR-TB?
we have differentiated it. We have differentiated the drug sensitive TB patients and their TB patients, and we will be presenting it as our secondary analysis.
So any differentiation between the drug sensitive and drug
Yes.
resistant TB patient about?
Yeah, there's a huge difference between the functional capacities. The drug resistant patients showed lower functional capacities, a lot more.
Okay.
Thank you, Dr. Mukita. Dr. Mustafa, is there anything else you would want to add?
Okay, thank you, Dr. Aditi. I actually have no question. Just a comment. I really like this topic because as a healthcare professional, I specialize in TB, in tuberculosis, and the fact that you are doing such great work and in really an underdeveloped say a very interesting area, and I would really like to, if you could share the full study with us, it could be of some significance. Thank you again.
I'm so sorry, the audio was breaking for me a little. But thank you so much.
He wanted to encourage you on this study, and he really liked your
Thank
work.
you
So
so much.
he
It
hope
really
that
means.
he hope that they will be able to see more of this and the full study in the future. Maybe in the future you do get collaboration since he was also in this field. Thank you again, doctors, judges, and Dr. Aditi. We'll be moving on to the code.
Have a good day. Thank you.
All right, we would like to remind all the judges to fill in the forms that were given to you previously, and as well as our audiences to please scan the code and choose your most preferred presenter. All right, up next we will have Dikshita. I'm not sure if I pronounced that right, but welcome to join us. Dr. Dikshita, are you there? If connectivity issues are there, you may turn off your video to have a smoother audio.
Yeah, I am here. I'm sorry, I've
All right.
forgot muting me. Yeah.
Not a problem. For this session, we will have Dr. Imad and Dr. Makita as our judges. You may start if you're ready.
Sure, thank you. So good morning to the judges and everyone watching. This is Deekshita, and today I'll be presenting on Lexacaftor, Tezacaftor, and Ivacaftor. So as you all know that cystic fibrosis is a disease where a single gene mutation disrupts an entire organ system, turning completely normal secretions into relentless and thick mucus. So over the past few decades, the management of cystic fibrosis was heavily reliant upon addressing the consequences, that is through airway clearance mechanism, treatment modes, or through chest physiotherapy, or through bronchodilators. But the CFTR gene modulator therapy has been an absolute game changer when it comes to the treatment of cystic fibrosis, because it shifted our attention from addressing the consequences of cystic fibrosis to treating the actual underlying molecular defect associated with that. So when it comes to these gene modulating therapies, the various dual combination and triple combination therapies available, and which proves that the therapeutic landscape in the field of cystic fibrosis is quite evolving. So this study analyzes the efficacy and safety of one such triple combination therapy, that is Lexacaftor, Tezacaftor, and Ivacaftor, in the patients with cystic fibrosis through a meta-analysis of randomized control trials. Now, speaking of the methods, so the databases that have been searched for performing this meta-analysis are PubMed, Scopus, and Web of Science. And the disease terms are given here, and the search terms are categorized into three different groups. That is the disease terms, which includes cystic fibrosis and people living with cystic fibrosis, and the treatment terms being Lexacaftor, Tezacaftor, and Ivacaftor, and also the common name that is given to this particular triple combination, that is Trikafta, and VX445 Tezacaftor, Ivacaftor, which is another name for Lexacaftor. And the study terms being randomized control trials. So all the randomized control trials which evaluate ETI in the patients with cystic fibrosis have been included. And the data that has been extracted for this study are the baseline characteristics, the efficacy outcomes, and the adverse effects. And also the risk of bias analysis have been performed using the Cochrane ROB2 tool. And the statistical analysis was performed using the Revman 5.4 software and using a random effects model, where the effect estimates were expressed as mean difference or risk ratios depending on the variable that has been dealt with. And the statistical subgroup analysis has been performed wherever there was heterogeneity. Now, speaking of the results, so this study included 6 randomized control trials, including a total of 1,187 participants, of which 608 were administered the intervention, that is Lexacaftor, Tezacaftor, and Ivacaftor, and the control group constituted 579 participants. So ETI was found to be significantly associated with an improved lung function, which is demonstrated by an increase in the forced expiratory volume percentage, and also an improvement in the CFQR score, which is the cystic fibrosis questionnaire, and also a significant reduction in sweat chloride concentration has been found. So the most frequently reported adverse effects in this using this intervention are cough, followed by headache, infective pulmonary exacerbations, as well as increased sputum. However, there hasn't been any statistically significant relation between the intervention and the control group in terms of the incidence of the adverse effects. And on performing the subgroup analysis based on the dosage of ETI and the treatment duration for which it has been administered, there hasn't been any significant impact on the treatment outcomes. Now, coming to the discussion, so Lexacaftor, Tezacaftor, and Ivacaftor, it restores the CFTR function through various complementary mechanisms. So one such is where Lexacaftor and Tezacaftor improve the CFTR protein folding and trafficking, and Ivacaftor mainly enhances the CFTR channel opening, which results in increased transport of chloride across the receptor into the cell. So our findings demonstrate a significant improvement in the lung function, which is demonstrated by an increase in the forced expiratory volume, and also an improvement in the quality of life through increase in the CFQR score, and an improvement in the CFTR function has also been demonstrated by a reduction in the sweat chloride concentration. And these results have been consistent with the findings of the previously published randomized control trials. So ETI therefore exhibited a favorable safety profile as well, because the adverse effects relationship of the incidence of them were not any statistically significant between the control and the intervention groups. So these findings support ETI as an effective treatment option for patients with cystic fibrosis carrying at least one F508 deletion allele. So with that being said, I'd like to conclude by emphasizing the fact that although Elixir, Teza, and Ivacaftor are associated with higher upfront costs, its ability to reduce the overall hospitalization or healthcare utilization, exacerbations that support its long-term effectiveness as a treatment for ETI, and also reinforces the fact that it should be used by the patients with cystic fibrosis as a viable treatment option. Thank you. I'm open to any questions.
Thank you once again for that. We will be bringing in Dr. Mukhita and Dr. Imad. Welcome, doctors. Dr. Mukhita, you may start with yours.
Dr. Dikshita, it was a good study, but my question is that about cystic fibrosis. You know which is the commonest organism related to cystic fibrosis? Which one?
Yes. It depends upon the age group. Like if it is the older population, then Pseudomonas is the most commonly associated one, and the younger population, it is the Staph aureus. If I'm not
okay. So in your Pseudomonas is the most common for everything. So have you checked for your patient for the Pseudomonas infection, and is there any differentiation between the both groups which have a Pseudomonas infection or any other bacterial infection?
No, doctor, not Dr. Mukhita. There hasn't been any difference based upon the infection of the patient. It has shown a pretty similar result, but the overall reduction also was not found. It did not have any impact on reducing the infection in patients with cystic fibrosis. In that aspect, it wasn't useful, but the other lung functions, it has definitely shown an improvement.
Okay. Yeah. Dr. Imad, you can ask your question.
Thank you, Dr. Sajid, for your comments. Thank you for the presenter for this outstanding study. I actually liked how you interrupted the risk of bias assessment and how you did all of the necessary methodology for systematic review and meta-analysis. Was the age specified in your sample? Like, was it inclusion criteria? Did you have a certain age for the patients?
No, not Dr. Ahmad. There hasn't been any age but related criteria, because most of the studies had even included people, like patients from the pediatric age group. So it was inclusive of all the age groups.
All right. So my other question would be, was your subgroup analysis pre-specified, or you did specify them accordingly after you extracted the data and did the primary analysis?
Yes, it has been conducted following the preliminary meta-analysis based upon the heterogeneity, and we have grouped them based upon the dosage of ETI and the duration for which it has been used.
All right, and you've mentioned in your discussion that it's cost effectiveness, right?
Yes.
Did you measure that, or you just out of your literature review you found that, or based on the market? What do you think about this?
That wasn't researched upon, Dr. Imad. It was based upon because the general notion is it is an expensive treatment modality for the patients with cystic fibrosis. However, the other factors like its impact on the lung functions and the other aspects should be taken care of when actually the physicians would be deciding whether to opt for that as a treatment option or not. So that was based upon the literature review.
Well, following a large systematic review and meta-analysis, you're now well aware of the literature, the knowledge gap, the RCTs, whether they were sponsored or not. So what do you recommend, for example, the future research in this drugs indications?
Yes, Dr. Ahmad. So I think there are various combination therapies available out in market. So it would be really important for us to know what has to be given at which point, because even the genetic analysis would play a role here. based upon the mutation involved. Like if it is a homozygous mutation, then it is a dual therapy that would be chosen. And if it's a heterozygous mutation, then a triple therapy. So first, it is quite important for the physicians to be aware of the combination that they'd be using. And also, I think, given the promising results, it would be quite beneficial in early stage cystic fibrosis and also the advanced ones for initiating a gene modulation therapy instead of just relying upon the measures which only address the consequences of it, that is the mucus clearance and stuff. And also, I think that would prevent the progress of the disease, and also would be helpful before the final treatment mode could be opted for, that is the lung transplantation, which is the ultimate mode that could be opted for.
Thank you for both excellent methodology and excellent study presentation.
Thank you so much. Thank you.
Thank you both judges, as well as the perfect, very, very great presenter. All right, so we'll move on to our code. We would like to remind everyone to please scan the QR code and to choose and to vote for our most preferred presentation. As for the judges, please do fill in the forms that has been given to you previously. We'll be announcing all the awards just right before the closing ceremony. Up next, we would like to welcome Harinee Murugan. I'm not sure if I pronounced that right. Welcome to join us.
That's correct.
All right.
Yeah. Hello, everyone. I am Harinee, an intern from Pondicherry Institute of Medical Sciences. Today, I am presenting my research titled Incorporating Detection of Carbapenem-Resistant Enterobacterials by Modified Carbapenem Inactivation Method and EDTA Carbapenem Inactivation Method in Surveillance Protocol to rationalize antibiotic therapy. So, antimicrobial resistance has emerged as one of the greatest challenges to modern medicine, threatening to reverse decades of therapeutic progress. And carbapenems are considered last-line antibiotics for treating infections caused by multi-drug resistant gram-negative bacteria. However, the increasing prevalence of carbapenem-resistant enterobacterials has become a major global public health concern. An important aspect of carbapenem-resistant enterobacterials is that different carbapenemases have different therapeutic implications. So, metallo-beta-lactams such as NDM and serine beta-lactams such as OXA48 respond differently to newer antibiotic combinations. Therefore, identifying not only the presence of carbapenemases, but also differentiating them is clinically important. So although PCR is considered the gold standard currently, it is expensive and not routinely available in many laboratories. So this led us to evaluate simple phenotypic methods that could be incorporated into routine surveillance. So the objectives of our study was three. The first was to detect carbapenemase production using the modified carbapenem inactivation method. And the second was to differentiate serine beta-lactamases and metallo-beta-lactamases using eSIM. And the third was to detect the carbapenemase genes, the NDM1, VIM, IMP, KPC, and the OXA48 gene using a multiplex real-time PCR. Coming to the methodology. This was a retrospective cross-sectional laboratory-based study, and it was conducted on 45 archived multi-drug resistant enterobacterial isolates collected in our tertiary care hospital. Repeat isolates from the same patients were excluded. So initially, all isolates were subcultured and organisms were identified along with antimicrobial susceptibility testing, which was reconfirmed. Isolates were then subjected to the MSIM to detect the carbapenemase production. Those that were positive underwent eSIM, where the addition of EDTA helps identify metallo-beta-lactamase production. Finally, the multiplex real-time PCR was performed to detect the 5 major carbapenemase genes. Clinical details and antibiograms were retrieved from the hospital information management system and analyzed. So, speaking of the patient statistics, most patients were male and the median age was 50 years. And majority of the isolates were obtained from the warts. Common comorbidities included hypertension, diabetes mellitus, and chronic kidney disease. Regarding the bacterial distribution, Klebsiella pneumoniae was the predominant isolate, followed by E. coli. On the right is the combined flowchart comparing our MSIM, eSIM, and RT-PCR results. Among the 45 isolates, 41 were positive for MSIM, indicating carbapenemase production, and 4 isolates were negative for both tests. And with the eSIM, 36 isolates were identified as metallo-beta-lactamase producers, while 5 were serine beta-lactamase producers. And PCR findings showed excellent agreement with the phenotypic methods. The NDM1 gene was detected in 36 isolates, while OXA48 was detected in 5 isolates. And 18 isolates showed co-expression of NDM1 and OXA48, indicating the coexistence of multiple resistance mechanism. So, in conclusion, Klebsiella pneumonia and E. coli were the predominant carbapenem-resistant enterobacterials, and NDN1 was the major carbapenemase gene detected with frequent co-expressions with OXA48. And eSIM, MSIM showed good concordance with RT-PCR and can serve as a reliable, low-cost phenotypic tools for CRE surveillance. Early differentiation of MBL and SBL producers can support rational antibiotic selection and antimicrobial stewardship. So, the take home would be strengthening routine CRE surveillance and infection control practice is essential to limit further spread. Thank you.
Thank you for that wonderful presentation. Now we will be calling on to our judges to join the platform, Dr. Sajid and Dr. Imad. Welcome, doctors.
Dr. Harinee, you are the intern in the college, yeah?
Yes.
Yeah. So as an intern, you are participating this type of study. It is a very good because it is actually postgraduate student study.
Okay, thank you.
Okay, so that a common conventional method about detecting of carbapenemase resistance. If you know about the MHT, modified host test.
Can you repeat that?
Do you know about modified host test, MHT?
No, I do not know in detail about it. I know it is one of the methods that are used, but not in detail about it.
Okay, so now the question about that means now you don't know about the MHT. So my question is that if anyone is carbapenem resistant organism like CRE, so what are the suggestive treatment for that one?
The suggestive management for that.
Yeah. So do you have any drugs which can be treated for the treatment for the CRE?
Yes, so the newer antibiotics from my study, the point was that the newer antibiotic combinations for serine beta-lactamase would be ceftazidime and avibactam, while for metallo-beta-lactamases, the studies have showed that we need to add aztreonam in addition to ceftazidime and avibactam for treatment purposes.
Yeah. Does anything option about from aminoglycosides?
I have not looked into it. I will have to look into it.
Because the newest drug is a plasmamycin, which can be helpful to help to treat this type of infection because it is a aminoglycosides and it is a very good for the UTI.
Okay.
Yeah.
Okay. Thank you.
Thank you, Dr. Sahid. We could proceed to Dr. Imad.
Thank you, Dr. Sahid, for your valuable inputs and for the presenter. Did you hear about the population, like switching subtypes of the antibiotics from population to population, which leads to the depression, the overexpression of antibiotic to a certain gene, which leads to inactivation of the genes, which eventually, after a while, we will have this resistance removed. Have you thought about like across the states, all right, like switching the medications subtypes and the antibiotic subtypes from a state to a state in order to have gene expression, inactivation, and other gene gain of functions.
So I have heard about it, but
I'm not sure if my idea is completely clear to you, but I've had a very fruitful discussion with my microbiology professor in, I believe, my second year. And he has told me that this is an ongoing research in the US and part of the Europe. So I would really be grateful if that also would be conducted in India and other parts of the world.
that would be that was one of the recommendations at the end of my study as well, to conduct a larger multi-centric study with bigger sample sizes.
Very perfect. And my second question, why did you go to check the RT-PCR with test instead of the WGS test or gene?
Can you repeat that question? Why did I go for RT-PCR instead of
WGS gene? I mean, there are two genes for the carbamazepine resistance.
So these 5 genes are predominantly present in Southeast Asia, especially in India. So they were more common. So we decided to go for these 5 genes with the RT-PCR.
Also, we can say cost effectiveness.
Okay.
Thank you so much.
Thank you.
Thank you, doctors. Now we will be proceeding to the code. We would like to remind everyone to please do scan the QR code and to vote for your most preferred presenters. All right, next up we have Shafia Ashrad. Thank you for joining us today. And for this session, we will still have the same judges as earlier. Could you hear us? All right.
Yes, I can. Can you hear me?
Yes, we could hear you. I think your connection might not be very good. You could turn off your camera to have good audio.
Okay, sure. So, good afternoon, everyone. My name is Dr. Shafia Arshad, and today I'll be presenting on behalf of my teammates our systematic review and meta-analysis titled Association of Plasma Ghrelin Levels with Irritable Bowel Syndrome. I'll briefly discuss why ghrelin is important in IBS and how we conducted this meta-analysis, our key findings, and what they basically mean for the future research. So firstly, a little brief background. Irritable bowel syndrome is one of the most common functional gastrointestinal disorders. It affects millions of people worldwide and is characterized by chronic abdominal pain, together with altered bowel habits, including diarrhea, constipation, or probably both. Although IBS is very common, its exact pathophysiology remains incompletely understood till date. One hormone that has gained increasing attention in the past time is ghrelin. It is primarily produced in the stomach and is well known as the hunger hormone. However, beyond appetite regulation, it also plays important roles in gastrointestinal motility, gut-brain communication, and regulation of digestive functions. Previous studies investigating plasma ghrelin levels in IBS have produced conflicting findings. Some reported increased levels, while others found no significant difference, particularly among different IBS subtypes. Because of these inconsistent findings, we performed a systematic review and meta-analysis. Our objective was very simple. It was to evaluate whether plasma ghrelin levels are associated with IBS or not by systematically reviewing the available literature and quantitatively pooling the evidence. So to answer this question, we performed a systematic literature search using 3 databases, including PubMed, ScienceDirect, and Google Scholar. Initially, we identified over 5,200 records, but after removing duplicate screening titles, abstracts according to our eligibility criteria, only 3 studies met the inclusion criteria. And we excluded the studies on the basis of their duplication or those studies which do not have any control groups in them, or those which are published in any other language other than English. And we also excluded the studies which had other comorbidities. So Studies included the 3 studies which fall in the inclusion criteria had 129 patients with IBS and 56 healthy controls. So for statistical analysis, we used a random effects model, which is appropriate because differences between studies were expected. The pooled effect size was calculated as the standardized mean difference with 95% confidence intervals. And this prisma flow diagram shown on the slide summarizes the study selection process. Now, this slide is the most important. It basically shows the results of our study. Overall, we found that plasma ghrelin levels were significantly different in patients with IBS compared with healthy controls. The pooled standardized mean difference was 0.86 with a 95% confidence interval of 0.26 to 1.46. And this result was statistically significant with a p-value of 0.005. We also performed subgroup analysis. For patients with IBS-C, which is constipation predominant IBS, ghrelin levels remained significantly elevated with effect sizes. Similarly, patients with IBS-D or diarrhea predominant IBS also demonstrated significantly altered ghrelin levels. However, we observed substantial heterogeneity among studies, particularly in the IBS diarrhea dominant subgroup. This means that although the overall association is significant, the magnitude of the effect varied considerably across studies. And there could be many reasons, including there could be difference in the patient populations or the laboratory method which are used to measure ghrelin levels, and variability in the study design. Well, despite this heterogeneity, our certainty assessment indicated that overall evidence remained of high quality. Furthermore, when we performed Lee 1-out sensitivity analysis, the findings remained consistent, suggesting that no single study disproportionately influenced the overall result. So what do these findings tell us? First, our results suggest that ghrelin may play an important role in the pathophysiology of IBS. Since it regulates gastrointestinal motility and gut-brain signaling, abnormal ghrelin levels may contribute to the symptoms experienced by IBS patients. Secondly, we observe differences between IBS constipation dominant and IBS diarrhea dominant. This suggests that different IBS subtypes may involve distinct neurohormonal mechanisms rather than representing the same biological condition. However, one important limitation should be acknowledged. Only 3 studies were eligible for inclusion, and considerable heterogeneity was present, particularly among IBS-D studies. Therefore, while our findings are encouraging, they should be interpreted cautiously. In conclusion, our systematic review and meta-analysis demonstrates that plasma ghrelin levels are significantly associated with irritable bowel syndrome. And these findings suggest that ghrelin has a potential as a diagnostic biomarker and may even help differentiate between IBS subtypes in future. However, before it can be applied in routine clinical practice, larger multi-center prospective studies are needed to validate these findings because the inclusion criteria only had 3 studies. Thank you very much for your attention, and that's all from my side. I would be happy to answer any of your questions.
Thank you very much for that presentation. Now we'll be calling on the other judges to join us on the platform, Dr. Imad and Dr. Njudo. Welcome, doctors.
Yeah, thank you, Ms. Ashad, for your presentation. Okay, I noticed in your findings, in one of your findings, you mentioned that there was a high level of heterogeneity, right?
Yeah.
Are you there? Okay. Okay. So in that case, what do you think is expected of you in terms of the confidence interval?
Well, as there were high levels of heterogeneity, basically in the IBS diarrhea dominant subtype. But though the heterogeneity level was high, still it did not affect our overall result.
Okay, maybe you could check this out. There's something called prediction interval. in cases of high heterogeneity. Well, my last question is around your confidence intervals for the findings you reported as significant. What's your interpretation of findings whose confidence interval actually span across zero? What can you say about that? Was I clear?
Our presenter may be
Can you
having
hear
some
me?
technical difficulties. Yes, hello.
Hello, yes. If the confidence interval spans across zero, then that is not statistically significant because might mean that there is insufficient evidence to conclude that there is the difference between the ghrelin levels.
Yeah, because I think that's what I observed for your first two findings. You could have a look again at the confidence intervals. You know, they span across zero, and it's going to affect your conclusions.
Yes, we know that. That's why we said that before we can clinically interpret this information, we need to have large studies because this study only included three studies fell in the inclusion criteria, and that two were not
Okay. Thank
any.
you.
There was no
Thank
gender differentiation or no patients with
I think that's all for me. Hello, that's all for me. Thank you.
Thank you.
Thank you. We may proceed to Dr. Imad. Is there anything else you would want to add?
Thank you, Dr. Shafi, for the presentation for the static review meta-analysis on ghrelin levels and their roles in IBS. You did conclude that ghrelin levels can be diagnostic in terms of IBS, right? Did you use any
Yes.
diagnostic performance? Like, for example, did you check for sensitivity and specificity in the
No, basically, we did not do that, any sensitivity or specificity of the test, but we just had a study across different literatures. And on the basis of that, we did this meta analysis and systematic review.
All right. Well, based on your literature review, would you think the deep brain therapy would reduce the ghrelin levels in IBS patients and also would have an effect on IBS generally?
Sorry, your voice was breaking. What did you say? What can reduce the ghrelin levels?
Based on your literature review, have you come across the deep brain therapy for treatment of IBS? And whether did you find any potential association or findings suggesting that it can reduce or it can affect the ghrelin level?
Based on this study, I think there is also mixed reviews that because sometimes brain-based therapies may influence ghrelin levels, but the evidence again is mixed and depends upon the type of therapy. Basically, the type that maybe depend if it is a stress reduction therapies or any other brain stimulation techniques, and the results again are very mixed.
All right, since we are short of time, for the next systematic review and meta-analysis or for the next study, and based on the extensive literature review that you have done, what would you modify in order to include a broader included study in the next inclusion criteria?
Well, I think the next inclusion criteria, we should more focus on the sample size and on the population, because I think in here the sample size was very low, and there were no comorbidities in the patient with the IBS. So I think that would really affect our study if we do include patients with different comorbidities.
Thank you so much for your elaboration and for your well presentation. Thank you.
Thank you.
Thank, thank you both for all those insight as well as our presenter. Now we'll be proceeding to the code. We would like to remind everyone to please scan the code and to vote for your most preferred presenter. And for our judges, please do fill in the forms that has been given to you previously. All our awards will be presented right before the closing ceremony, so we do hope everybody will be joining us up to the end of our conference. All right, next up we do have Raj. I'm not sure if I pronounced that right, but welcome to join us tonight.
Hi, I'm Arush Raj. Am I audible?
All right. Yes, we are able to hear you. So for this session, we would still have Dr. Imad as our judge. You may start when you're
Great.
ready.
Thank you. So, a few months ago, I watched my classmate answer a question in seconds, quickly, fluently, and with complete confidence. There was just one problem. The answer was not really his. It came from an AI tool, and he did not think it through. That moment stayed with me because his confidence was real, but it was borrowed. It belonged to a machine and not to him. I am Arush Raj Chugh, a first year medical student at David Teveldiani Medical University in Tbilisi, and I studied this habit, which I call borrowed confidence, among 104 fellow medical students across two countries. These tools entered medical study almost overnight. Research calls them either helpful or harmful. Both miss the group in middle, the students who see AI weakening their reasoning yet keep relying on it. So I asked myself a question. Does relying on AI contribute to poorer mental health? And who continues to use it despite recognizing the risks? Here's what I did. An anonymous, voluntary online survey, a snowball sampled through student networks, 113 students screened, 104 analyzed, 71 in Georgia, 33 in India. Mental health used DAS-21, a validated instrument. No questionnaires exist for AI learning dependency, so I built a 10-item scale. They held very well together, giving a Cronbach's alpha of 0.837. I read the data in three ways. First, the dependency, how much each student leans on AI, which is low, middle, or high. Second, the severity, how deep the distress runs. And third, the final one, the paradox group, my favorite. The students who said AI helps them and harms their thinking, both at once. The findings were striking. 98% of 104 students used AI almost daily. Distress was already high. 7 in 10 had moderate or worse anxiety. 6 in 10 with depression. Co-result, the more a student is dependent on AI, the worse their mental health across depression, anxiety, and stress. The most dependent showed 50% higher depression and 56% higher anxiety than the least ones. To be clear, both anxiety and depression rise together, but one moment survey can't tell us which causes the other. Then, my favorite, the paradox group. Most felt AI improves their understanding, half saw it weakening their reasoning, and nearly a third said both at once. The paradox group, and they carried the heaviest distress of all. Only 41% verified the AI content they relied on. The strain shows physically too. Almost 9 in 10 sleep under 7 hours, and nearly half meet the criteria for moderate or worse stress. None of this proves AI causing harm. It shows a habit settling in before medical education has decided what good AI use looks like. Let me be honest about the limits. I asked this once to myself. So, this is a link and not a cause. The sample may not represent all students. Workload could be one thing driving them both, and I'll recheck on that. And it needs a larger group for it. But the conclusion is very simple. More the dependence on AI, worse the mental health, and those who saw the harm but still kept using it, that's even worse. So let's teach safe AI habits from year one. How do we fix this? Not by telling students to use less AI, it clearly helps us. And awareness alone isn't enough. So, and a third already saw the harm and carried on. The answer has two levels. First, the awareness. Give this trap a name so students recognize it in themselves. Second, the training. Think the problem through first. Use the AI to check yourself, check your answer rather than asking it to write for you, and verify anything clinical. Our textbooks were chosen with care, and AI deserves the same care. Institutions guiding which tools students use and how at every stage. One image to close. Every AI answer carries a disclaimer. This AI can make mistakes. Please double check. And if we train our doctors whose confidence is borrowed from AI, patients will one day need a disclaimer for themselves too. This doctor may make mistakes, and none of us wants medicine to get there, right? Thank you. I'm grateful to my mentors and to every student who took part in this study. I'm glad to answer your questions now.
Thank you once again for that presentation. Now we'll be going to call our judges to join us. Dr. Imad, welcome to join us.
Hi, Dr. Shok. Thanks for your presentation. I do have a set of questions. First of all, this is an interesting study and the era of
I can't hear you, sir.
elevation.
Your voice isn't audible.
Oh no,
Is my
Dr. Imad is quite audible on my end.
Okay.
Well, well, that is weird. Okay, maybe Shog, you could try to reconnect as well as Dr. Imad, and we'll try to solve this as well.
Yes.
Let's give that a minute. While we're trying to wait for the reconnection, we would want to. Okay, Dr. Imad is back. Let's see if we could have him. Hello, Dr. Imad.
Yes. Are you able
Hi.
to hear me?
Yes. Yes, I am.
Perfect, Dr. Shah. Yeah, I was saying that thank you so much for this interesting study in the era of AI elevation and trend in medical education. Second of all, how did you select your sample size?
So I did this sampling through snowball sampling. It was a voluntary and anonymous survey. It was screened about 113 students, and nine of them were incomplete. So I just took them off and continued with 104 students.
And how do you plan to overcome the selection bias in the next or in the course of the study?
In the next survey, if I'm able to get this survey on a larger scale, first I'll have a repeated screening on those 104 students to check them how if workload is responsible for the distress and anxiety under the students, and that will help us or clear me with the.
All right. How did you make the questionnaires reliable? You've mentioned about the internal consistency using Cronbach alpha and validation of
Right.
the questionnaire. Yeah. How did you make sure that it's reliable for your sample?
So I can't, I will not claim it if it is reliable, but it gives us a link that those 10 questions are pointing towards one thing, which is dependency on AI. So I'll have to work on that, and I'll have to keep screening those 104 students and maybe a much larger group so that I can understand if my 10 scale item is reliable or not.
All right, thank you. We can pilot the study. We can have external reviewers and students who can elaborate more. We can have interviews. That they are all methods to make the study reliable, the questionnaire reliable. My other question: you have concluded that AI use can result in worse or depression, anxiety, and worse mental health, right?
Sorry?
Yeah. Uh, in your results, you concluded that AI use in medical students among medical students can result in depression, anxiety, or worse mental health. Is
These
that
are two
correct?
factors which are, no, it is not. These are two factors which are linked together, the distress and the anxiety, which are linked together. But workload could be one thing driving both of them, because if a student has a bad mood and like it's all dependent on workload.
All right. So, what do you think the factors behind using AI and these results, like for example, anxiety, depression, and so on? What do you think? Like, why do students have these factors? have these manifestations, let's say.
Can you rephrase your question? Sorry.
Yeah. What do you think the causes or the reasons behind the elevation of depression, anxiety, and other outcomes you have found in patients or in students who use the AI? Like, would you think of a baseline belief that AI may replace students or may replace educators or may replace medicine? Because this is a
No,
common and a
AI
trend
can't.
concern in medical education currently. And even journals
Right.
now are currently continuously updating their rules in the use of AI and so on, referencing and so on.
Right. I don't think AI can replace the educators. And firstly, AI is not totally causing distress, the depression, the anxiety, and everything. Those factors, these are not caused by AI. Those could be one reason which is caused by AI. And maybe a good survey with a larger group with continuous survey for more than a year can lead us to this answer to your question.
Thank you so much. And this study has a potential and future if it's, as you've suggested, larger, prospective, maybe control versus non-control. That all would help. Thank you so much.
Thank you so much. Uh,
Thank you so much,
I have one thing to
Dr.
say. Can I?
Yes, of course. Go ahead.
Before I leave, I wanted to, as you said, this study has a potential. So I wanted to take this to a larger scale, and I was planning if there is someone from US because in the next month. So I was planning if someone could help me work through this research together in US. That's it.
All right.
Thank
Thank you
you.
so much for that
Thank you so much,
invitation.
Dr. Ahmad.
I think we do have someone working on the same or inline research that is also in the conference. So you could look through the live as well and get in contact with that researcher. If I
All
may
right.
also add a suggestion on your research, we do since you are looking onto the anxiety, if I heard correctly, you could look into the pre and post aspect since we are also not sure if the anxiety is the one that's causing it or it's the cause the effect after. So I think that's one of the factors that you would want to look into. That's on the anxiety side. The second would be on AI education in medicine education rather, is that as Dr. Imad have mentioned that medical education and the integration of AI is quite a big issue right now. So I think you could also look into the literature in how Chinese universities and Singaporean universities are using AI in medical education. So I think what they're trying to do is to use an AI as only a model to study and not something that would provide them answers. So they're trying to beat AI as humans and not use it as a companion. I'm not really sure on the specific, but then you could look into those as well.
Thank you so
All right.
much. I'll look
All
into
right.
this.
All right. Thank you, both
Thank you.
judges and our presenters. Now we'll be moving to the code. We would like to invite everyone to please scan the QR code and to choose the most preferred presenter to vote rather. And as for our judges, please do fill in the forms that has been provided to you earlier. Our awards will be presented just right before the closing ceremonies. So we do hope everybody will be joining us up to the last minute of our conference. All right, welcome back. And we are going to finish another series of case reports. First off, we're going to invite Waleed. Welcome to join us this afternoon.
Hello.
Hello. All right. And she will be discussing on the risk factors associated with tonsillitis. Is this the one? Sorry.
No,
No,
this
God.
is not the one. Um,
This
it's
is the one.
yeah, this one. Yes.
Yeah, the contagious lumbar bilateral pars, the text of L3 and L4, and so on. Yeah, please
Yes.
do. In this session, we will still have Dr. Imad as our judge. You may start once you're ready.
Okay. Good afternoon. My name is Dr. Khadija Waleed, and I am a graduate of Nawaz Sharif Medical College. And today I'm presenting a case report titled Contiguous Lumbar Bilateral Pars Defect at L3 and L4 with intact L5 treated with pedicle screw fixation and interbody fusion. Now, this is a rare spinal cord condition because it involves both an acute traumatic pars defect at L3 and a chronic degenerative pars defect at L4, while L5 remains intact. And I will briefly discuss the patient's presentation, surgical management, and clinical outcome. Okay, so this case involves a 42-year-old female who presented following a road traffic accident. She had a history of chronic low back pain for the previous 2 years, suggesting an underlying chronic pathology. After the accident, she developed acute neurological symptoms, including sensory loss in the L3 L4 dermatome and weakness of hip flexion and knee extension, with the muscle power being reduced to 3 out of 5. And the radiological imaging demonstrated grade 2 anterolisthesis at L4. And more importantly, the imaging revealed a very rare combination of an acute traumatic pars defect at L3 together with the chronic degenerative pars defect at L4, while the L5 vertebra remained intact. And because of the neurological deficits and spinal instability, surgical intervention was considered the most appropriate treatment. Now, regarding the surgical technique and fixation, the patient underwent surgery through a posterior midline approach with exposure from L3 to L5. Subperiosteal dissection was performed, followed by insertion of bilateral pedicle screws measuring 6.5 to 45 millimeter to provide a stable fixation. To decompress the affected nerve roots, multiple procedures were carried out, including laminectomy, flavectomy, medial parsectomy, and bilateral fistectomy at L3 to L4 and L4 to L5 levels. And the main objective of the surgery was to achieve adequate neural decompression, restore spinal alignment and lumbar lordosis, and provide a rigid stabilization across the two unstable spinal levels using pedicle screw fixation with interbody fusion. Regarding the interbody fusion, it was performed at both the unstable level, that is at L3 to L4 level. A peak cage with bone graft was inserted, while at the L4 to L5 level, a peak cage with bone substitute was used. And the cages helped restore the disc height, maintain spinal alignment, and promote a solid fusion between the vertebral bodies. And fluoroscopy was used throughout the procedures to verify the correct position of pedicle screws and interbody cages. Lumbar lordosis was restored. Rigid fixation was achieved across both unstable level, and adequate decompression was confirmed before wound closure. And the pictures below demonstrate the surgical exposure during decompression, while the fluoroscopic imaging confirms the satisfactory placement of the pedicle screws and final fixation construct. And finally, it's also important to acknowledge the limitations of this case, and due which included a preoperative CT and MRI were not present due to resource limitation. In addition, the follow-up period was relatively short and no biomechanical studies were performed. These limitations should be considered when interpreting the surgical outcomes, although the patient's clinical recovery was excellent despite these. And regarding the patient's post-operative recovery was very encouraging. On the first post-operative day, she was mobilized successfully. Her pain score improved from 8 out of 10 to 2 out of 10. The surgical drain output was only 100 milliliters, and by 3 weeks, sensory function had recovered significantly. Muscle strength improved from 3 out of 5 to full strength, and follow-up imaging confirmed stable hardware. And then at 10 weeks, the patient was independently performing activities of daily living. Imaging demonstrated progressive spinal fusion, and no postoperative complications were reported. The postoperative x rays shown here confirm good spinal alignment and stable fixation. So, in conclusion, a contiguous bilateral pars defect at both L3 and L4 is an extremely uncommon, especially when caused by a combination of both acute trauma and chronic degeneration. And this case demonstrates that posterior pedicle screw fixation with interbody fusion provides excellent decompression, restores spinal stability, and results in early neurological recovery with good functional outcomes. Thank you. That's it.
Thank you for that presentation. Now we'll be calling on the judges to join us on the platform. Hello, Dr. Imad.
Thank you so much for the presentation and for the case. I have a question. What was the threshold for surgical intervention in this case, based on the you didn't do pre-op CT or MRI?
Sorry, can you repeat the question?
What was the threshold for what was like the why did you intervene?
Basically, it was because of the neurological findings. It involved the motor weakness and sensory weakness, which because of which surgical intervention was planned, and including there was this acute trauma, and because of the pain scale, the patient was in significant pain, because of which a surgical intervention was planned.
All right. What about clinical examination? Did you what about like important findings did you notice? Like, for example, was there any signs of kyphosis or hematoma on the level
Uh,
of posterior iliac
include
crest?
Yeah, so basically, there was a grade 2 anterolisthesis, and spinal instability was present. Therefore, the conservative management wouldn't have provided adequate decompression or restore stability. So that's why surgical intervention and was planned for stabilization and um, decompression, basically.
All right. You did mention about the motor function restore and sensory restore post operation, but
Yes.
I didn't notice. But did you like measure or assess the autonomic function of the pelvic post operation?
Sorry. Can you repeat? What did we measure?
Did you assess the autonomic function of the pelvic post operation?
Um, I'm sorry, I'm not sure about that.
Yep, no problem. Thank you so much for the case presentation. That was a great one. I just hope that these minor comments considered. This is one. Two, if also you could provide in your presentation that patient consent was taken. We know it's
Oh, yes.
taken, but we have to hear it. Thank you so much.
Okay. Okay. Thank you.
Thank you so much, doctors, Dr. Imad and Dr. Walid. We will now be proceeding to our code. We would like to inform everyone to please do scan our QR code and to vote for the most preferred presentation. And we will also want to remind our judges to please fill in the forms that have been put to you previously. Moving forward, we will be inviting Dr. Sazihar. Thank you for joining us tonight. Would you please share your presentation with us? Dr. Sazihar is a PGY2 General Medicine from PES, Institute of Medical Science and Research, India. While processing, could you please introduce our title?
Yeah, ours is a presentation of myeloma masquerade. Basically, it has the. Sorry, my name is Maunashri Potreddy, and I am a third year medical student at PS Institute of Medical Sciences and Research. Our guide, Dr. Shashidhar, is unavailable right now, so I am the one that is presenting. Yeah. Ours is a case presentation of myeloma masquerade, diagnosing multiple myeloma in the absence of hypercalcemia and Benjamin's proteinuria. Yeah, multiple myeloma is basically a malignant plasma cell disorder, which is defined by the bone marrow clonal marrow infiltration. So, multiple myeloma is a malignant plasma cell disorder. In myeloma, these cells turn malignant. These plasma cells turn malignant and they crowd out the bone marrow and churn out abnormal proteins that damage the kidneys, bones, and blood. So, most of us are taught to recognize myeloma using the acronym CRAB criteria. So, which is basically calcium elevation, renal failure, anemia, and bone lesions. Um, so the two of the most textbook red flags are hypercalcemia and Benjamin's proteinuria in the urine. But what happens when a patient has myeloma and neither of those two classic clues shows up? So that is exactly this diagnostic puzzle, the masquerade that we encountered. Our aim was simple, to show that multiple myeloma can hide behind normal calcium and a negative urine test, and to remind ourselves why we must keep looking even when the textbook signs are silent. So, let me walk you through our patient, a 60-year-old man who came in with 15 days of generalized weakness and poor appetite, on top of 6 months of intermittent low back pain. The pain was dull, non-radiating, worse with activity and worse at night. On examination, he was pale, mildly tachycardic, and 105 beats per minute with a blood pressure of 150/80. We also found thoracic kyphosis, scoliosis, and tenderness over his lumbar spine, but there was no neurological deficit. At this point, our differentials were multiple myeloma, spinal tuberculosis, and metastatic malignancy. So we investigated further. His hemoglobin was strikingly low. His hemoglobin was strikingly low at 6.6 gram per deciliter. His total protein and globulin ratio was inverted at 0.44 when normal is 1.2 to 2.2. The pattern alone told us something is overproducing the protein. But here is the twist. His serum calcium was completely normal at 9.8 and his urine Benjamin's protein came back negative. So two classic clues for myeloma are missing. So, we didn't stop there. An MRI of the spine showed diffuse osteoporosis and multiple lytic lesions with reduced vertebral height. A skull X-ray showed the classic punched out lesions. You can see them. To confirm it, we went straight to bone marrow. Aspiration and biopsy revealed sheets of abnormal plasma cells, binucleated and multinucleated, and even classic flame cells. We then ran a serum protein electrophoresis, and there it was, a sharp monoclonal spike and M1 confirming a clonal plasma cell disorder. When we checked the serum free light chains, kappa chains were markedly elevated at 234.27 mg per liter against a normal range of 3.3 to 19.4. So even though calcium and benzoin protein were silent, three other pillars like bone marrow biopsy, serum protein electrophoresis, and the free light chain assay gave us our answer as multiple myeloma. We started him on weekly bortezomib and daily thalidomide with prophylactic acyclovir, fluconazole, and allopurinol, and we have been closely monitoring his counts, renal function, and nerve symptoms. Uh, why does this matter? Because if we had relied only on those two textbook clues, we would have missed or delayed this diagnosis. And in multiple myeloma, the delay costs some bones, kidneys, or even costs lives. So what's our take-home message? Multiple myeloma can wear a mask, it can hide without hypercalcemia, without Benson's proteinuria, and still be every bit as dangerous as it can be. As clinicians and even as students, we need to keep a high index of suspicion. Whenever we see an older patient with unexplained back pain, anemia, and high globulin with low albumin globulin ratio. So when clues stay silent, bone marrow, serum protein electrophoresis, and free light chain assay can speak for us. Thank you.
Thank you for that presentation. Now we will be calling on the judges to join us on the platform. Dr. Imad, welcome to join us. Dr. Imad, are you here with us? Oh, yes.
Yes.
Hi. Thank you for the presentation. This is a very interesting case report. You have started your approach with general survey, and then once you found osteolytic bone marrow or osteolytic survey was consistent with there was osteolysis in terms, you didn't exclude the multiple myeloma, and you included that in your differentials, and then you went for cytobiopsy, which suggested and confirmed the diagnosis of multiple myeloma. What do you think of other biomarkers that can enhance your diagnosis and that can confirm your diagnosis as multiple myeloma?
Yeah, some lambda light chains like now we have tested for kappa and lambda light chains. Even sometimes heavy chains can also help. Then like some antibodies like IgG and IgM etc. could also help. Yeah.
Right. Have you considered metastatic multiple myeloma?
Sorry?
Metastatic plasma. Have you considered metastatic plasma tumor, plasma cell B cells tumor, like for example hematoma, or
Yeah, but there was no such kind of
in short term, have you considered extramedullary
extramedullary hematopoiesis.
Like, have you looked at livers? Have you looked at kidneys? Have you looked at
Actually, we did the renal function test, and there was normal renal function test, including the calcium. So he didn't have that much problem with his function test of kidneys. And then we didn't prescribe him the liver function test. Like this
all
patient
right.
was,
Have you considered amyloidosis secondary to multiple myeloma?
yeah, we have considered that one. When we tested, there was like serum free light chains were giving more like these. It was supporting the amyloidosis diagnosis too, but there was this bone osteolytic lesions, etc., which helped us to differentiate from amyloidosis.
Oh, that's great. Thank you so much for the presentation and for the educational message. It's very invaluable education message. Thank you.
Thank you.
Thank you, doctors. Now we will be proceeding to the code. We'd like to remind everyone to please do scan the QR code on the screen right now. These will help us understand who will be your best presenter. For the judges, please do fill in the forms that has been provided to you previously. All awards will be announced shortly just before the closing remarks. Next up, we have Dr. Waleed Ahmad. Hello, doctor. Welcome for you to join us.
Hello. I hope you can hear me.
Yes, we could hear you loud and clear. All right. So that you may start
Hold
when
on.
you're ready.
This is the end. Wait.
Not a problem. So
Okay. Hello, my name is Dr. Waleed. I am a house officer at Nasir Teaching Hospital, Peshawar. The topic of my presentation is risk factors associated with tonsillitis in patients aged 4 to 18 years in tertiary care hospitals of Peshawar. To give you a bit of background, tonsillitis is an acute inflammation of the tonsils characterized by pain in the throat, fever, anterior cervical adenopathy, tonsillar exudates. Tonsillitis is caused when viruses such as rhino and adenoviruses or bacteria such as group A beta hemolytic strep pyogenes infiltrate the tonsils and develop inflammation. Tonsillitis is one of the most common throat disorders amongst children. The aim of our study was to determine the risk factors associated with tonsillitis in pages aged 4 to 18 years in tertiary care hospitals of Peshawar. For our methodology, our study design was a case control study. We used convenience sampling techniques. The study setting was once again Nasir Teaching Hospital. The tools of data collection was questionnaire, and we used the modified center criteria to diagnose tonsillitis on patients. The target population was tonsillitis patients in Peshawar during 2023 to 24. The inclusion criteria was patients aged 4 to 18 years that consented to data collection, and patients admitted to the ENT ward. The exclusion criteria included comorbidities in patients aged younger than 4 and older than 18 years. The sample size was calculated with the WHO sample size calculator, considering a 95% confidence interval, a precise level of 6.13, and an estimated prevalence of 18%. 151 subjects took part in the study, with a total of 52 subjects in the case group and 99 subjects in the control group. The study started in October 2023, where we formulated the objectives and wrote our introduction. In November to December 2023, we wrote the question. We completed the data collection and analyzed it, and by January, our research was complete. So here are some of the results. As you can see, we focused on 4 variables, one of which we had to exclude when we controlled for other variables. The one we excluded was spicy food, because the significant value was 0.64, which means it was not significantly associated with tonsillitis. For sour food consumption, we took a reference value as no consumption at all. We found that a higher consumption is a major risk factor, as with an odds ratio of 4.52 and a 95% confidence interval of 1.44 to 14.08, we found that individuals who consume sour food 6 to 7 times a week are 4 times more likely of developing tonsillitis than those who don't consume sour food at all. Also, from the table here, you can see that moderate sour food consumption does not significantly change the risk, with a p-value of 0.87. Similarly, you can see from the table that a history of recurrent throat infection increases the risk of tonsillitis by 3 times, with an odds ratio of 3.32. Furthermore, individuals living within 10 kilometers of polluted environments are 2.49 times more likely to develop tonsillitis than those living much farther away from pollution. For the final step, we assessed the multicollinearity to find that the risk factors are whether the risk factors are highly correlated with each other. From the table here, you can see that the VIF values, otherwise known as the variance inflation factor of all of our variables, are above 1, indicating that there is zero multicollinearity and all of our risk factors are completely independent of one another. For the discussion, a study conducted in District Mardan in the year 2018 also showed that sour and spicy food had a positive association with tonsillitis. This is most likely due to the irritant effect that these types of food can have on the delicate tissues of the tonsils and throat. A polluted environment was also found to have a vital role in causing tonsillitis in a study conducted in the city of Kathmandu, Nepal. And finally, in a study, a positive association of recurrent throat infection with the increased risk of tonsillitis was found, which is in contrast with the findings of an earlier study, where no such correlation was found. This difference in findings could be because of the differences in the study design, variable definition, time frame, and confounding variables. In conclusion, a polluted environment, recurrent throat infections, and the frequent use of sour and spicy food are significant risk factors in causing tonsillitis, and public health measures should be implemented to address these factors. Thank you.
Thank you for that presentation, Doctor. Now we will be bringing in our judge for this session, Dr. Imad, once again. Thank you for joining us.
Salam, Dr. Waleed. Hope you're doing well. And thanks for your well-conducted study. This is Mohammed Imad. In Islamabad currently, and regarding your study, I'd like to comment on some strength, like using of multivariable regression, using the study design itself is very suitable for your aims. However, you did chose convenience sample, which obeys an exert selection bias in this particular study design. Why couldn't you choose another selection or like simple randomization or other techniques?
Okay.
I mean, the preferred here is simple randomizing sampling.
Yes, we were forced to use convenience samplings because when we did this research, we had a limited time frame to conduct the research, and convenience sampling seemed suitable within our time frame. And it was also a lot more convenient for us as medical students compared to the other sampling techniques presented to us.
All right. And you did use logistic regression, right?
Yes, sorry?
You did use logistic regression tests, right? In your
yes.
study. Okay. What were the confounding factors? Particularly interested in the confounding factors, as you have did predict the association between like for example recurrent sore food intake and recurrent infection and so on in association with tonsillitis. So what were the confounding factors and what are the effects for that?
Yes, so we mainly found from logistic regression, we found that sour and spicy food had an effect on each other, meaning that spicy food was insignificant because sour food was acting as a confounding factor by adding to the effect, basically, which gave us the initial p-value, which would seem significant. But after we did logistic regression, we found that spicy food was not significant.
All right. Do you acknowledge any other limitations of the study?
Any other limitations? We had a relatively small sample size. That was one of the limitations. And because we were focusing on the local population, maybe a base for a larger population for the study would have been more significant. That was one of the limitations.
Yeah, and if I may add, Doctor, if we can also use objective measures rather than subjective, and considering recall from patients, which can affect the generalizability and validity of the results. But overall, this is
Yes.
a very thoughtful study. Thank you so much for the
And
presentation.
there was one more limitation, sorry. Convenience sampling you mentioned, yes, it is prone to selection bias, which is also another limitation of our study. So
Yeah.
it's good that you pointed that out for us.
Thank you so much and have a good night.
Thank you so much.
Thank you, doctors. Thank you as well. Now we will be proceeding to our code. We would like to remind everyone to please do scan our code to vote for your most preferred presentation. And for our judges, please do fill in the form that were given to you previously. Our awards will be given and presented right before our closing remarks. So I do hope that everybody will be joining us up to the end of our conference. Right now, we'll be going on to Aline Toomey, School of Medicine, University College Cork.
Hi there.
Welcome to join us.
Okay. Can you hear me all right?
Yes, we could hear you all right. So we'll be discussing on the navigating diagnostic uncertainty and therapeutic complexity in IgG4-related sclerosing during a case report. You may start when you're ready.
Okay. Well, hi, my name is Aline Toomey, and I'm a second-year medical student at the University College Cork. Today, I'll be presenting a case of IgG4 sclerosing cholangitis, which I'll refer to as IgG4-SC. So for some background, this is a systemic fibroinflammatory disorder that frequently mimics pancreatobiliary malignancies, and for that reason, establishing a diagnosis is often quite challenging, especially if patients have significant comorbidities where the gold standard of tissue histology has risks. So the purpose of this study is to present a case of IgG4-SC, which illustrates the following things. A diagnosis of IgG4-SC can be established through pathognomic serology and therapeutic response in high-risk surgical candidates. The necessity of proactive risk stratification and shortening rituximab maintenance intervals is essential to prevent life-threatening relapses and reduce cumulative organ damage in high-risk phenotypes. So this is a case of a 72-year-old male who presented to his GP with a week-long history of malaise, diarrhea, and pruritus. His medical history is significant for mechanical aortic valve replacement, needing lifelong warfarin therapy, ischemic heart disease, atrial fibrillation, and 2 CVAs. Physical examination confirmed biliary obstruction with visible jaundice, scleral icterus, as well as pruritic excoriations. Initial laboratory work confirmed the clinical suspicion of cholestatic pattern of liver injury with significantly deranged liver function tests, and this prompted CT imaging. And this showed intra and extrahepatic strictures and a focal mass in the pancreatic uncinate process with superior mesenteric artery encasement. This finding, along with the double duct sign, raised suspicion for pancreatic adenocarcinoma. Definitive tissue diagnosis via endoscopic ultrasound-guided fine needle aspiration was attempted, but this was non-diagnostic due to the patient being on warfarin. But they were able to obtain biliary brushings through ERCP, and this revealed inflammatory changes without cytological atypia. Further, the C19-9 serum levels were normal, and MRCP imaging showed intra and extrahepatic ductal stricturing, which prompted suspicion primary for IgG4 related sclerosing cholangitis. So, for that reason, serum IgG4 levels were tested, and they were found to be markedly elevated at 8.5 grams per liter, which is 4 times the upper limit of normal. And this warranted the suspicion for IgG4 related sclerosing cholangitis, specifically type 4, as the strictures were isolated to the hilohepatic bile ducts, which is the area where the bile duct exits liver, and this prompted corticosteroid therapy. So subsequent imaging showed complete resolution of the uncinate mass and pancreatic head inflammation, and this confirmed the diagnosis of IgG4-SC, specifically type 4, with associated type 1 autoimmune pancreatitis. Unfortunately, during the corticosteroid taper, the patient experienced a clinical relapse with acute cholangitis and required biliary stenting as well as reinduction therapy. The chosen immunosuppressant was azathioprine, 50 milligrams daily, However, this was introduced with caution as the patient does have a known thiopurine methyltransferase deficiency, which predisposes him to life-threatening myelotoxicity. In addition, as he's over 50 years old, there is concern of increased risk of pancreatitis as well as solid organ malignancy. So these concerns promote a transition to rituximab infusion, 1,000 milligrams IV on days 1 and 15 every 6 months. and the patient tolerated this well and showed clinical improvement with no relapses. However, following a 15-day delay of a scheduled maintenance dose of rituximab, the patient presented with acute cholangitis. So for these reasons, it was decided that because of his high risk of reoccurrence, which is likely due to his peak serum IgG4 levels being 4 times the upper limit of normal, and the anatomical distribution of his biliary disease, he should have a 5-month infusion cycle instead of every 6 months. As of March 2026, where we met the patient, he is stabilized and he remains under close surveillance to help personalize his treatment and prevent further relapses. And he provided informed consent for the publication of this case report. So this case highlights the clinical dilemma where cardiovascular comorbidities and lifelong anticoagulation for a mechanical valve precluded a definitive tissue histology, making reliance on pathognomic serum IgG4 levels more important for diagnosis, as well as initiating immunosuppressive therapy. This case of type 4 IgG4-SC, characterized by isolated strictures, along with baseline serum IgG4 levels being significantly above 2.7 grams per liter, are independent predictors of a relapsing course. And the importance of personalized medicine is demonstrated in this case, where an acute clinical flare-up occurred after a 15-day delay in the scheduled rituximab infusion. And this suggests the necessity of proactively categorizing high-risk patients for intensified maintenance schedules of a 5-month cycle. In conclusion, this case demonstrates that in high-risk patients, a multimodal diagnostic approach that incorporates pathognomic serology, CT imaging, and response to corticosteroid therapy is a safe and reliable alternative to EUS fine needle aspiration to establish a probable diagnosis, and the importance of proactive biomarker-guided protocols to improve long-term outcomes in this challenging patient population. Thank you so much.
Thank you for that presentation, Aline. Now we'll be calling on Dr. Imad and Dr. Franklin for our judges. Hello, Dr. Franklin. Welcome to join us.
Yeah.
Dr. Imad.
Yeah. Thank you very much for your very insightful presentation. Yeah. I just have like one quick clarification to make, and this is just based on what you think. So I think your presentation was very clear. I was able to follow through and I understood like the course of the patient and the short-term outcomes. But I'm just thinking, what do you think could have been responsible? Like, do you think like the steroids got tapered off early? Because I know it's an issue like when people are managing autoimmune diseases, that like if they begin to like taper down the steroids early, it could like lead to relapse. Like, just thinking broadly, do you think like that could have been responsible for the initial relapse the patients had?
Sorry, just to make sure I understood your question, you mean the fact that he started on steroid therapy like before they were sure of the diagnosis? Is that what you mean?
No. Like if you go back to your slides on the management, I understand the patient was started on steroid therapy. Then the management team began to like taper down the steroids, then noticed the progression in the disease before. Is it how? Yeah. So I'm just wondering, like, how long was the patient on like steroids before the management team began to taper down? Because I'm just thinking, because if they taper down too early, it can lead to this progression of disease. So I was just wondering.
Sorry, I understood your question. He was on an 8-week steroid therapy plan, which included the tapering, I believe. I don't think they waited too long before starting the azathioprine because they were kind of thinking ahead of like the next step if the steroids didn't work.
Yeah, but on the steroids, the patient like showed response to treatment, correct?
Yes, and he did respond to treatment, yes.
Okay, then shortly after he began to progress when the steroids began to. Okay, all right, yeah. I think I'm very clear on like the course of treatment. I was just trying to clarify the duration before the tapering down happened. But yeah, thank you so much for the presentation. Yeah.
Thank you.
Thank you, Dr. Franklin, for your valuable comments. And thanks, Aline, for the presentation. This is a very interesting case. I do have a set of questions. First is, how did you make sure that this presentation is consistent with IgG for autoimmune cholangitis without histopathology? You can answer this. I will proceed later.
Yeah, so there's a few different diagnostic criteria or different guidelines. Like there's the Japanese guidelines and the HISWORT criteria. And besides histology, there are a few other criteria with the imaging showing biliary stricturing, as well as the pancreatic mass, as autoimmune pancreatitis is often associated with IgG4 related disease, as well as the IgG4 levels being 4 times the upper limit of normal, which almost has a 99% sensitivity for IgG4 disease. And the fact that he responded with steroids is another criteria for it as well, and that he didn't have elevated CA19-9 levels, which kind of helps with reducing the risk of it being cancer, as well as the biliary brushings that they were able to obtain. They didn't show any signs of atypia, and it was inflammatory changes. Sorry, that was very long.
No, that was perfect. So the next question is the patient, based on the case presentation, he had more than one relapse, right?
Yes.
Exactly. How do you manage or how do you plan to monitor and manage if he develops future relapse?
Yeah, so I think based on his progression so far, he's going to have more follow-ups, like every 2 weeks. They'll be checking his liver function test. Every year he will be having screening for any pancreatobiliary malignancy, and they're going to shorten the rituximab infusion cycle to every 5 months to hopefully prevent any relapses. So he's going to have more monitoring.
Besides screening, do we have any or other protective factors against relapse?
I'm not sure, to be honest, besides the IgG4 levels and the LFTs being remaining intact, but even then it's not it's for certain, because just 15 days of delay for a 6-month infusion, he did have a relapse. So maybe that's something that I can look into if it exists, or if something that future research needs.
Thank you so much. If Dr. Franklin would add something, thank you.
Yeah, I don't have anything to add. I think like her responses to the questions are like, yeah, well, are valid. Because I was also wondering like what are the risk factors for relapse in the long term. But yeah, I think we'll just patient monitoring and surveillance. Yeah, should be able to like catch it early. Yeah, thank you so much.
Thank you, guys.
Right, thank you, judges. Thank you for that. We will now be proceeding to the code. We would like to remind everyone to please do scan the code on the screen right now and to vote for your most preferred presenter. And as for the judges, please do fill in the forms that have been provided to you previously. All right. Up next, we would have our Harger. Harger, are you there with us right now? Yes. Hello. Welcome back. So we'll be having you once again.
Yeah. So can I start?
Yes, you may start.
Yeah. So hi everyone, I'm Hargun Kaur Malhotra, a third-year medical student from Shri Guru Ramdas University of Health Sciences, Amritsar, India, and I'm going to present a case titled "The Ureter's Unexpected Journey to the Uterine Cornu, a Rare Case Report." So this case describes an exceptionally rare congenital anomaly of the urinary tract that not only posed a diagnostic challenge but also was an important surgical decision. Background and aim. The ureter develops from the ureteric bud of the mesonephric duct and normally inserts into the trigone of urinary bladder. And failure of this normal migration normally results as an ectopic ureter. Approximately 80% of ectopic ureters occurs in association with the duplex collecting system following the well-known Wiegert-Meyer rule. And in females, when the ureter inserts distal to the external urethral sphincter, the classic presentation is continuous urinary dribbling despite normal voiding. Although ectopic ureters may insert into Mullerian structures, such as the cervix or vagina, but insertion into the uterine cornu without a duplex system is exceptionally rare. Our aim was to report and present this rare anatomical variant in a 19-year-old female while highlighting the diagnostic challenge and the importance of tailoring surgical management according to the renal function and anatomy rather than relying on solely the conventional treatment algorithm. Case presentation. Our patient was a 19-year-old unmarried female who presented with the continuous urinary dribbling since birth, despite normal voiding. Importantly, she had no history of dysuria, urgency, recurrent urinary tract infections, previous pelvic surgery, or genital trauma, and had normal regular menstrual history. On examination, the urethral meatus appeared normal and urinary pooling was seen at the vaginal introitus. Routine lab investigations were within the normal limits, while the ultrasound demonstrated an atrophied left kidney. On CECT and MRI, a dilated tortuous left ureter inserting directly into the left cornu was observed, with the contrast spilling into the uterine cavity, subsequently in the vagina, confirming an ectopic insertion. And because the preservation of renal function was an important consideration, a DTPA scan was performed, which demonstrated the left renal GFR of 1.1 milliliter per minute compared to the right GFR of 75 ml per minute. These findings confirmed that the left kidney was severely atrophied and was essentially non-functioning. Management. The management of ectopic ureter depends largely on the underlying anatomy and the functional status of the kidney. In duplex collecting system, constructive procedures are performed. However, in our case, the patient had a single system ectopic ureter where the entire kidney drained through the one ectopic ureter into the uterine cornu, making this case fundamentally different from the more commonly encountered duplex anomalies. Given the globally atrophic kidney and negligible renal function, the absence of salvageable renal tissue, the patient fulfilled the accepted indications for nephrectomy, and thus she underwent a left simple nephrectomy. She became completely dry from the first postoperative day and her recovery was uneventful. She was discharged in a stable condition and has remained symptom free on follow up. This case demonstrates how combining detailed anatomical imaging with functional renal assessment can guide the most appropriate management strategy in rare case anomalies. To conclude, although ectopic ureters are uncommon, clinicians should strongly suspect this diagnosis in young females presenting with continuous urinary dribbling since birth. And our case is unique because it demonstrates an ectopic ureter inserting into the uterine cornu without a duplex collecting system. Thank you.
Thanks for that presentation, Argun. Now we will be joined by our judges, Dr. Mustafa and Dr. Franklin. Welcome to join us.
Yes, thank you very much again, Hagan, for the presentation. This was brilliant. This is a very clear presentation, and it was interesting to just like see that the patient could find help, because I can imagine like a teenager having this constant urinary dribbling, the social issues and everything. Yeah, but I'm just thinking broadly, like, and this may be based on different facilities, but was she able to get access to things like social care? Because I imagine that like she would have experienced some issues in terms of anxiety, because you could be around friends and have like this urinary dribbling. But just talk, are you able to like speak to me more about the social aspects of the diseases and what her experience could have been like and how she was able to get rehabilitation?
Yeah. So though she presented late, like when she was almost 19-year-old, but since her kidney function of the left kidney was only 1.1 ml according to the DTPS scan, so as she reports, she says that she used the sanitary napkins or the diapers that would fill in only, like she used to change in about 2 to 3 days, like the whole of it would used to fill in 2 to 3 days later, though she had to change because of the sanitary conditions and to maintain the hygiene. But
Yeah.
otherwise, if we consider the whole collection of the urine, So it used to fill in 2 to 3 days. So and she belonged to a very low socioeconomic status.
Okay.
So that is why, like, which is one of the social aspect in, especially in countries like India, where people come from a very low uh, socioeconomic status. Like, these are the various challenges we often face. And even during her reports, like, if she used to come like after almost 2 to 3 months with the next report. Like, if the MRI is done in July, she used to report for the next test after 3 months.
Yeah. Okay. Yeah. And just again, like, thank you so much. Like, I'm just great, just happy to hear that like this patient was able to like just get help and get like definitive care for her condition. Yeah. Thank you.
Thank you.
All right. Thank you, Dr. Franklin. It seems that Dr. Mustafa might not be available for this session, so we will be moving on. Thank you again, Hargan, for that wonderful presentation.
Thank you.
Okay. Moving on to the code, we would like to remind everyone to please do scan it and to vote for your most preferred presenter. As for our judges, please do fill in the form that were given to you previously. All right, up next we have Anu, and she'll be presenting another case report, an interesting one. Hello, nice to join us.
Hi.
Hi. I do not seem to see your presentation here.
Yes.
Please
Give me
do
one
share.
second to share my screen. Do you guys see my screen?
All right. Please wait a minute. Yeah, it's over here. For
Okay.
this session, we will still have Dr. Franklin as our judge. You
Sounds
may
good.
proceed.
Hi, everyone. My name is Anuraga Mayappan. I'm a third-year medical student at American University of Antigua College of Medicine. So here I'll be presenting our case, Beyond Polymyositis, a refractory lumbar spasms under revealing underlying ISEC syndrome. The key issue in this case was diagnostic anchoring. The patient carried a diagnosis of inflammatory myopathy, but his presentation did not behave like typical polymyositis. He had shock like lumbar spasms every 5 seconds and only a mildly elevated creatine kinase, positive anti GAD65 antibodies, and poor response to standard therapy. Our goal is to highlight the clinical clues that should prompt clinicians to consider autoimmune neuromyotonia or ISEC syndrome in patients with refractory spasms. So, this patient was a 72-year-old man with inflammatory myopathy, scoliosis, hypertension, who presented with repetitive shock like lumbar spasms occurring approximately every 5 seconds. Neurological examination was otherwise unremarkable. The first key clue was the mismatch between the symptom severity and the muscle enzyme elevation. His CK was only 181 units per liter. However, sustained muscle activity caused systemic complications, including lactate elevation and mild troponin elevation, consistent with demand injury. The second key clue was positive anti GAD65 antibodies supporting an autoimmune neurological process. The third clue was the treatment failure. IV methylprednisolone or orphanedrine did not improve the spasms. Together, these findings shifted the working diagnosis from primary myopathy alone toward peripheral nerve hyperexcitability, and plasma exchange was initiated. After the plasma exchange, the patient had marked clinical improvement. His spasms improved dramatically, his lactic acidosis resolved, and the cardiac biomarkers normalized. This response supported the diagnosis of autoimmune neuromyotonia in the setting of inflammatory myopathy. He was discharged on prednisone taper and methotrexate with outpatient neurology and rheumatology follow up. The major clinical point is that the response to plasma exchange was not only therapeutic but also diagnostically informative, especially because EMG and VGKC specific testing were not performed during this admission. This case provides three practical teaching points. First, severe spasms with a low or only mildly elevated CK should prompt clinicians to think beyond active polymyositis alone. Second, Anti-GAD65 positivity can support an autoimmune peripheral nerve hyperexcitability syndrome, particularly when the clinical phenotype fits. Third, steroid refractory symptoms should trigger EC or early escalation to plasma exchange or IVIG when neuromyotonia is suspected. In summary, refractory shock like spasms should not automatically be attributed to polymyositis. Careful integration of the symptoms, the CK level, antibody testing, treatment response, and multidisciplinary input can prevent treatment delay and serious metabolic complications. Thank you, and I welcome the questions.
Great, great, great and insightful presentation. We will now welcome Dr. Franklin to join us.
Yes, thank you very much for your presentation. Again, like, it's an exciting case report because I'm not very familiar with like autoimmune myotonia, but I was just wondering, is there like it comes off to me that like this was a diagnosis of exclusion because you have to like try to exclude other things. But did you come across any criteria for diagnosing autoimmune myotonia, or it's more like a diagnosis of exclusion?
No, so the actual criteria is the anti-GAD65 antibodies. So
Okay.
that is specifically for Isaac syndrome or the neuromyotonia. But this patient was not tested for that in the very beginning because he had an already polymyositis diagnosis. So it was also automatically assumed that it was a flare-up of the polymyositis. But the anti-GAD is a specific criteria for neuromyotonia diagnosis.
Okay. Yes. And I would imagine that like this anti-GAD65 is very sensitive and specific for the condition, correct? Then I'm
Yes.
wondering, in terms of like just chronic treatment or like long-term follow-up, what's the plan going to look like for a patient like this?
So for these patients, IVIG is the treatment for flare-ups, but he is also prescribed methotrexate to control the disease, and also on a prednisone taper, which should after this flare-up should help the neuromyotonia as well as the polymyositis. So the prednisone should help, but for the flare-up, they need IVIG.
Okay. And this is something that we have discussed like in terms of other case reports. Then for someone like this, I'm just trying to think for monitoring of or like for surveillance long term, it's going to be maybe more like symptomatic monitoring, right? Or is it like any other specific thing?
Yes, symptomatic monitoring and controlling their spasms and pain.
Okay. Okay. All right. Yeah. That's very clear. Yeah, thank you very much for your responses. Yeah.
Thank you, doctors. Now we will be moving on to the code. Another reminder for all our audience to scan our code and to vote for your most preferred presenter. As our judges, please do fill in the forms as well, for the ones that were given to you previously. All our awards will be announced just in a few minutes before our closing remarks. So we do hope everybody will be ready by then. Next up, we will have Karma Diki. Ooh, sorry, no. We will have Uziar Assad. Nice to have you with us tonight. Hello.
Hello, thank you so much for giving me the opportunity. My name
We
is
could hear you loud
Uzair
and
and
clear.
can you hear me?
Yes, we could hear you. Please proceed.
Yes, my name is Uzair Asad and I am an ex-graduate of Nawaz Sharif Medical College. Today, I'm going to present a case report that is basically a hepatobiliary mucinous cystic neoplasm, which mimicked hereditary cyst disease, which resulted in a diagnostic pitfall by showing a water lily sign. A little bit about the background. Hepatobiliary mucinous neoplasm is a rare cystic liver tumor that predominantly affects the middle-aged women. And the most common differential diagnosis when you see a water lily sign on imaging is the hydatid cyst disease in the endemic areas caused by Echinococcus the parasite. In our case, that was similar as well. And it can come across as an unusual diagnostic challenge because a giant MCNL can radiologically mimic a hydatid disease, hydatid cyst disease. So our aim was to present a rare case of a giant hepatobiliary MCNL with classical hydrated imaging features and highlight the importance of histopathological confirmation in complex cystic liver lesions, as you can see in the slide as well. So our case included a 55-year-old female who presented to the clinic with a 6-month history of progressive abdominal distension and right upper quadrant pain. On clinical exam, she had a large palpable mass which was extending from the right side and crossing the midline. The initial workup was done, including an FBC, liver function test, and a UNE. Tumor markers were done because due to the middle age woman with just suspicion of any ovarian thing, and a CT scan and a pelvic ultrasound was done. As you can see in the image, that the CT scan showed a large cystic mass with you can see the edge is stripped off from the margins, showing a water lily sign. In the next image, I'll show you that it's also look like a daughter cyst as well. That is very suggestive of a hydrated cyst. The management included exploratory laparotomy with the aspiration of 3 liters of mucinous fluid, and a near total excision of the cyst wall was done. And the histopathology was sent to 2 pathological centers in order to make a definitive diagnosis. So the CT scan was reported as a 25 centimeter multiloculated hepatic cyst. As you can see that the cyst included, you can see that the lower edge of the cyst, it shows that there is a daughter cyst of it. And when you see this, it's a differential diagnosis of a hydrated disease. It's very much like a hydrated cyst. But the histopathology came back as a hepatobiliary mucinous cystic neoplasm with ovarian-like stoma. And there was no evidence of dysplasia or malignancy, and the patient recovered well after the surgery. There was a post-operative wound infection, including Klebsiella in the cultures, which was treated successfully with IV antibiotics. IV meropenem was given. So the discussion include that it's when you see a cystic lesion on a CT scan, the differential obviously in the endemic areas come to our mind that it could be a hydrated disease. But in young female, middle-aged female, you should always be you should always keep MCNL as a differential, and obviously in the CT scan it's very difficult to diagnose. It would always be a differential, and histopathology is the hallmark for the definitive diagnosis, and the treatment for that is the complete excision of the cyst and then sending it for the histopathology. So yes, and the water lily sign is very suggestive of a hydrated cyst. But in our case, although very rarely you don't normally see a water lily sign with the MCNL, but in our case, we saw the water lily sign as well. And at the end, the complete excision and histopathology evaluation are essential for the accurate diagnosis and optimal patient outcome. So thank you very much.
Thank you again for that insightful presentation. We'll be getting the judges to join us on the platform, Dr. Franklin and Dr. Imad. Welcome, doctors. Dr. Imad, you may start.
Hi, thanks Dr. Asad, for the presentation. I have a set of questions. My first question would be, what were the limitations in the CT scan that made
limitations of the CT
that made you like confused between hydrated cyst and the mucinous neoplasm?
Yes. So obviously, when you see a cystic lesion on a liver containing daughter cyst and a water lily sign, it's most of the time it is a hydrated cyst. With a mucinous neoplasm, you don't normally see a water lily sign, and the septations that you see are usually thick walled. And with a hydrated cyst, you see thin wall septations. So in our case, it was that is why our case was sort of like the rare one in which there was thin septations and there was water lily signs and also the daughter cyst as well. So on the CT scan, it's very difficult to be of certain. Obviously, you can get a differentials as well.
Yes.
It depends where the patient is. Obviously, in the endemic areas, you will always keep hydrated cyst as your top priority, and you treat the patient as a hydrated cyst until proven otherwise. Obviously, in non-endemic areas, you can actually and middle-aged women, you can actually the differential would be higher for MCNL.
Dr. Asad, have you considered doing serology for hydrated cyst?
Yes, in this particular patient, it wasn't done, but obviously it should have been done. The thing is, it could be false negative, and you can't actually rely on serology for that. Obviously, if the serology come back as negative, you're still gonna treat him as a hydrated cyst. So a serology should have been done. It is an adjunct, but I don't think it changes anything management wise.
Or I wanted also to ask if your aspiration was intentional, but sounds like, yeah, it was intentional. So I'll move to my other question, which is my other question would be about, sorry, just yeah.
Can I just add
what
one?
were
Yeah.
You can proceed. No problem.
So aspiration, as you're saying, so obviously, if you see a hydrated cyst, you treat it as pair. So you should puncture and aspirate, and to decrease the size, and then you inject the hypertonic saline to kill the. Aspiration is always needed. Even with the aspiration, it had a serous fluid, so but aspiration was it should have been done, like it would have been done in hydrated cyst as well.
I understand that hydrated cysts are
Yeah.
endemic in the settings where you do your practice, but if you were in other settings, would you consider other differential diagnosis?
So the other differential that can come to our mind after looking a cyst on the liver on a CT scan could be some intrahepatic ductal pathology, neoplasm, and could more. But obviously, the first would be hydrated and MCNL, cyst adenomas. You can sort of
Adenomas,
any
okay.
biliary cyst, intrahepatic biliary neoplasms. And also liver abscess as well, although they are not like this well defined, but you can keep that into mind as well. Liver abscesses, yeah.
Well, this is just an elaboration, but would you consider pancreatic amylase and pancreatic enzymes because there is a midline shift?
Pancreatic amylase, not, but certainly you can do CA19-9 to rule out any intraductal or intrahepatic or extrahepatic ductal pathology, ductal tumor, and for pancreatic head tumor as well. CA19.9 can give us the information, but the amylase. ML, it's not the standard practice as well. In this scenario, I think it won't change any management plan.
All right, thank you so much. That's it.
Yeah,
from
but obviously
my
it can give
side.
us an idea if there is any damage.
Yeah, that's what I meant. If there is any damage, obstructive damage.
Yeah.
I'll leave it to Dr.
Yeah.
Franklin. Here you go.
Yeah, thank you very much, Asad, for your very clear presentation. Just one question, and this may be based on my limited knowledge on like MCNs in the pancreas. Like for the ones in the liver, are they considered pre-malignant lesions? Where are they like precancerous tumors?
Yes, very. That's actually a very good question. So obviously, if and that is why the reason for pelvic ultrasound. So if you feel any mass and it's in the liver, you first of all think of any malignancy. So you always see ultrasound pelvis was done to rule out any ovarian pathology that has metastasized to the abdomen, to the peritoneum or anything in the liver. But the thing is, you obviously, if you see them, in order to confirm it, even the CT scan is very limited, and you need MDM discussions with the radiologist, whether it is a malignancy or not. And obviously, if you don't see anything anywhere else, and just in the liver, it's very difficult to say that it is a malignant lesion. You can do biopsies, but if there is a cystic lesion in the liver, I don't think any interventional radiologist would be keeping in mind that it could be hydrated cyst and there is a risk of spillage. They won't do a biopsy for that. So to answer your question, there is always a possibility, but if there is no primary tumor elsewhere, it's very difficult to say that it's a metastatic thing. And it looks more like a primary liver lesion. Either could be hydrated or either could be some primary liver pathology.
Okay, all right. Okay, all right. Thank you very much for your response. I think this is something I'll look up because I was just thinking that, the way in like the cervix, like CINs are pre-malignant lesions. I was thinking that like MCNs are also like pre-malignant lesions. Like it could maybe be the early sign of maybe like a possible cancer that could happen decades down the line. Like that's what I was thinking about because I was wondering in terms of surveillance, what these patients can benefit from in terms of long-term monitoring.
Yeah, so definitely they have a potential. The MCNLs, they have a potential of turning into cystoadenocarcinomas. These neoplasms have a tendency to, but fortunately in our patient that there was no dysplasia and malignancy seen. Obviously, if they are locally more invasive, if they turn into cystoadenocarcinoma, they are locally invasive. They can obviously involve the surrounding liver tissue and the main structures of portal veins. That would make the surgical resection even more difficult, and also they have a tendency to spread to the nodes as well. Although there is no specific guidelines for MCNL because they are very rare to have a surveillance or follow up, but usually for ductal pathologies or pancreatic tumors, after resection you usually follow up with CT scans initially every 6 monthly to see if there is any recurrence. In our case, there was a near total resection, so that is why there was a bit of cyst left. So a repeat CT would definitely help to see if it has come back or not. Although there is, as on the histopathology is a bit reassuring, but obviously CT scan over down the line 6 yearly and after 1 yearly would definitely give us better information.
Okay. Yeah. Thank you very much for your responses on that side. Yeah.
All right. Thank you. Thank you very much. Thank you so much.
Thank you, doctors. Thank you all. We'll now be proceeding to the code and moving on. We'd like to remind everyone to please do scan the code and to vote for your most preferred presenter. And we will be moving on to our next presenter. Now let's welcome Dr. Manur. Hello, thank you for joining us. Welcome.
Am I audible?
Yes, you are audible.
Thank you.
Although the poster might be too small, please do adjust that.
I think you can just. I think it does not. Yeah. So.
Okay, I guess that would be all right then. The bigger, the better.
Okay.
All right.
Okay. Good evening, everyone, respected judges, esteemed fellow presenters, and all the viewers. I'm Anoor Ahmed from Rawalpindi Medical University, Pakistan. And I'm here to present my poster on a kaleidoscope of autoimmunity, divergent autoimmune phenotypes within a nuclear family. Autoimmune diseases are a heterogeneous group of chronic disorders that collectively affect approximately 5% of the global population, and their incidence has been increasing over the recent decades. So, before discussing my case, I would like to briefly introduce the concept of autoimmune tautology, which is based on the observation that many autoimmune diseases they share common pathogenic pathways. This shared background includes genetic predisposition, hormonal influences, environmental triggers, and immune dysregulation, which together form what is known as the mosaic of autoimmunity. You can just consider each of these factors as a tile, and they interact with each other to develop the autoimmune disease. And our topic, which is the kaleidoscope, a kaleidoscope is actually an instrument which creates different colorful patterns. So the concept of kaleidoscope of autoimmunity is that the same underlying pathogenic mechanisms can give rise to a wide spectrum of clinical phenotypes across different individuals and even within the same individual over time. While autoimmune diseases they frequently occur in the same patient as polyautoimmunity, or they cluster within different families as familial autoimmunity, but the reports of markedly diverse autoimmune manifestations that occur within a single nuclear family they remain relatively uncommon. So our case here today, it highlights the fascinating spectrum of autoimmune disorders. So I'll start with my case. It's actually about two sisters. One of them is a 38-year-old female school teacher who presented with progressive difficulty in climbing upstairs. So she had proximal limb weakness. She did not have any respiratory weakness or bulbar symptoms. Further evaluation revealed her serial serum potassium level to be between 1.9 and 2.1, consistent with hypokalemia. Further history revealed that she had hair loss with polyarthralgias and hair loss and polyarthralgias with low-grade fevers. So an autoimmune workup was done concerning for SLE. Her ANA was positive, but her anti-double-stranded DNA was not positive. It came out to be negative. So radiographical evaluation revealed that she had nephrocalcinosis. So the diagnosis of nephrocalcinosis along with hypokalemia led us to our diagnosis of distal renal tubular acidosis. So the patient actually had hypokalemic periodic paralysis secondary to systemic lupus erythematosus, with the underlying mechanism being the distal renal tubular acidosis. She was eventually treated with prednisolone and IV potassium for her hypokalemia till her potassium reached 3.5. After that, she was on oral Neo-K tablets and oral sodium bicarbonate tablets for her distal renal tubular acidosis. She was given prednisolone, hydroxychloroquine, methotrexate, and folic acid for her SLE. Which eventually improved. Her symptoms eventually improved. But during the follow-up, we noticed that she had recurrent muscle weakness with weight gain, despite her potassium level being normal. So further workup was done, which showed that she had a raised TSH level and low T3, T4. Her anti-thyroid peroxidase antibody was found to be positive. So that led to a diagnosis of autoimmune thyroiditis. So our first case, she presented with distal RTA secondary to systemic lupus erythematosus and autoimmune thyroid disease. So it's a clear example of polyautoimmunity. Our second case is her 42-year-old sister who actually initially presented with right upper quadrant pain, jaundice, weight loss. She had a bilirubin of 5, elevated transaminases, hepatitis B, C negative. Liver biopsy was not done, but her ANA profile was found to be positive. ANF or ANA profile was found to be positive, and anti-smooth muscle antibodies were also positive. So these clinical findings and her positive anti-smooth muscle antibodies led to a diagnosis of autoimmune hepatitis in our second case. So she was eventually treated with prednisolone and azathioprine. During the follow-up, she had features of that were concerning with systemic sclerosis. She has mark-like faces. She had salt and pepper skin pigmentation, perioral skin tightening, sclerodactyly, claw-like hand, and so she had these systemic sclerosis features that I have also attached here on my poster below. These images, they are of the same patient. Uh, so she was eventually treated with mycophenolate mofetil and a maintenance dose of prednisolone for her systemic sclerosis. So during the during follow-up, she actually improved. Her neck extension was improved, hand mobility was improved, and overall movement was improved. And her skin facial features, they were not the facial features, her skin tightening was improved actually. Now, after some time, she started complaining of dry eyes, foreign body sensation in her eyes, and dry mouth. A Skirmer test was done, which was found out to be positive, which led to a diagnosis of Sjogren syndrome. So, our second case, who was the sister of her first case, presented with these autoimmune diseases: autoimmune hepatitis, Sjogren syndrome, and systemic sclerosis, which is another a case of polyautoimmunity. So our cases here, they highlight a concept of the kaleidoscope of autoimmunity, that those individuals actually which share common genetic pathway, genetic makeup, or environmental influences, who are of the same environment, who are influenced by the same environment, like these two sisters. So they actually develop widespread clinical pattern of autoimmune diseases, although their pathogenic mechanism was the same. So this phenomena is known as the kaleidoscope of autoimmunity. So a key clinical message is that the clinician should maintain a high index of suspicion for additional autoimmune disorders in affected patients, as well as they should consider evaluating the family members of the affected patients for any underlying autoimmune disease. That ends our presentation. Thank you so much, and I am open to any questions that you may ask.
Thank you once again for that insightful presentation. We'll now be welcoming Dr. Franklin and Dr. Sonja Danon from the University of Michigan. Thank you for joining us, doctors.
Yes, thank you very much, Maho, for your presentation. And yeah, this is just me thinking how the families of these patients can benefit. Like, just thinking broadly, will you think something like just family screening for other autoimmune diseases could be helpful in like in a situation like this? Do you think there's a need for like just this genetic tree and trying to like trace things and see who else may have something just lurking around the corners? Or you'd have to wait until they present symptomatically? What are you thinking?
Yeah, so I think the family, any patient who presents with autoimmune disease, first the clinician should be aware of the other autoimmune diseases that can be present in that patient, and they should get a ANA workup done in majority of in the family members of those patients, because ANA are, in our case, both of the sisters had a positive ANA, although the specific antibody like anti-double-stranded DNA in SLE patient, it was not positive. Maybe just anti-sclerodermal antibody in systemic sclerosis, but was not positive. But the ANA titers were very high in both of these ladies. So I think ANA is a sensitive test for autoimmune diseases. So it should be done in the patient who present with autoimmune disease and the family members also.
Okay. All right. Thank you very much for your response.
Thank you.
Dr. Mohammed, over to you.
Thank you, Dr. Franklin, for your inputs, and thanks, Dr. Ahmed, for the presentation. I do have a set of questions. Did you do the HLA typings?
Are you talking about the HLA serotypes? Yeah.
Yes.
So regarding the HLA serotypes, I would say that certain HLA serotypes may be positive, but there is no specific antibody that, for example, in a patient of distal RTA that presented secondary to SLE, there is no specific antibody that causes distal RTA in antibody. It's just the autoimmune tubulointerstitial nephritis that occurs secondary to SLE in these patients. So there is no specific antibody and there is no mechanism proved, but still these patients present with wide spectrum of autoimmune diseases, and an HLA workup can be a factor because genetic makeup is a very important factor that presents in mosaic of autoimmunity. That is one of a factor that lead to the development of autoimmune disease.
Yes, Dr. Ahmed, but this is, as you've stated, a familial autoimmunity and polyautoimmunity. So actually, a family would be involved in this. Like, for example, we are talking about the diabetes mellitus type 1, or we're talking about thyroiditis, or we're talking about other autoimmune like SLE even. And we're like, if I recall correctly, there is actually a B27 could be involved in this. All right. And the distal arterial involvement is a complication of the autoimmune, let's say, storm. All right. So, yeah, that is one message. Otherwise, you did generalize your findings regarding the autoimmunity in the family. Like, for example, you did say for next practices or for multiple practices, when we do have one patient from a family that has suspected autoimmune disease, we should like screen the rest of the family members. On what grounds are you sure that we should do that? How can you justify the rationale behind this generalization?
Either we should do a ENA workup done in those patients, in the family members, or we should be highly aware of the symptoms that can present in those patients, such as a systemic sclerosis patients. She had the specific facial features of systemic sclerosis that we should be aware of, like the mask-like faces, the mouse-like appearance, perioral skin wrinkling, tightening of the skin, and salt and pepper skin pigmentation. So the clinician should be aware of these specific features, because not all of the features are present of an autoimmune disease are present in a single person. So they should be aware of any feature that might present that may lead us to the diagnosis of autoimmune disease.
Awesome, Dr. Ahmed. And also regarding autoimmunity, there is like one of the manifestations or one of the ground factors for developing or for having the autoimmunity to develop is having a previous or sudden, like for example, infection or stress or yeah. How can we like generalize this? How can we be sure for the rest of for other suspected autoimmune disease to generalize this?
I think we should be aware of the complications of the autoimmune disease.
I apologize if I didn't like paraphrase my question correctly. Like in this presentation, have you like there was any history taking regarding the previous infection and previous stressors that the patient has been into?
Yeah, the history taking from the patient was complete, but like in our second patient who presented with autoimmune hepatitis, there was no specific trigger of that. We just got to know it because hepatitis B C titer was negative, and she suddenly developed right upper quadrant pain with jaundice. In history taking, there was no specific trigger of the autoimmune disease. It started in her age at about 42 years age, which is a common age finding of those patients of autoimmune disease, of autoimmune hepatitis. There might be certain triggers of autoimmune diseases that may trigger them, and I think the clinician should especially know those triggers that may lead to the exacerbation of the disease.
All right. Since there is the first sister had polyautoimmunity, right?
Yes.
Would you recommend doing screening for DM type 1 or other autoimmune diseases in the second sister?
Yeah, definitely. Like type 1 diabetes mellitus, it's another autoimmune disease that presents because of auto antibodies against the lymphocytes, against the B cells of the pancreas. So I think we should get a screening done for type 1 diabetes mellitus in that patient. In actual fact, the first patient, yeah, I think we should get that done.
Thank you so much, and thanks for Dr. Franklin for his inputs.
Thank you.
Thank you, doctors. That was such insightful talks. Now we'll be moving on to the code and to the next presentation. We'd like to remind everyone once again to scan the code and to vote for your most preferred presentation, and for the judges to fill in the forms that was provided previously. Next up, we will be following the presentation of Karma Dickey. Hello, nice for you to join us tonight.
Am I audible?
Yes, you are audible.
Okay. So, good afternoon, everyone, respected judges, my fellow presenters, and all the lovely audience over there. I'm Dr. Karmadiki Sherpa from Nepal, currently doing my internship in TMSS Medical College and Rafatullah Community Hospital in Bangladesh. I'm pleased to present my case report in today's World Conference of Medical Students Research, and my poster title is A Rare Case of Madelung's Disease in a Non-Alcoholic Female from Bangladesh. So, starting from a short background, Madelung's disease, also called multiple symmetric lipomatosis, is a rare metabolic disorder primarily affecting the neck, shoulders, upper trunk, and proximal upper limbs. Its prevalence is about 1 in 25,000 individuals, commonly affecting middle-aged Mediterranean men having a chronic history of alcohol consumption. The pathogenesis remains unclear, but possible mechanisms include mitochondrial dysfunction and brown adipose tissue metabolism abnormalities, etc. Diagnosis is done by clinical presentation and examination and imaging techniques like ultrasonogram, CT scan, and magnetic resonance imaging. The next one. Coming to the interesting part, the case. A 35-year-old female was presented to the medicine outpatient department with the chief complaints of gradually progressive symmetrical swellings around the neck, suprascapular area, and upper chest for the past 2 years. The swellings were of significant cosmetic concern and created a psychosocial distress to the patient. However, there was no pain, tenderness, or any compressive symptoms. There was no history of sudden increase in the size and constitutional symptoms like fever, weight loss, or any other features suggestive of malignancy. There was no history of alcohol consumption by the patient. On examination of this patient, physical examination revealed symmetrical, soft, non-tender, and mobile subcutaneous nodular swellings over the posterior and lateral aspect of the neck, extending to both the shoulders, upper part of the chest, and back and proximal upper arms. Overlying skin was normal. Systemic examination revealed no any abnormalities. On investigation of this patient, since comorbidities like diabetes mellitus, hypothyroidism, dyslipidemia, and hyperuricemia are commonly associated with Madelung's disease, we performed some laboratory investigations like complete blood count, liver function test, thyroid profile, random blood sugar, lipid profile, serum cortisols as initial investigations, where all the findings were within normal limits. Ultrasonogram of the neck and upper limbs showed multiple homogeneous hyperechoic subcutaneous lesions, suggestive of lipomatous masses. CT scan of the neck confirmed the presence of diffuse, symmetric, non-encapsulated lipomatous deposits. And histopathology, well, it revealed mature adipose tissues without evidence of malignancy. Now here in this slide, we have 3 images of non-contrast CT scan, as summed by figure number 1, constituting axial section, sagittal section, and coronal sections represented by figure number A, B, and C respectively. Here, the red arrows shows diffuse symmetrical accumulation of fatty tissues, and which is present around the neck, extending over the shoulders, upper chest, upper back, and likewise. So for the management of this patient, the patient was counseled regarding the benign nature of the condition. Conservative management was given, including weight control and dietary modifications regarding also and regular physical activity. Surgical excision and liposuctions were also discussed as a potential options. But at this stage of the treatment, patient refused for any surgical intervention, so we continued our non-surgical management. Moving on to the conclusion, this case expands global evidence by documenting highly atypical presentation of Madelung's disease in a young, non-alcoholic Bangladeshi female, emphasizing on the point that Madelung's disease need to be considered and should be considered in patients with symmetrical cervicothoracic lipomatosis, even if the patient is female and even in the absence of alcohol consumption. It improves clinical practice and diagnostic recognition by increasing the awareness about atypical presentations and facilitating early diagnosis, reducing misdiagnosis, and avoiding unnecessary investigations. It drives future research by highlighting the need for further studies regarding the pathogenesis of the disease and evidence-based management across diverse population. Lastly, but not the least, it would be really unfair, right, if I wrap up my presentation without giving you some takeaways, clinical takeaways. So here are 4 clinical pearls for you all from my case report. Firstly, Madelung's disease can also occur in females, although it classically affects the male, middle-aged male. And absence of alcohol consumption does not exclude the diagnosis of Madelung's disease. CT scan is crucial for the diagnosis. And lastly, always and always exclude liposarcoma and distinguish lipoma before you call it a Madelung's disease. Thank you so much for being such a patient listener. Thank you.
Thank you for that insightful presentation. Now we'll be calling on the judges to help us. Dr. Imad and Dr. Sonia. Hello, welcome. Doctors.
Hi, thank you so much, Dr. Karma, for the presentation. This was a thorough investigation and follow-up regarding reaching such a hard diagnosis, because there are some other, like familial molding disease and other diseases that can be overlapping with this disease. I have a question. Did you assess for mitochondrial dysfunction on genetic basis?
Oh, like you are asking me if we like confirm mitochondrial dysfunction in this patient?
Yes.
No, regarding that, like we had like due to lack of resources in our hospital, we couldn't do that one as it is, sir.
So if you are about to publish this case report, would you recommend in the educational message to have this mitochondrial dysfunction check, at least on genetic basis?
Yes, sir. I would recommend that.
All right. And through your clinical examination, did you check for any neuropathy associated? Yes.
Since the patient was presented clinically in initial days of the this disease, so it was not like to the extent where the neuropathies occurs. Like there was no any compressive symptoms, there was no any complicated features like dysphagia, dyspnea, or any neuropathies. So.
All right. What were your differential diagnoses?
There were lots of differential diagnoses, since this is a common presentation in patients. Like obesity is like most common, like people, we can easily get like confused with that. And plus we had like lipoma and some people with liposarcoma, plus other lots of multiple lipoma. These were differentials.
Thank you so much. I'll give the floor to Dr. Sonia.
Hi, thank you so much. Just to expand on Dr. Imad's questions. So because this is an atypical presentation, what made you think this was the presentation in the first place, ruling out these other differential diagnoses?
Yes, thank you for your question. Like this was like Madelung's disease isn't the initial thought that comes, because it's a rare case, and plus a typical presentation as a presented by female, that also 35 years old. But like when we conducted other findings, like when we did CT scan of that, and there was like symmetrical deposition of the fatty tissues, that is very unlikely, because in lipoma there are capsulated adipose tissue, and in this patient there was no capsulated, and plus there was symmetry. symmetry of the fatty tissues, which is very unlikely in case of lipoma or any liposarcoma, because there are those presents as solitary nodules, and here we had like symmetrical nodules and plus non-encapsulated. So this directed us to this diagnosis, which was really rare case.
And then I understand that you did conservative management.
Yes.
At what point would you suggest surgery? Like, what symptoms would you be looking for that would prompt you to want to suggest surgery?
Surgery, ma'am, like at this point, the mainly patient's preference was non-surgical, but we would have advised and suggested patient for surgical management if she had brought some complicated features or like features suggestive of dyspnea, dysphagia, compressive symptoms, and also the neurovascular compressive symptoms. Then we would suggest the patient for surgical management.
Okay, thank you so much.
Thank you so much.
Thank you, judges. Thank you as well, Karma, for that wonderful presentation. Now we will be moving on to the QR code. We want to remind everyone once again to please scan the QR code and to vote for your most preferred presenter. We would also want to inform the judges to please fill in the form that has been provided to you previously. All right. So before we end our session, we will have one more presenter, Dr. Milin. Happy for you to join us today. And we'll also have your presentation on the screen.
Am I audible?
Yeah. Yes, we could hear you loud and clear. Your presentation? Yes, exactly. All right. You may start when you're ready.
Okay. So my name is Milan Kurup, fourth-year medical student at the Alabama College of Osteopathic Medicine in Dothan, Alabama, United States. I conducted this research through the Helen Keller Hospital System in Sheffield, Alabama, specifically the Quad Cities Pediatrics Clinic in Sheffield, Alabama. And this is where we got the consent from the parents and the guardians to conduct this research on the 7-month-old female. And we are here going to be talking about a case of cutaneous mastocytosis, which presented with atypical urinary manifestations. So a 7-month-old female presented to our clinic, presenting with a red-brown cutaneous plaque on her left wrist. This was also followed with some comorbidities, including polymorphic maculopapular rashes that lasted for like less than 30 minutes throughout the full body, along with some other comorbidities, including plagiocephaly, hypotonia, a collagenous nodule on the left ear, and left nasal lacrimal duct stenosis, all which we think is related to the cutaneous mastocytosis. The main aim here is to highlight the rare symptoms of urinary tract anomalies, including hydronephrosis, urethral dilations, and vesicular urethral reflux, which was also presented with her cutaneous mastocytosis after urinary tract infection. For some background, cutaneous mastocytosis is a subcategory of mastocytosis, which is a proliferation of mast cells, which is often a genetic disease caused by a KIT D816V point mutation in most forms. And there's an adult systemic mastocytosis form, as well as a pediatric cutaneous mastocytosis form. The adult form may have more organ damage and systemic symptoms, but the pediatric form usually only is limited to the skin and dermatologic regions. So here we're highlighting how it can spread. For the progression of our disease, the patient was born unremarkable, no signs of infection with spontaneous vaginal delivery. But around day 12, the patient presented with her first initial sign of this with a Derrier sign, which was a cutaneous lesion that was initiated by a wheel flare reaction, which is initiated by irritation or a tongue spatula. By day 14, this lesion had turned into a xanthosmoid cutaneous mastocytosis, the bullous form, the natural progression of mastocytosis, which eventually popped and left a scar remnant, as shown in the figure here. Later on, by day 25, or within 1 month of birth, the patient had notified the physician that they're also having full body macular papular rashes, otherwise known as polymorphic urticarial pigmentosa. And this only subsided with alleviating creams such as Benadryl cream and left indistinct scars throughout the body. Later, with skin biopsy, this was ultimately diagnosed as cutaneous mastocytosis as per the World Health Organization criteria. When presenting to us, we first noted that the patient had some signs of a urinary tract infection with foul-smelling urine and irritation and all. However, the patient had juxtaposing negative urine cultures and urinalysis, which made us kind of question what was the underlying pathology here. Because while the patient had negative urine cultures, she was positive for leukocytes, proteinuria, and hematuria. Hence, we did a further workup with a renal ultrasound, finding that the patient had right kidney fullness, questionable mild hydronephrosis, and urinary bladder wall thickening, as shown in the images here. After giving her treatment with Keflex or cephalexin, we noticed that the patient had remitted all her urinary tract symptoms, no fevers, no foul-smelling urine. And while the urinary cultures and urinalysis were all unremarkable, the patient still had persisting genital urinary tract symptoms, as shown with the voiding cysturethogram, which presented and, as illustrated here, showed vaginal reflux, left grade 2 out of 3 vesicular urethral reflux, a large post-void residual, right renal pelvocalcitasis, and dilated distal ureters, as well as her hydronephrosis of the right kidney. And so this was all confirming the fact that while the urinary tract infection had subsided, her hydronephrosis and her urinary tract symptoms were persisting. Ultimately, the main aim of this study is to highlight the fact that while mastocytosis can be diagnosed with skin biopsy, genetic testing, clinical signs, and invasive bone marrow studies, there are still no definitive cures or discovered cures for mastocytosis. And all that we can do is avoid inciting factors, have EpiPens on file in case of an anaphylactic reaction, supportive therapy, and other novel treatments such as gene-targeted therapy and tyrosine kinase inhibitors. And while renal involvement is rare, even in systemic adult forms of mastocytosis, as highlighted here in red, we know that it is not impossible for this to be included in the cutaneous forms of mastocytosis in the pediatric population. And so due to genetic variants, it is our duty to understand the pathogenesis, the prognosis, and individualized treatments for those affected by mastocytosis, even as a rare condition, and account for its heterogeneity. So I thank you for listening and happy to answer any questions about this.
Thank you so much for this insightful presentation. Now we'll be calling on the judges to join us on the platform, Dr. Imad and Dr. Sonia once again.
Hi, thank you so much. Just a follow-up question. Was a biopsy performed on the urinary tract as well, or was it primarily voiding studies that was used?
Yeah, so there was no biopsies done on the urinary tract because we did not want to do any invasive diagnoses for this in this specific situation. We're hypothesizing that the inflammatory nature of mastocytosis is affecting the genital urinary tract. This could be totally two different conditions. However, with the skin biopsy, we knew that the patient was diagnosed with mastocytosis, and now we're seeing all these like plagiocephaly, hypotonia, collagenous nodules, and now we're seeing these genital urinary symptoms. We're thinking there's some inflammatory condition, especially with negative urine cultures and all.
And then did you think about looking at different urine markers as well? So for example, like N-methylhistamine to see as a way to avoid doing any invasive biopsies?
That was not considered, but that is something that we should do in the future for sure, to see what other inflammatory conditions are maybe the cause of this, maybe if they're linked at all.
Thank you so much.
Thanks.
Thanks, Dr. Danon, and thanks, Dr. Krop, for the presentation. I do have a couple of questions. First, what was your initial differentials for once you've seen the skin lesions?
Yeah, so obviously, like the first thing that us physicians will think about is anything, acute, like anaphylactic reaction or, some type of urticaria, something around those lines. However, also we're thinking maybe like thrombocytopenia, some type of platelet dysfunction, HSP, like Hinchan purpura, something along those lines. However, upon diagnosis, these were all excluded, and so then we went with and we saw maybe some other reaction. And while we thought maybe this could be an allergic type presentation, it was not. So that's how we ended up at the mastocytosis diagnosis.
All right. You did mention KIT mutation, right?
Yeah, the KIT
Yeah,
mutation.
but how do you interrupt it in this patient? How?
Yeah, so the tyrosine kinase inhibitors like imatinib and stuff can disrupt it. However, these are also gene specific. That is why it is our duty to find what is the specific genes that are being affected. And one thing that I do want to highlight, in Alabama here, we don't have access to easy, fast genetic testing. And so this patient had a lot of trouble finding specific like treatment options for her.
That's great. And one last question from my side. Would you be able to elaborate more on your exclusion regarding systemic mastocytosis?
Could you repeat it? I didn't understand the question.
Yeah, would you be able to elaborate more on exclusion of the systemic mastocytosis?
Oh, yeah. So the exclusion of systemic mastocytosis is for, I mean, as of now, based on the like the World Health Organization criteria and all, we see that cutaneous mastocytosis is the more prominent in the pediatric population. Systemic mastocytosis is a collection of maybe some patients started with cutaneous mastocytosis and it develops into a more systemic form, and especially not at 7 months of age. It usually occurs much older, like once in the 20s and 30s, etc. So at 7 months, in order to progress so fast to systemic mastocytosis, was not documented unless this is the first case. So that's why it was first diagnosed as cutaneous mastocytosis, and now we're seeing all these systemic signs.
Well, doctor, I would say this is a challenging presentation. So at first, an initial presentation, what would you think of other systemic syndromes, let's say? Because we have skin lesions, we have urethral dilations, we have multiple of manifestations. So we would normally resonate this to be some sort of systemic involvement.
Yeah, so we're thinking like, SLE or something, you're saying like something more broad, like some ANA disease or some other autoimmune disease. I mean, maybe the patient is comorbid with that, but with already diagnosis of mastocytosis, which we cannot exclude. Maybe it is a collection of diseases like a vectorial type thing, like something along those lines. But for sure, here we're seeing many different presentations, such as the hypotonia, the neurologic type thing, or the collagenous skin lesions, as long as now genitourinary lesions. So we're seeing a collection of different symptoms here.
So despite the initial workup, what do you think of one single test that can lead to fast diagnosis and hence reduce the cost burden on hospitals and clinical practice, and also time saving for practitioners?
Yeah, so skin biopsy is the first initial step for this one. However, maybe a genetic test that will identify KIT D816V mutations fast, easy, maybe almost like we do in ANA somehow, if we can figure it out. There are other markers like CD2, CD25, CD30. I mean, we see these in lymphomas and leukemias all the time. However, in this case, it's a very genetic heavy disease. So maybe something along those lines.
Yeah, thank you so much for this outstanding presentation. That was wonderful. Thank you.
Thank you.
Thank you once again, doctors, for joining. Now we will be moving on to the code for our last presenter. We would like to remind everyone once again to please scan the code and to vote for your most preferred presenter. And for the judges as well, to fill in the form that was provided to you previously. So your votes will help determine the awards that we will be announcing just before the closing ceremony in just a few minutes. So this concludes all our oral and poster presentation, and I would like to send out a heartfelt thank you to all our presenters for the past 2 days for their hard work. And as for our judges, thank you so much for the excellent questions, insights, and professional suggestions. But before we go to the ceremony, we do have an invitation from the judges to send out their reflection for these past 2 days. So I would want to welcome Dr. Adarsh Keshari. Thank you for joining us tonight.
Thank you, Nathan. So it was a pleasure to serve as a judge for the poster presentation at IJMS. Thank you for the wonderful opportunity. It was a privilege and a really enriching experience and an interesting experience to evaluate the outstanding work presented by the participants doing interesting research projects throughout the world, not only in India or Asia specific, but throughout the country, and also to connect with a lot many judges and to a lot many interesting individuals like you as well. So I sincerely appreciate the opportunity to contribute to this academic event and commend the organizing team for conducting such a well organized and engaging program. Everything was well planned, thoughtful, interacting and witnessing with the presenters, and discussing alongside their enthusiasm, innovation, and scientific rigor was really inspiring and provided a great opportunity. So, thank you once again for your trust and for the opportunity. Look forward to continuous contributions to future editions of IGMS and wish the organizing team continued success. Looking forward to the results as well. Thank you so much, Nathan. It was wonderful interacting with IGMS and looking forward to future interactions and future editions of IGMS for the same. Thank you so much.
Thank you once again, Dr. Adarsh, for giving the reflection speech from the judges. Now we will, as mentioned earlier, we do have highlighted studies from artificial intelligence, clinical medicine, surgery, public health, medical education, and more other topics there. And we have medical students from all around the globe. All right, welcome back to after a short break, and it's the moment that we've all been waiting for, the announcement of our awards. Now, on our awards, we'll be doing that one at a time. And I would want to thank all of our presenters, our judges, once more before I say the first award. So first, we will have our first award, which is basically a best research presentation, original research. And for the third place, we have curbing the crippling challenge of osteodental fluorosis, role of domestic defloration method. Second, that will be the effect of the post-conflict educational disruption on patient safety competence. We have a special mention, assessment of psychological distress in cancer patient and its association with quality of life. And our first place, we have sleep disorders and restless leg syndrome among patients on maintenance hemodialysis in Pakistan. Congratulations. The next list is on the best case report presentation. Second place, we have pulmonary artery pseudoaneurysm following necrotizing pneumonia after autologous stem cell transplantation. First, an unusual case report on Kuhn's syndrome following cystoscopy. Congratulations. The next list of awards, we have the highest score during abstract revision, original research. Third place, we have sleep disorders and restless leg syndrome among patients on maintenance hemodialysis in Pakistan. Second, we have AI-assisted learning and in critical thinking. And first place, we have early post-marketing safety signals of anifrolumab in odor vigilance. Congratulations. Next list is the highest score during abstract revision, case report. Second place, we have idiopathic warm autoimmune hemolytic anemia in 5-month-old infant. Second special mention, we do have Pauci-Immune focal crescentic and necrotizing glomerulonephritis superimposed on diabetics necroglycosis. And first place, we have when CPR fails, the open ring sign as a diagnostic anchor in possible HIV-associated PML. Congratulations. Next, we have Basic Science Bench Research Project Award. For first place, we have enhancing science communication skills among medical trainees through an interactive online workshop in Sudan. And we do also have another list. Another special mention on this actually was the Basic Science Bench Research Project Award is the value of pleural fluid and terminal pro-brain natriuretic peptide levels in patients with cardiovascular disease. All right, the next list would be the most liked in the public. Third place, we have curbing the crippling challenge of osteodental fluorosis. Second place, we have residual inflammatory risk in atherosclerotic cardiovascular disease. And on the first place, we do have comparative efficacy of vibration, ice, and topical anesthesia for reducing botulinum toxin injection pain. Congratulations! And we do have one more award, which is the most watched of day one, and that will be on the barriers to medical research participation among undergraduate medical students in Ethiopia, a cross-sectional study. Congratulations to all our winners. So I would want to take a moment to reflect on the two-day conference we have witnessed, a rich, colorful posters, presentation, all representing scientific research from every corner of the globe. What we saw from these 2 days is a testament of global vision and a passion of early career researchers. We are joined by medical students across Africa, Asia, up to Latin America, and the Caribbean, each showing their dedication, creativity, and passion for contributing to medical research and promoting clinical healthcare. Medical students engaging in research is not a local phenomenon, but a global movement. We saw advantage in mental health, oncology, public health, traditional medicine, and of course, AI integration. Study design varied from systematic reviews and meta-analysis, prospective, retrospective cohorts, randomized controlled trials, public health intervention, and rare case reports. Many of these topics represented or mirrored the world's most urgent healthcare challenges, and it is inspiring to see medical students leading these conversations. To all our presenters, thank you for bringing your great ideas and your initiative to share them here on this platform. Your work brings in another step into medical student research, and it reminds us how this conference exists. I'm pleased to announce that our presentation videos will remain available on YouTube, and we will soon upload timestamp for each talk so that you can easily share your individual representation with your mentors, programs, and collaborators. Moving forward, the World Conference of Medical Student Research continues to grow and evolve. Before we conclude, I would want to express my sincere gratitude to the people who made this conference possible. To our director of the conference, Moses Stefanos, thank you so much for your leadership and vision managing our team within the background. To the logistics and the people working on the backstage, Dr. Camilo Agamas and Moses Stefanov, who have always helped us with the streaming platform. To the hard work of screening and management of the abstract, we have Dr. Kalev Karatni, Shahil Aryal, Sayali Kulkarni, Udal Chioma, and Sohil Aryal. If you're on the backstage, please feel free to join me on stage as well. Hello, everyone. We would want to thank you once again for your hard work and time for our abstract managers. Thank you. And to Sayali Karni and yours truly, our masters of ceremony, who have guided us mostly through every session of this conference. Thank you for all your hard work. And last but not the least, our editor-in-chief, Dr. Francisco Bonilla Escobar. He is the reason and why we are able to do this conference every year. Thank you so much for his dedication and time. Finally, thanks to all our judges, all our friends, and all our presenters, and the extraordinary panels of experts that we had this year. Your time and excellence has been very, very wonderful, and it have lifted up the medical student research to a higher standard. Thank you very much. On behalf of the entire International Journal of Medical Students, thank you for being part of the 2026 IJMS World Conference of Medical Student Research. We hope this conference inspire you to continue your scientific journey wherever they may lead you. We look forward to seeing you again next year. Thank you so much. And that will be officially the end of our conference. See you next year. Bye.